No, it'll be there. It'll be there. Yeah. Well, that's good. I mean, put it up there as well. That's I have seen some better. Yes, that's very true. No, it's it'll be worth doing. Yeah, it could be a good addition for this technology. So Rick. I'll be out there. That's fine. Lovely. Righto, good morning, everybody. Good morning and welcome to Prosperity Institute. The doors are shut. We are live online, on X, on YouTube, on other social media platforms as well. Welcome back to Prosperity Institute for those who are regular attendees. But I see so many new faces today, which is great because we're doing a little bit of a specialist conference. So welcome to Prosperity Institute for the first time, if you are indeed a debutant at our events, and I hope to see you at other events in the future. My name is Fred de Fossard. I am Director of Strategy at Prosperity Institute, and it is a delight to continue what is a new project for Prosperity Institute. Those of you who might know our work will have seen stuff that we've published on economic policy, constitutional reform, energy policy, Equality Act, immigration, all those kind of meaty red meat right-wing things. But last year, the former managing director and I were thinking the right-wing ecosystem in Britain is just not talking about healthcare reform at all. And that's true of public services as well. So we thought something has to be done about that. So we need to start setting up a research program, opinion research, conferences, events to really dig into what is the future of healthcare in Britain and how organizations like Prosperity Institute can play a role. So this conference is the latest step in that project. I'm delighted to welcome you all here today. We are running multiple panel sessions and talks throughout the day. We'll hear from clinicians practicing in the health service, entrepreneurs who are working with the health service to try and provide new forms of innovation from the private sector, opinion pollsters with really deep insight into what the public actually thinks, politicians who are wrestling with how NHS reform is allegedly the third rail of British politics, but also the thing that soaks up almost all our taxpayers' money. So something must be done. We are really, really happy to continue this work. We will be publishing a series of policy papers. Our editorial and research director, Reese, will have sent round a policy pack for you to chew on before you arrived. That should give you a rough idea of the kind of direction of travel we want to go in. But this is, as I said before, the beginning of quite a long project. Many, many ideas are needed, many ideas from the people in this room and people in your networks. We'll be always grateful to speak to you throughout the course of the day, at the drinks do at the end, for your ideas. So before we get into the meat of the proper sessions, we are going to start with a film on screen produced by Dr. Nick White and a documentary maker called Tim Samuels, which sets out the problem and the general direction of this work. Thank you very much.
One of the biggest challenges facing Britain is the future of healthcare and whether the NHS can deliver the outcomes our country needs. As a doctor with 25 years experience on the NHS front line and a former medical director, I believe we must start with an honest diagnosis. Without that, there's no hope of an effective cure. The warning signs are clear. Public satisfaction with the NHS is at the lowest level ever recorded, just 26%. Only 20% amongst under 35s For those people using A&E, just 22%. More than half of people expect things to get worse over the next 5 years, and only 16% think things will get better. The government itself admitted on day one that the NHS is broken. They're right. Simply spending more money isn't fixing the problem. We're already spending $214 billion a year on the Department of Health, rising to $246 billion by 2028. On current trends, healthcare will consume nearly 15% of our entire economy in a few decades' time. This is clearly unsustainable. Despite spending a similar share of GDP to other developed nations, our outcomes lag behind. Life expectancy has stalled, and healthy life expectancy is going backwards. Every extra year lived in poor health carries heavy costs for taxpayers, businesses, and families. It risks becoming an economic drag on Britain's future prosperity. Real reform needs to work at 3 levels. First, we must improve the health of the nation as a whole. Health doesn't start in hospitals, it ends there. It begins in families, communities, and the daily choices that people make. The Harvard study on human health and happiness, running since 1938, shows that strong relationships and stable families are the biggest predictors of long, healthy lives. The evidence is clear. Finishing education, getting a job, marrying, having children are strongly linked to better health outcomes. Every government policy on tax, housing, and education should be judged on whether it supports these foundations through incentives, personal responsibility, and opportunity, rather than bureaucracy. This is why we should make healthy life expectancy the single most important metric in British healthcare, not waiting lists or total life expectancy, but how many years people actually live in good health. Second, we need to reform the wider healthcare system beyond the current NHS model. Universal coverage remains essential, but it does not have to mean state-only delivery. Almost every successful healthcare system combines universal coverage with a genuine mixed model of provision. We should reintroduce tax relief and private medical insurance for individuals as well as for companies. This is not privatisation, it is common sense. It would bring billions of pounds of private capital into building the extra clinics, theatres and scanners the NHS needs. Polling shows that nearly 70% of people across all political parties would use private care if they could afford it. We should also encourage more competition among insurers, including new mutuals and benevolent funds, and support small doctor-owned clinics and hospitals. In Japan, where clinicians own and run much of the system, ownership drives better decisions and accountability. Third, the NHS itself must be run more effectively with stronger incentives and accountability. We need performance-related pay for senior leaders and frontline clinicians. Local pay bargaining so individual hospitals can reward staff appropriately for local conditions and hard-to-fill roles. Much better use of data so doctors and patients have the information they need to make genuine choices, because real choice drives improvement. Successful organisations should be able to grow, while failing ones should change or shrink, just as they do in every other sector. Countries like Switzerland, Australia, and Japan show it is possible to deliver universal coverage with real choice, financial sustainability, and some of the best healthy life expectancy anywhere in the world. If we're serious about the future of the NHS and our national prosperity, we can no longer shy away from these bold sorts of reforms.
Righto. So that gives you a flavour of the things that we have been working on that we want to discuss with you all today. I'm here to give a little bit more of the political context and try and answer the question, why are we doing this? You will all know that the 2012 health reforms cast a very long shadow over politics of the NHS in this country. What could have been a moment of great radicalism and great excitement, was politically bungled, and the Conservative Party and every organisation kind of associated with it was scared of touching healthcare reform basically ever since. Think tankers, organisations who believed in the principles of healthcare reform realised, no, this is just not worth the bother. The political class will not do it, and they'll be too terrified of any change. So after the 2012 reforms, we have the 2015 five-year forward view, which I think was probably best described as the Conservative Party's way of telling the public not to panic. We won't destroy the NHS. Please vote for us. Don't vote for Ed Miliband. And that seemed to just about work. And but really a sort of relatively unhappy consensus just continued. And then, of course, the pandemic, which I think is probably the necessary jumping off point for this work. Because in a context when we design our entire lockdown policy around the needs to protect the health service, which I don't think in turn did a particularly good job of protecting the British people, or at least that's what our opinion polling shows when it comes to public disillusionment. The time has come to actually look a little bit more radically and from first principles about where we need to go next. The funny thing is I think the public are always much further ahead of the conversation than the political class. The political class are still tinkering at the edges with a few ideas of maybe we change some data regulation here, improve some processes between primary to secondary to social care there, and everything will be okay. And of course, we run our entire fiscal policy around raising taxes to pay salaries to people in the health service to stop them going on strike, and therefore hoping that the entire country doesn't fall apart. I'm sure you agree it is becoming a little bit of a racket at this point, and taxpayers are wondering why their tax bills get higher and higher, and the services they're looking for from the health service, but also public services more widely, do not seem to improve. So our hunch is that the NHS is slightly less of a third rail politically than it used to be. It is still, of course, an incredibly important and sensitive political issue. It is always rated as one of the top 3 most important issues when it comes to the British public, and we will hear properly in depth from Scarlett about that in just a minute. But of course, it only really is a top 3 continuous issue because we have a fiscal and political settlement which places it at such a high level of political priority. I would love to know how many elections are won or lost in other Western countries over a single payer healthcare system. I have a feeling Britain might be quite unique in that situation. Though, of course, other countries do have NHS-style models, Canada being quite a famous one. And the politics of the healthcare in Canada versus America are similar in many respects as well. Americans like to claim that Canadians flee to the United States because the waiting lists in Canada are so long, whereas the Canadians like to claim that Americans are all going bankrupt because they can't afford their healthcare, and so they move to Canada for universal healthcare. So it is funny seeing this exact debate played out in another side of the world. But back to Britain. Prosperity Institute, obviously, the clue is in the name. We are devoted to policy work which improves the prosperity and health of the nation. As Nick White said in his introductory video, the health of the nation is not simply about the condition of our hospitals and condition of our GP surgeries. It is a much more holistic thing. We do think it relates to wider economic policy and wider social policy. And I think these things are also interconnected, particularly when it comes to the amount of money we spend on public services in Britain. So the policy proposals that Nick mentioned, we will go through in much more detail, but I hope that gives you a flavour of the direction of travel we are going in. We think that it's a little bit of a balance when you're approaching this work as a think tank. How radical should you be? How pragmatic should you be? We all know that the closer to reality and closer to the detail politicians get when it comes to things like public services reform, their risk appetite does decline. But think tanks also are meant to be the people providing blue sky thinking, the really radical ideas, flying the most wild kite and hoping others will follow. But I also think that at Prosperity Institute, we need to take a slightly different approach. We have seen many ministers with great ideas approach government and blow up on impact, not necessarily because of their own fault, but I think it's often a lack of planning, a lack of thinking through the second and third order effects, a refusal to properly assess trade-offs. So I like to think that the policy work that we're going to be doing in this area will help politicians and will help people in this room and the wider political class think and address the trade-offs and also make a proper plan for action. So I would love to pass on to founder of Merlin Strategy, Scarlett Maguire. We've collaborated with Merlin since late last year on this. We kicked this project off with a massive opinion survey, which we published in February, called The Health of the NHS, I think it was, really examining thousands of voters' views on the state of the health service. So Scarlett, without further ado, please take it away. Tell us what the public thinks.
Thank you, Fred, and it's been brilliant to work with you and your team on this issue, partly because I have felt for a long time that detailed public opinion research on the NHS has been very much neglected as an area, and I think Fred is absolutely right. It is one of those areas where the public, if not yet, ahead is a good way of putting it, but they are trying to come to their conclusions in the absence of any political debate on the issue, which is a fascinating position to be in, because it really does mean that they are basing their opinions, which you will see here, out of their day-to-day experiences of them, their loved ones, people they know, using the health service and then trying to piece together what's going on, again, because it's not really being addressed, I think, by people in positions in politics, or at least not in a sort of very widespread way, given what an important issue it is to voters. So we'll sort of start off, as Fred said, this was a huge survey across the United Kingdom, and we found some very interesting things. So first of all, this idea that the NHS is broken, as we saw in Nick's video, that indeed the Labour government said before they came into power, the public broadly agree. So you can see there all those red bars. The NHS is in decline and looks to be getting worse. Now, Labour voters are the only ones that disagreed with this at this stage. That is in part because their people are in charge, but it's also actually, just as a slight aside, we're now seeing that Labour voters generally are a lot more optimistic about everything. It's partly just because of the changing demographic nature of those voters. But if you look here, so obviously Reform voters are by far the most dissatisfied, but Green voters as well, actually, say that NHS is in decline and looks to be getting worse. And actually only quite a small minority of these individual groups who think that it is going to be on the right track when you look at it from voter breakdown. But even that split at the top, you would not have really seen that a few years ago. And I think this is what we want to draw attention to. So this research came off the back of quite a lot of focus groups that I've been doing on the issue, where it kept coming up. And I found that the attitude towards the public was changing. So previously, you would get the public bemoaning the fact that the politicians just wanted to underfund the NHS. That was always their response, saying that the NHS needs more money. Whatever happens, we must put more money into the NHS, and then it will be okay. The public have changed their mind now. So yes, on the surface, when you ask, you can see that people say the biggest challenge is a lack of funding. But you will also see there's some other things here as well. So I think the high levels of immigration is an interesting factor. We've got some more slides on there. Aging population and demographic changes, and not enough doctors and nurses. And again, it's actually quite interesting because the public have quite specific views on the sorts of doctors and nurses they would like to see. When you look at this one, I think this was mentioned in Nick's video, and it is really interesting. So again, this has changed over time. So this survey was a one-off, but you can see from previous similar studies that you did not used to find these sorts of answers. And again, when I think about focus groups, so here you can see 7 in 10 would say they would use private healthcare if they could afford it over the NHS. And again, I think this is where the public's readiness to rethink some of the NHS. There's still, as Fred said, it's still a very sensitive area for sure, especially when you start talking about reforming it in any way, let alone if you start using words like prioritisation, which they very much do not like. But what you see in focus groups now is an old woman saying, I've just saved £10,000 that I can't really afford to get a hip operation privately because I cannot deal with the waiting list. And you're seeing this pop up increasingly across voters, across demographics, across political spectrums. And there's this sense that more and more people are starting to think, whatever happens, I'm going to try and make myself less reliant on the NHS. Not more. And again, you can see the split is actually fairly non-partisan. So you have even 7 in 10 current Labour voters say they feel that way, 6 in 10 Green voters, and then similar, Reform voters and Conservative voters higher. This is also very interesting. So we can see that health practitioners are still very trusted in this country. Again, this is not a longitudinal survey, but what you can see, some patterns and some others, is that it seems to be that since COVID, actually trust in doctors and surgeons and nurses has actually slightly declined anyway, in GPs. But I think that's part of a wider question. But the NHS generally, that performs highly. But what I'm quite interested in is actually the trust in things like private healthcare companies and the fact that they rank higher than, I mean, politicians comes bottom of every chart wherever you put it in when it comes to trust, but above politicians, directors of NHS trusts. And so we are in this situation where the public are saying they would like to consider private care. They actually do trust other modes of delivery for private care, but they're still sort of feeling quite conflicted and are very worried about some of what they perceive to be the scary scenarios as if private care takes over entirely, which again we will come on to. And so here we go. This is another question that we asked. And so it's saying, throughout the duration of my lifetime, I think I will cost more to the NHS than I paid into the NHS through tax. Now, some people might be interested in the age split here. It's slightly counterintuitive, actually, because I think when a lot of us look at it and we look at 18 to 24-year-olds, we think that 18 to 24-year-olds and younger generations will instinctively know that in all likelihood they will probably end up paying more than they will be getting back, just because of the sort of crisis we're in with public services, with what they will end up receiving from the state relative to previous generations. They don't really see it like that, actually. They're a bit more optimistic. And I think this is quite an interesting way of stepping outside of the sort of Westminster bubble. But you see there's actually, I think this is another way of looking at dissatisfaction. So if you're in a situation where from, above the age of 35, you've got a majority of people saying, not basically, I think it's a way of saying they're not happy with the current service and they do not have trust in it for their longer lifetime. So they're saying that throughout the duration of my lifetime, I think I will pay more into the NHS through tax than I cost the NHS. And so this is the idea that it's imbalanced against their favour, and the money that they are putting in via the government, they're actually not getting the value from that they would like to see. So this is quite interesting. Where do you think the UK ranks in terms of government healthcare spending per person compared to similar countries? This is again a little bit where the sort of we found this in the research. The UK is actually very poor when it comes to this is not unusual for this country. It's very common across all countries, actually. They don't have much of an understanding of how other countries do things, and so I think this sort of highlights that when people think about how much the UK ranks in terms of government healthcare, they think that we're spending way less than other countries, and that's the same across all of these different political groups. And again, I think actually that's their views of the outcomes necessarily more than how much is being put in, because I think they find it very hard. Again, I've done focus groups where you show them, a bit like Nick was saying in that video, levels of spending relative to outcomes for other countries, and their jaw hits the floor. They are very shocked to see that we're not getting the same money back that other countries are. So I think that's a sort of status of that. This is quite interesting. So we've seen that, in fact, one of the most effective sort of political messaging lines in favour of immigration over the recent years, and I think we still see some people use it effectively, is this idea that we need a lot of immigration because otherwise services like our health service, and in fact, in particular, our health service would fall apart. There's been quite an interesting shift in change in public opinion. Now, this is partly because the public have hardened their views towards immigration quite considerably just across the board. But this is interesting. So overall, immigration is a bigger benefit to the NHS than a burden. But you can see that actually by 2-to-1, more than a 2-to-1 ratio, the public believe that immigration is a bigger burden on the NHS than it is a benefit. And we are seeing this actually in views across public services. Now, this does actually not lead to necessarily easy solutions, because there's large chunks of the public now that think if you just removed that part of the equation as in a strain on public service, then everything would fix itself. And they think the only problem is that there are too many people trying to use something that would otherwise work incredibly well. We can debate whether that is the case, but I think it means that they're potentially negating other trade-offs when they think about it. But nonetheless, I think this was one of the things that at the time we found most impactful, and we found, surprised a lot of the people we were showing the results to back in February. So here you can see the NHS should prioritise hiring British doctors over foreign workers. Now, I know Fred has done quite a lot of work on this already, but again, overwhelmingly popular with all voter groups. And I think, again, the public don't really know of some of the reforms that have come in that means that British doctors are not prioritised over foreign workers. But one thing that we picked up in the groups as well that I was doing was that sort of increasing hesitation about the standard of care from some of the foreign health practitioners that they'd encountered in recent years. And so here you can see that concern. So the standard of care by foreign workers is not the same level as British workers, and you can see that only Green voters disagree with that. So you can see that otherwise, Reform, Conservative, Labour, Lib Dem voters all think that the standard of care is not as good, or at least that's what they've been seeing over recent time. And then, so all of this, the sort of current dissatisfaction with the NHS, the sorts of things the public think are not working for them, might be going wrong. I mean, it's very much on my mind at the moment, but we had some shocking findings on faith and maternity services, which are maybe not so shocking, given some of the reports that services over the past few years, but deeply sobering stuff. But when you come to the question of reforming the NHS, I think this is where it's clear that the public are operating in a vacuum of discussion. You know, they have no idea what the different options are, what the potential, how other countries do it. And they basically still, the only two options in their mind are America, which they think of as sort of scary, ghastly. People can go bankrupt if they need any sort of operation. Lots of people dying far before they should, versus England, healthcare for all. And we found that once we started probing that, we got some quite interesting results. Once we started giving them a bit more information. So even though that first slide I showed that people thought the biggest problem with the NHS, or one of the things that was most wrong, was a lack of funding, here, when we actually put side by side, do you want to increase funding for the NHS or reform the NHS? It was reform the NHS that won out. Again, across most focus groups, you see 6 in 10 say the NHS needs fundamental reform. And again, that reflects the point that the public no longer think that more money will fix it. And you quite often hear them describe it as a black hole. We've given it more money, it's not getting any better. I don't have faith that, just more money will fix it. And again, they tend to blame that on managers and bureaucrats more, politicians, because they always get the blame, but like managers and bureaucrats within the NHS more than they do some of the things that's fundamentally wrong with the model. But they still think it needs large scale reform. And if we just keep putting money into it, we're not going to get the results that we want. And so then when we look at the areas they would like to keep the same, so again, this idea that the NHS is universal and universally accessible is incredibly important. So keeping the NHS free at the point of use is still very much a sort of shibboleth with the public. And then they would also like to see hiring more doctors and less managerial staff. You can see there that amend the NHS model entirely does come last. And again, I think that's partly because they have no idea what those different options are still at this point. And again, so this is interesting. I mean, I would take it with a pinch of salt, because we did give them some information, but they don't really know what a lot of these healthcare systems are. So they wouldn't know, for example, that Canada had a system that was much more sort of close to ours than Switzerland. They don't have that sort of understanding. But you can still see there that America is the sort of bogeyman that looms very large over any conversation with the NHS. I think that's partly because it's where a lot of politicians always go to when they're trying to criticise people that look like they might be trying to suggest different ideas to the NHS. They say, no, you don't want to be like scary America, but that is really, really sunk in with the public. And you get a certain amount of way with them, especially in groups. And then if they hear words like privatisation or think that's what's coming around the corner, they completely change, and they sort of go back to saying, no, actually, we mustn't touch it. That's all completely fine. When thinking about reforming the NHS, what should be the number one priority? So this is actually quite similar to the last slide, but again, you'll see the increasing number of doctors and nurses in our healthcare system. So again, the public are confused by the fact that we seem to be spending more money on it than ever. They feel like they're paying more taxes than ever. But then when they turn up, there's not enough doctors and nurses, and they don't understand that mismatch. They don't understand what's going on. And again, no one's really talking to them about that, the gap there that they feel instinctively every day. And then, so that is a roundup of the polling. I will hand back, but happy to answer any questions that anyone has after, or to send any of the full report and polling through as well. Brilliant. Thank you.
Thank you so much, Scarlett. It is fascinating. The overlap between Reform and Green voters is one of the most interesting finds there. I really want someone to dig into that. My name is Rhys Laverty. I'm the Editorial and Research Director here at the Prosperity Institute. Dr. Nick White, who we saw in the video at the start, he has been our policy lead on our healthcare project. Sadly and deeply ironically, he is unwell and so isn't with us today. Which is a great shame, because for months I've been planning a Simpsons gag to welcome him to the stage with, "Hi, Dr. Nick," but that will now sadly not come to fruition. So Nick was going to be doing this part of this session, taking us through the policy platform that we have been developing, but it falls to me in his stead to go through it. I have been working with him on it over the last several months, along with Emmanuel Igwe, our in-house economist. So I'm fairly well briefed on it, but there will be lots of NHS and healthcare experts in here, more well briefed on all the acronyms and structures and labyrinthine ways of the healthcare service that I may not be able to answer in exhaustive detail, but one of the reasons we want you here today is to have further conversations and feedback on these policies afterwards. So I would love to put you in touch with Dr. Nick after this, and we want to have some good follow-up to this conference. So further discussion available later on. Nick himself is an experienced cancer surgeon, former NHS and private sector medical director, was at the front lines of running some very big operations during COVID, so has seen a lot of this stuff up front at the coalface, to use a very cliched expression. Well, in view of the politics that Fred's given us and the polling that Scarlett's taken us through, we wanted to develop policy. A year ago, Emmanuel teamed up with Nick. They met at a conference and we discovered a real affinity in his outlook and the kinds of reforms he was thinking of, and our approach to things here at the Prosperity Institute. These reforms are nothing architectonic. I'm sure there are people in this room who would love to rip everything up and start again, and I wish you the very best of luck in doing that. But that's not what the platform that we've put together does. But we do want to go further than the mere tinkering that Fred has touched on. And we want bold, targeted, strategic reforms which do not privatise our national healthcare system, but certainly would have the net effect of exposing it to some market forces, which would be to the good of the National Health Service itself through competition, further resources it can draw on in the private sector, and would also improve the private sector itself. I will take you through our policies now. This is not a fully costed manifesto. These are ideas that we want to workshop and develop over the course of the next year, and we will publish them in more detail than was in the policy pack most of you should have received, and that was an initial outline and sketch, and we will flesh these out in more detail over the course of the next year. This is our policy platform. The three principles that have underpinned our thinking here are accountability. We want the NHS to be held to account on efficiency with taxpayer money and on the metrics that really matter, rather than stats that are easier to manipulate or targets that look convincing but mask underlying problems. And we want the NHS to be really accountable on what it achieves or doesn't achieve. We want incentives to govern this. Private and public sector healthcare staff, they need meaningful incentives to drive the change that we need. And we want choice. We want barriers and distortions to be removed that will allow the public to make the choices that they want in healthcare. Even 60%, 70% of Green voters, as we've discovered. And this has led into three themes that govern our policy platform. One is the health of the nation. We want to measure and improve public health more effectively with a focus on the meaningful metrics and the biggest determinants. That will be our first panel after this, which I'll be chairing. The second theme is reforming healthcare. Largely, this is freeing up private providers to provide choice, improved outcomes, whilst improving the NHS itself. And then more directly, improved NHS management, accountability, and meaningful incentives for frontline staff. These are our three themes. And so I'll take you on a whistle-stop tour through the policies themselves that fall into these areas. First of all, the health of the nation. Our first policy proposal is to make enabling most people to finished, spelling error, you wouldn't know I was the editorial director here, to finish education, gain employment, get married and raise children, make this a core mission across the whole of government. This is sometimes called the success sequence for success in life. This sequence is hugely determinative. In this graphic that was included in our policy pack, you see the determinants of health over the course of a lifetime. Obvious things, health behaviors, clinical care. 40%, however, socioeconomic factors. This is backed up with things like the Harvard study of adult development, which Nick mentioned in the initial video, and numerous other findings as well. And it's these broader determinants that we think public health should really address to enable people to prosper. We will talk about this a bit in our first panel. Public health can sort of send shivers down the spine of conservative-minded people. It immediately makes you think of nanny state, sugar tax, and these sort of piffling, tinkering, often reactive policies. But we think that a wider system which enables people to prosper will be to the benefit of the health of the nation. This is probably deliberately our most vaguely drawn policy proposal because everything feeds into this: school choice, job creation, tax reform, cheap energy, reduced immigration, revised PSHE education, public health campaigns. Many things will need to feature in a gestalt shift for how we see the determinants of healthcare. It's easy to see why the success sequence is somewhat politically charged. It might portray a certain set of what is valuable in life, but yet, despite however conservative or right-coded it might be, we know objectively that it feeds into objective good outcomes for the health of the nation. So we would like to see that as a shift across the whole of government in how we think about health and prosperity. Following on from that, we want to replace life expectancy with healthy life expectancy as the key performance indicator for healthcare. Life expectancy has stalled currently in the UK to pre-COVID levels. Now you must have some sympathy with constantly making life expectancy a target. Man has 70 years, 80 years if he has the strength. You're going to tap out at some point on life expectancy, of course. But healthy life expectancy has dropped in the UK over the course of the Tory government and into today. See, 2011, the healthy life expectancy, this is the number of years lived in good health. For men, 62.7 years, 80% of their life. For women, 63.7 years, 78% of their lives. In 2024, we'd basically lost two or more years of healthy life expectancy. That is proof that the NHS is not delivering the outcomes that it really should. And this doesn't govern our targets and the things that we measure and the things we seek to achieve. But healthy life expectancy provide a singular, meaningful aspiration that aligns with everyday priorities. If you ask people, would you like to live forever and be incredibly ill the whole time? They will say no. Would you like to live a somewhat shorter life and be in good health up until you kind of pop your clogs in the middle of the night? Yes, that's basically what most people want. And it would also have net benefits of increased productivity. People would have longer working lives, which apparently I'm going to need, given the wider state of the welfare and pension system. And it will reduce the burden on the state if people are healthier for longer. Third in this, double up my slides. Third in this, we want to focus on tertiary prevention as the correct interpretation of the shift from hospital to communities. As many of you will know, this Labour government has three big shifts that govern its approach to healthcare. One of those is shifting from hospital to community. Primary prevention, I'm aware teaching some of you will be grandma being taught to suck eggs, but for those of us who are not healthcare familiar, primary prevention is stopping disease onset, secondary prevention, screening and immunisation, and tertiary prevention is preventing the progression of already diagnosed diseases. In the way they've gone about the shift from hospital to community, Labour have largely emphasised primary and secondary still in our assessment, but we think that there should be much greater focus on tertiary prevention. Again, we cannot prevent people from developing these long-term health conditions, but we can do a lot, we think, to prevent them from progressing. So a couple of performance indicators that we suggest for that is to reduce the portion of patients with 2 or more known comorbidities experiencing 2 or more unplanned hospital admissions in a given year. Try and get that down to 1 or more. And prevent under 40s with long-term conditions from progressing to moderate or severe stages. We think that would be a very strategic thing to aim for. And last in the health of the nation section, make better use of digital and data. Of course, digital and data is often the great silver bullet, the white knight riding in to save any failing system, the NHS not least of all. But often the way it is done currently in the NHS, I'm sure professionals will confirm this, leaves a lot to be desired. Particularly how it's funded. Typically, NHS digital resources come from depleted capital budgets, meaning they become a sunk cost very quickly, rather than being a revenue budget, which is part of the day-to-day running of the service. And as we move to more cloud-based subscription services and things like that, a shift in classing funding as a revenue item rather than a capital item would do a lot of good. Tweak the Treasury rules to allow that. There are other things you can do, leasing frameworks, tax incentives for digital providers, other revenue streams, and this would obviously free up capital budgets to do the things that they are meant to do. And we think this would be a decentralized thing rather than dictated from the top. Different trusts and boards allowed to decide what digital tools that they need are. We need this data in the hands of the public health officials, looking at the big picture at the top, frontline staff responding to the day-to-day flow of availability resources, and the public as well, to be given better data on how the health service is performing. That takes us to our Health of the Nation offering. Next is reforming healthcare. This largely takes us into the theme of freeing up the private sector, both for its own sake and for the wider benefit of the national system. As Nick mentioned in the opening video, we think reintroducing tax relief from private medical insurance would be a transformative, probably the perfect balance of transformative, imaginable, conceivable, but fairly radical. Those of you who are old enough to remember, we did have tax relief during the major years on private medical insurance. This was very swiftly done away with in the first new Labour budget of 1997, I believe. But currently 13% of the British population, 8.4 million people, are covered by some form of private healthcare. 2/3 of that is a company policy, a third personal, which is quite a lot. C.S. Lewis has a line somewhere about how everyone stopped going to chapel in England because one day everyone looked around and realized that no one left in chapel believed in God anymore. And the reliance on the NHS feels like it's heading for a similar thing when we will look around and realize that a significant proportion of people in any given room have some form of private healthcare coverage. And the Overton window on the sort of stigma that hangs around on private healthcare will begin quite naturally to fall away because suddenly you realize that everybody is doing it. So you have all these shy private healthcare policy holders. The insurance sector, its tax revenue currently is just over 5 billion. That comes from NI, income tax, insurance premium tax, industry-specific tax. Tax relief, we think, if you introduced it, could probably double the number of people currently holding a policy. Now, that would immediately, we estimate, cost the Exchequer 2.73 billion. But if we retained the insurance premium tax, the increased uptake of the policies, we think would reduce that to just under a 1.9 billion loss, which is not dreadful. But elsewhere, that would inject a huge amount of capital into the private sector, obviously, which would give people more choice and relieve burden on the NHS and create resources, as was mentioned, machinery, devices, theatres that the NHS can then use. So this is a policy we're very, very keen on and think could deliver some transformative benefits fairly swiftly. 2, we want to lower barriers to new entrants who want to provide medical insurance. We will hear from some insurers later on in the day. Currently, the industry has a small number of incumbents: Bupa, AXA, Aviva, Vitality, WPA, and Exeter. Largely dominate the market currently. They've been able to be successful for various reasons. We think of a variety of deregulatory measures, particularly by the Competition and Markets Authority, would release more insurers of different kinds, many different options and structures available for insurance providers around the world. And we think that breaking some of the incumbency hold and allowing more providers to move into the market would be transformative. Third, improve support for small and medium healthcare enterprises to encourage different ownership models. This is, again, a broad suite of different kinds of reforms and deregulation we can make, plenty of which are just general business deregulation that would make it easier for anybody to start a business, let alone a healthcare business. And something we would love to see across the industry is an emulation of the GP model. It's one of those bits of sort of private action that is hidden within the healthcare system that most people don't realize, even though this has been the model of GP cares, GP surgery since the beginning of the NHS, really, that obviously GP surgeries are largely owned by the clinicians. That drives accountability and efficiency and innovation. This is the case for hospitals in many other parts of the world. Japan was mentioned in our opening video. So we would love to see various kinds of relief and creative options for allowing new entrants into the market to provide these kinds of options. A little bit of slash and burn, bring all the arm's length bodies back into the DHSC. There are currently 23 ALBs reporting to the DHSC, Care Quality Commission, MHRA, General Medical Council, this excluding the NHS itself. These also have oversight of the private sector. Many of you will know they regulate what private healthcare companies can do, whether that's medicines, devices, clinical trials, provision of healthcare. We think folding these back into the DHSC would restore accountability and control, But this needs to be done in a more methodical way than has been done with NHS England. One of the first sort of times that Dr. Nick put his head above the political parapet was writing about the approach that Labour have taken to the abolition of NHS England. Of course, fans of deregulation probably threw up a cheer when we heard that NHS England was going to be done away with. We thought the bonfire of the Quangos, or sort of small home fire of the Quangos, might be on its way. But the way it's been done has been poorly thought through and has actually obscured better kinds of slash and burn that could be done elsewhere. So we think bringing the ALBs back into the DHSC would provide accountability. That would mean that people's feet are held to the fire when new entrants, innovation is being suppressed. Lastly, improving NHS management. Now, this is, of course, itself a bland and bureaucratic title for a policy suggestion. Streamlining bureaucracy, streamlining governance and reducing bureaucracy. This, again, would be very broad given the size and the shape of the NHS. But the labyrinthine structure of the NHS is well known. 215 trusts, 42, soon to be 29 ICSs, multiple layers of governance overseen by 7 regional teams who report to NHS England's 29-member board. I've never been made to make a decision with 28 other people, and I hope I never am. As I mentioned, abolition of NHS England has been rushed and poorly thought through. Not a good example of this, but there are things we think could be done fairly swiftly in this area. Extending the current approach of combining leadership teams of provider trusts within ICS boundaries would be a good place to start, and something already in motion. It could be viable to write off some current deficits, in which we are so stuck, in order to have a strict enforceable ban and consequences for deficits in the future. Review the size of management teams at the top of trusts. Often they are double that of a private company, which may well be linked to their lesser productivity when compared to private entities. Limits on very senior management, which is a particular pay band, as many of you will know, within the NHS, to prevent these top-heavy, expensive teams, which weigh things down and slow things down. Performance-related pay. Frontline staff will face very few meaningful financial or professional incentives for efficiency. Again, in contrast to GPs. GPs are forced to economize, forced to innovate, and they have skin in the game. This is not the case for many other frontline clinical staff. COVID did see frontline staff thrive when given something like that autonomy, but costs ran away in many places. So we know that the innovation can be there, but there needs to be some skin in the game for keeping costs down. So balance is needed. We think you could introduce this incrementally instead of just a blanket pay rise, which is often what happens by hook or by crook after incentive negotiations. You could do this gradually, build up to around 15%, say, of a consultant's pay over 5 years, align their personal incentives to make more money with the goals that the DHSC wants to achieve. Similarly, for trusts, you could phase into outcome-based funding, depending on performance. On a similar theme, incentivize productivity through revising fiscal policy. The 100k tax cliff is well known at this point as a blocker for the most productive members of society. And given where pay bands lands, I understand this particularly affects doctors who would love to work more for the love of the game, as well as for the financial reward. They're scoffing. I think they do. They genuinely are the kinds of people who would work their socks off because they have a vocation. But this tax cliff, restrictions on pension contributions restrict these incredibly productive members of society. So we think a way you could do this is obviously it would affect people more broadly, abolish the taper, raise the allowance, and then scrap it over the course of 3 years. IR35, which is an arrangement that doctors employed by the NHS will take on to be able to do other work elsewhere as a sort of separate entity, as a private company. These rules are complex and, again, reduce incentives. We think if you simplified or scrap that, you could put 200 to 400 million back in the pockets of these staff who use these IR35 arrangements currently. And there are other non-IR35 ways that medical staff manage to do extra work. This would be a broader form of change that would affect business tax more generally. You could cut dividend tax, abolish restrictions on pension contributions that would incentivize people to carry on doing more work. Local, not national pay bargaining. This was mentioned by Nick in the initial video. NHS pay bargains, of course, dominate the headlines whenever they come. It's really, the national pay scale is a relic of centralised NHS control. It distorts the labour market, wastes taxpayer money, and it is probably the source of so much of the industrial conflict that we have become very accustomed to. If you could go to local pay bargaining, this would empower trusts and care boards to negotiate directly with their staff, mitigate these distortions where parts of the country or certain hard to fill roles, parts of the country where it's hard to fill those roles, are not allowed to offer increased incentives to people compared to places where it's much easier to recruit for those roles. There's already precedent for this. This is the thing. So many of these things you realise there's already precedent elsewhere within the national healthcare system. The Welsh NHS offers higher consultant salary. There are signing on bonuses across all four nations, all four home nations of the United Kingdom. So really, this is probably one of the most strategic things that we could push for. One of the more controversial, nefarious, evil, American-sounding things that we could discuss is co-payments for GP appointments. GPs are obviously under severe strain with increased demand but lagging funding. Now, to prove that this is not simply a nefarious attempt to abolish the NHS being free at the point of use, just last month, the BMA annual GP conference voted strongly in favour of exploring a Plan B hybrid NHS private model similar to dentistry. Of course, you pay for your dentist, your NHS dentist if you have one, which would include means-tested subscriptions. Essentially, you pay a subscription service to your GP. We think a sort of co-payment model, pay as you need, would be more flexible and direct, and would align with existing things such as dentistry or paying for prescriptions. Of course, many people go for their free GP appointment and then say a quiet prayer to thank God for the NHS being free at the point of use as they queue up to pay for their prescription. So we think there is already workable precedent and ways to think about this. We've sketched out a potential model to begin with 5p per consultation. You could have a 40-60 revenue split between the practice and the national pool to spread the benefits of this around. You aim for 40% of people to pay, which we could align with 40% of people pay for their prescriptions. That would be a good place to start. And we see it as a potential 2 billion in the first year of revenue. If you have a £2 uplift each year, that could deliver an additional 800 million into the sector as a whole, split between the practice and the wider pool. Also, in our polling, I don't think Scarlett mentioned this, fines for did not appear appointments proved incredibly popular. People love finding people who don't turn up. So that's a winner. The Sun ran with that story when we were doing the publicity for this. And that could be implemented fairly easily via a kind of deposit payment system in advance. Doctors' surgeries have these systems built in now already for payments. So fairly easy to implement if you're particularly punitively minded. Rebuild the NHS clinical workforce through training, recruitment, and retention. This is obviously a very big policy area. We have this staffing crisis, we all know, caused by bottlenecks, high domestic attrition rates among our native graduates, a reliance on cheap foreign labour, and poor retention of experienced staff who decide it's not worth the aggro and go elsewhere. Ways to ameliorate this: increase our medical school places, end the cap for training British medical students, prioritise British graduates for these foundation and speciality posts, and increase the training for those posts in the first place. You can introduce new pathways, apprenticeships, to get more people, more mature people into these roles. And incentivising returnees is quite potentially a sort of, appearance of the Rohirrim Hell's Deep moment. If you forgive me one nerdy reference, riding to the rescue people who've been driven out of the system or driven abroad. You can offer tax breaks. Reform had an example of this in their manifesto, or pro rata student debt forgiveness based on NHS service to lure back people who've gone abroad having been trained here. I'm sure there are other creative ideas for how we can deal with the workforce problems. That takes us to the end of our policy platform. We will throw some of these into the questions and discussion later on throughout the course of the day. But I hope that at the end of this session, you've got a clear idea of where the Prosperity Institute is coming from, the political background that's left us in this NHS mess, which seems to leave absolutely nobody happy. Whoever they vote for has meant we have felt called into a field that's been otherwise vacated to throw something out there, put a flag in the ground, and see who wants to join us in developing this policy platform over the next year. So look forward to your contributions throughout the day. We are going to have a short coffee break now before coming back for our first session on the health of the nation. Thank you.
Oh yeah, that was your thing. Go ahead.
Hello, hello. Welcome back, everybody. Great to hear chatter about very specific niche bits of healthcare policy. It's exactly what we want today. You're hearing from me again. I apologise again. I did fill in for Dr. Nick earlier. This was meant to be the only time you heard from me today. You will be sick of me by 12 o'clock, but I'll be off the stage after that. Welcome if you've joined us in the break. This panel is on the health of the nation. The first theme of the policy platform that we have put together here at the Prosperity Institute. We will have opening remarks from each of our panelists, who I'll introduce in a second. Then I will chair a discussion for half an hour or so between them, and then we will go to Q&A from the floor for about 15-20 minutes at the end of the session. Well, I am pleased to be joined to my left by Simon Marcus of Update Consultancy and formerly Head of Policy at Reform UK. Will Andrews, who is the Managing Director of the Country Living Care Group and the author of the book Surgeries Not Sticking Plasters, 20 Operations to Fix the NHS Without Selling Out, Selling Short or Selling the Silver. Sibilance in all its glory. In that one. And Stephen Childs, who is Special Advisor at Palantir on healthcare, and Henry Hill, Political Editor of The Critic, formerly of Conservative home. Very pleased to be joined by you all. 2 or 3 minutes opening remarks from each of our panelists, and then we'll move into some panel discussion. Simon, would you like to kick us off?
Thank you, Rhys, and thank you for inviting me today and for Prosperity Institute for putting on this excellent conference. I'd just like to speak very broadly about the outcomes in the excellent policy document that was circulated in terms of employment, families, healthy life expectancy, and many others which are related, which I'll talk about as we go. And in a lot of the work I've done over the years, it's become clear that there is a particular cohort that drives negative outcomes in all these areas. And it's something government has known about for many years. Mostly it began in 2012 after the riots in 2011. And the conversation was about troubled families that bump along the bottom of the system, going in and out of the criminal justice system, the children going in and out of the youth justice system, multiple welfare benefits, multiple negative health outcomes, substance abuse, and so on. And that's developed over the years, and it seems it's evened out now, an estimate of around 400,000 families. Now, no one has yet estimated how many people, individuals that is. But, it's 400,000 families, 2 million children, so you're probably talking between 4 to 6 million people whose outcomes, in many cases, are known and predictable and avoidable. It costs around 40 billion a year. That's a very broad estimate. It's based on 2012 analysis, which again shows how behind successive governments have been in analysing this problem. And what I'd like to suggest is in finding solutions to this problem, reducing these outcomes, saving a lot of money and improving a lot of lives, a lot of the work has gone on upstream. The question has been, how far upstream can we go to stop this or just address the problem? And I was very pleased to see again in the PI policy document talking about self-reliance and personal responsibility. And conclusively, the research over the years have shown that these soft skills are key to avoiding these outcomes later in life that these 400,000 plus troubled families often fall prey to. So the next question is, how do you introduce these values into the system? And it's not just personal responsibility, it's a broad set of values, a work ethic, self-discipline, gratitude. That's a key value that I believe they've done a lot of work on in Birmingham University, the Centre for Character Studies. So it's the transmission and internalization of this soft skill set, a morals and values skill set that helps get people out of poverty. It's proven over the ages. It massively impacts all the outcomes we're concerned with in this talk. There's education, joblessness, welfare system, and so on. And I would suggest that thinking and understanding and how we can implement these values back into society, where not only have they no longer been transmitted from parents to children in schools and so on, they've actually been replaced with a set of counter values: grievance, victimhood, blame, and excuse. No one can succeed if they imbibe those values at an early age. And very often the system is set up to inculcate those values into young people. So I think that's what I'd like to start with and see if we can knock that idea about in the coming hour.
Thanks very much. My name's Will Andrews, doctor by background a long time ago, and spent the last 20 or so years doing things like health system turnarounds, service launches, and that kind of thing on both sides, advisory and also in-house. First of all, I thought what was presented this morning was fantastic, and I think there's a huge amount that I would agree with. I spent the last year, as Rhys was saying, writing a book on the NHS and how to fix it. Because of a lot of what Scarlett was saying, which is actually there's a lot of people out there thinking this is broken, but there's a very little debate or sort of ideas on what needs to happen next. And so I think this is a very welcome sort of day for us to sort of get our arms around that, and I'm excited to be part of it. I would just say a couple of things in opening remarks, just to sort of be the downer on the conversation and to set the scene. That's because we're facing something really quite serious. This is not just a nice to have conversation amongst intelligent people where we can maybe go and, influence something small. This is something quite urgent that we all need to focus on. The first thing is we've got a massive demographic population issue coming our way very, very quickly. 1950, when the NHS was founded, we had 50 million people in the country. 50 years later, that had grown by 10 million. 25 years after that, it had grown by another 10 million. That's today. And now in the next 10 to 12 years, we're facing another 10 million people coming into the country, and therefore that being a burden on the NHS. The reason why that is important, and there's no sort of political agenda in me talking about population growth, apart from for the health system, that's really important. For every million people, you need about 3,000 to 4,000 hospital beds. And by hospital beds, I mean the beds, the doctors, the surgeons, the GPs, the nurses, the managers, everyone else. And so Boris was actually right directionally in terms of his 40 hospitals. It's been laughed at in many quarters, but it's correct. The other thing that's happening is obviously that we're getting older. Again, inception of the NHS, 1950 or so, 10% were of retirement age. Now we're heading for 25% being of retirement age. And it's not just healthy, happy 65-year-olds who are fine. It's an entire long tail of people all the way up to into their early hundreds who are increasingly complex, increasingly expensive as a result for the nation to handle. So really, really important. The second thing is obviously we've got a few illness issues that are coming our way very, very quickly. One is obviously mental health. It's hard to get our arms around what that means. The second is obesity. Both are incredibly important because they're very complex. They spawn lots of other conditions, and they also economically disastrous for us as a nation, because it's very hard to hold down a job for a long period of time to the level we need if you're suffering from those sorts of issues on a long-term basis. And we're seeing there's not really the will to get our arms around something like obesity. I was working, for example, with a company that was launching a GLP-1 into the market a few years ago. So I went out and talked to anyone about obesity, and there was just nothing there. It was crickets and tumbleweed, no pathways, no one really focused on it. A few dejected people sitting in broom cupboards saying, gosh, this is something we probably won't be able to solve in our lifetime. So we've got a real issue we need to solve there. And then I won't go on too much longer, but essentially the third sort of juggernaut coming in our direction is the collapse of the NHS. And it's being propped up by infusions here, there, and everywhere, but it really is on its back with tubes coming out of its nose at this point. And it, our line of defense against this has become a Maginot Line, completely swamped, surrounded, and no longer useful. And then just very briefly, fourthly, we've got this impending vision of health inflation. So everything's becoming more expensive. We're a very technical industry, and we're a very people-heavy industry. And those two things together are a recipe for ballooning budgets. So for those reasons, the health of the nation, i.e. getting way ahead of the problem, is incredibly important, and look forward to the discussion.
Thank you, Reece. Good morning, everyone, and thank you for the invitation to join you today. My name's Stephen Childs, and I've spent the last 30 years of my life as a manager in the NHS. So I feel a little bit uneasy at the moment. But when I left 14 months ago, I thought it can't be any worse than that in terms of controversy, and I joined Palantir. So you're probably questioning some of my life choices. But I thought what I would do is just explain in a couple of minutes the journey I've been on over those 30 years and genuinely the reason why I moved across to Palantir, because I am not technological by instinct or by professional practice by any means. I started off in the NHS in general practice in Deptford in southeast London as a practice and business manager, and that practice soon became a fund holding practice. So there's some resonance here with what we were hearing earlier from Reece. GPs given responsibility for budgets, for commissioning, purchasing, if I'm honest, services from hospitals, from community service providers, from mental health providers. And they were given the incentive to do things differently for their patients, the incentives to look for preventative mechanisms to reduce the demand of their patients on secondary care services. I think it was probably one of the most productive periods of the NHS. It was fairly crude commissioning relative to how sophisticated that became later on. Around about 1999, that changed, and change of government, fund holding was ended, and we moved into what became a succession of commissioning bodies that were delegated that responsibility to look after the money for communities and take responsibility for improving the healthcare of those citizens. Originally, that was primary care groups. They matured into primary care trusts. I moved north, and I was the chief exec for a period of 4 NHS primary care trusts on Teesside. I also, for a period, was responsible for delivering community services across Middlesbrough and Redcar and Cleveland. The last 12 years, and this was as a result of the Lansley reforms, when clinical commissioning groups were established to again take responsibility for commissioning these services, much closer to clinicians this time. Andrew Lansley tried to alleviate those GPs from the burden of running big commissioning organisations and set up commissioning support units. Interestingly, commissioning support units, NHS bodies that had to compete with the private sector to provide these services to provider organisations as well as commissioning bodies. Probably the first time the NHS has truly exposed any element of its services to market forces. We started off with 19 commissioning support units. Market forces indeed ripped through that cohort of organisations to the extent there were only 4 left 2 years ago. They went to administration, services were taken over by the private sector, some went back into the NHS. But the really interesting thing was we were given the freedom to trade, and we were given the freedom to develop services. We were even given the freedom to export. And a large proportion of my responsibility became to provide data services and digital products to the NHS. So that brought me very, very close to the challenges we face in the NHS when it comes to data and digital. Difficulties in making sense of the data we have, difficulty in scaling adoption of best-in-class digital products. And that all came to a head during the pandemic. And at that point, I found myself working hand in glove with Palantir, who were brought in to rescue the situation. And then when I left the NHS, as I say, 14 months ago, I was approached by Palantir to ask me if I would be prepared to help them with what is, and I'll come on to it a bit later, probably the NHS's most ambitious data modernisation programme, the National Federated Data Platform. And the irony was I felt I could make a bigger difference to the NHS, which I firmly believe in, from within inside Palantir, more so than I could from within inside the NHS. Thanks, Rhys.
Henry.
Thanks. Fred asked me here to talk about the political economy of healthcare. That obviously touches an awful lot on stuff in the second panel, but actually health itself poses a significant challenge for any centre-right or right-wing government, at least as conceived on a liberal basis. Most obviously, level 1 of that is how much the NHS costs. The Tories managed to double NHS spending in real terms between 2010 and 2024, tripled it in cash terms, got absolutely no credit for it. Labour managed to run in that election against Tory cuts to the NHS. And obviously that involves raising taxes, which undermines the rest of the Conservative offer. But at a deeper level, if under our system you have a theoretically unlimited right to healthcare support, then reciprocally, the state has a legitimate interest in controlling your lifestyle choices to an unlimited degree. If you are suddenly considered as a labour unit, as a productivity unit, we hear statistics discussed about, like, well, if we banned this or we banned that, then we could maybe drive up productivity by 0.1, 0.2%, whatever, which if you were to put it on an individual basis would sound absurd, right? Like if you were to say, if your boss were to come up to you and say, well, if you forwent all of your pleasures, you could earn a bit more money for me, you'd tell them to sod off. But you turn that, you spread that over millions of people and you turn it into a statistic, and suddenly that is sensible healthcare policy. And this is something the Conservatives have always struggled with, right? Because the Conservatives always theoretically anti-nanny. So we hear the words, right? Personal responsibility, right? But personal responsibility doesn't mean anything if it is simply one way of getting you to a state-approved outcome, and if you don't do it through personal responsibility, you'll just do something else, right? But because we're never willing to simply let people actually suffer the consequences of their own choices, we're always going to step in, we're always going to provide the care, then personal responsibility is meaningless. The only way that you ever have personal responsibility in a system is if you are prepared to let people take responsibility for the consequences of their own actions. An insurance system does this. If you live an unhealthy life, if the risk of you needing healthcare goes up, the premium you pay goes up. It directly internalizes the cost of your choices. And it therefore affords you the freedom to make those choices. We do not have that in this system. And finally, and this is more of a policymaker's problem, basically the danger with collecting any sort of data is that there will always be people who can't resist using it as a call to arms, right? Like, we see this all over public policy. Healthcare, life expectancy, up or down. Is there something that is the leading cause of death in something or other? Well, we need to deal with that. But of course, as you said in your own speech, there'll always be something that's the leading cause of death until we stop dying. But nonetheless, that needs to be dealt with. The one that drives me absolutely mad is when we talk about preventable deaths. There's no such thing as a preventable death. There are postponable deaths, but there are not preventable deaths. But of course, the question is that it is treated in a lot of public health policy spaces as axiomatic that a preventable death is a thing that you should avoid through policy interventions. But actually, if it arises from your own policy choices, from your own personal lifestyle choices, I think most people here statistically are enjoyers of alcohol. You will probably live slightly less long. I mean, Chris Snowden might disagree with me on this, but I don't think he's here. You'll probably live slightly less long if you drink more than one glass of red wine a day than you would if you abstained. But that is a richer, more enjoyable life. But all of that subjective stuff is completely unquantifiable and doesn't appear in any policy assessment. And so I think that the challenge for a right-wing government, at least not an authoritarian right-wing government would actually find it fine, but at least a liberal right-wing government, is how do you design a healthcare system and sell to the electorate a healthcare system which doesn't lead to the absurdity we saw during the pandemic, where we were all informed to protect the NHS, which is a complete inversion of the relationship that the NHS should have with the British people.
Thank you very much, gentlemen. I'll stay with Henry for the first question, but to maybe pull together a couple of the things that Will and Simon said. If I were to very much simplify the state of the nation that they've painted, according to Simon, we are bad. According to Will, we are old, fat, and mad. These are not good outcomes, but the British political right, Henry, seems to have been unable to talk about the NHS in terms of outcomes. It will praise the NHS for being the NHS, as you've written about, but it has not been able to grasp the fact that our outcomes are worsening. Why is it not able to do that?
Well, essentially, you can only praise the NHS for process. Even the King's Fund, when it was trying to come up with, it was a Commonwealth Fund, the American one that was trying to come up with this big case for why the NHS was the best system in the world, and it created this amazing chart with the NHS as the top system in sort of 8 out of 10 metrics. And then there was one metric at the bottom, which was healthy outcomes, which was basically every single medical metric, and it was 10th out of 10. But on all sorts of others, it was incredible. The NHS is basically a process, right? When you talk about the NHS, it is essentially having a tax-funded monopsony buyer of health labour and monopoly provider of healthcare services. And the reason that you can't really talk about the outcomes is because, for the reasons that Scarlett outlined, the moment you start talking about the outcomes being bad, people are like, oh, what do you want to do with the NHS? And then Labour goes, they want to sell it. And of course, it's a nonsense charge, because who would buy the NHS? I mean, what is the pitch deck for a network of decaying temples with unsustainable service obligations? But nonetheless, that is the allegation. And the Tories have learned, I think, quite fairly in narrow political terms, that it's simply not worth the bother, right? Because it exposes them to enormous downside risk. The public do not trust them on the NHS. The public might, in the abstract, as Scarlett was saying, if you sit them down and you take the politics out of it, and you start leading them down the garden path of healthcare policy, do you want X, do you want Y? You can get them quite a way. But the moment they get a whiff of privatization, then America, all that whole that drawbridge slams up. And Labour will, of course, immediately trigger that in that response in the electorate. I think that the other side of it, and this one you can blame the Tories more for, is that they have just not been particularly strategic. So we've heard about how there's more people than ever claiming private healthcare, right? Now, you're never probably, in current political conditions, going to manage to do a sort of big bang year zero reform of the NHS. But you could bring back making private health insurance tax deductible, right? That was the case under Thatcher. That was the case until I think Tony Blair came in. That would incentivize more people to get private care. That would normalize private care. And if we had done that in 2010, by 2024, you'd probably have substantially more people with private health insurance, which would have an effect on public attitudes, which would redirect demand out of the NHS, which would help existing budgets to go further. But of course, we didn't do that because we were in the sort of David Cameron era of the Conservative Party, which was just like, ooh, I hope no one thinks that we're right-wingers. And so we didn't do any of that. And so that's the problem with the Conservatives. They've been afraid to touch it in a big picture way, which I think, again, given that they have to win elections, you can't really criticize them for. But they've also just been utterly unprepared to do any kind of moderately controversial, granular stuff which might have moved the dial.
And to my fellow panelists, please feel free to jump in at any point. Is that why the Tories, of all people, left us with a public health legacy that was sugar taxes, calorie labelling, tobacco taxes, packaging restrictions, a smoking ban that the Labour government then put into place, even though it was a Tory policy? That's all they can bring themselves to do.
Oh, I didn't even go into that because I'd honestly just start screaming into the void. So a couple of interesting tidbits about that. But the sugar tax and the tobacco sale restriction are really interesting insights into the actual nature of public health policy making at that end of it.
And they all poll well, these kinds of policies. They all poll well.
They poll well, but I mean in terms of the way they're made, because the way that normally these things are framed, and indeed the way I framed them a minute ago, is that, we've just got to make very hard utilitarian choices because of the. But actually, whenever the evidence doesn't really point to needing to make these choices, they just do them anyway. So the most egregious one is on Rishi Sunak's sales ban. There was a paper, sort of white paper put out by Downing Street about the impact this would have on tobacco sales. And as far as I can see, there's normally rules to public health. You can massage things, you can sort of exclude and misrepresent data a bit, but you don't just make stuff up. And the Rishi Sunak's Downing Street crossed the line by just absolutely inventing the chart that created the basis for this policy. So it predicted that without this intervention, smoking levels would taper off at rate X, can't remember it off the top of my head, and with the intervention, rate Y. There's no evidence anywhere, as far as I can see, for the first figure. It is not the figure that was been used internationally. It was not the figure in the Cancer UK report that they linked. It was also not the figure in the Khan review done by the British government, which they ignored. It was just an invented figure, and it exaggerated the impact of that policy by 800%. Now, of course, why did policies like that happen? In that case, it's because Rishi Sunak genuinely hates smoking, and he wanted a legacy, and no policy pursued by a prime minister looking for a legacy is good policy. And also, the impact of that policy is only ever going to be measured after he left office, right? Because if you actually look at it, people say, oh, they're doing the Australia policy. They're not doing the Australia policy. The Australia policy was a terrible policy, but it was sensible in that it recognized that the only way that that policy would be deliverable is if you banned the private retail of tobacco and you introduced a state monopoly on tobacco retail, which is what they were going to do in New Zealand, sorry. And they're not doing that. There were no proposal to do that. It's utterly unenforceable. The sugar tax was originally designed, purported that it would take lots of calories out of people's diets and make the nation healthier. Do you know off the top of your head the number of calories it has actually been found to take out of the nation's daily diet?
You're going to tell us?
I can, but do you want one guess? It's fun.
I have never counted my own calories. So
3.
I have no idea. 3 calories.
3 calories. So all of the paper actually suggesting that it would make a significant impact on calorie intake was retracted, and there was a report that went out in an NHS journal, and that report got no pickup. And all that really happened is that people like Nesta and the other people who advocated for this policy changed the metric they were using. And so now they said, well, it's taken sugar out of people's diets, which is obviously a slightly tautological definition. But again, if you're a Tory minister and you don't have particularly strong feelings on this, there is a very well-established chorus of people, of lobby groups, of think tanks, who will praise you to the skies if you bring this in. They will invite you to panels, they will clap, they'll put your art on their fridge. And if you don't do that, you get this drip feed of evil Tory. And you need somebody with particularly strong strength of will and belief to counteract that.
That can segue us to the things that Simon talked about in his opening remarks. So we want to, we've given the nanny states and piffling public health interventions a good kicking. Public health can often seem like particularly reactive, back of a fag packet stuff, but Simon, you've touched on the bigger values drivers, and then I think the picture that Will gave us showed us what the current kind of set of values are how they're cashing out in real terms. Nanny state intervention over here, we don't like that. But of course, if the drivers are values and how you live your life, that's can, in principle, sound like an even more controlling interventionist kind of state reach, that you should live your life this certain way, even if we have proven in development studies that the success sequence, education, job, marriage, children is good for you. Not necessarily, we wouldn't necessarily want to tell people, and therefore you must live your life that way. So how do you, when it comes to then thinking seriously about policy to shape those values, which we know will be good for the health of the nation, how do you kind of square the circle there without, we don't want the nanny state putting on sugar taxes, but do we want it telling us that we need to get married and have children?
Well, I'm keen to stay away from labels. And I think there's a litany of disastrous initiatives that speak to that. Who remembers the big society? Full of fantastic ideas and principles, it really was. But of course, it fell flat on its face because it came across as slightly condescending, otherworldly, patronizing, very sad. So I think perhaps what might inform this is the concept of regressing to the norm, going back to what actually is fundamental to human nature, or certainly has been in Western developed societies in the last few hundred years, which is some kind of coherent family community-based life, hence family community country for reform. Mm-hmm. And what's happened over the last 30 to 40 years is that's been disrupted and broken. Yes, by perverse state incentives, a broken welfare system, but also the draining of unchanging traditional values from society. And so while I certainly sympathize with what Henry said about just say to someone, be responsible, well, that's not good enough, clearly. And there does have to be a stick as well as the carrot. But there is a huge amount of low-hanging fruit here. And just by introducing these concepts, perhaps the soft skills I talked about, the set of morals and values, which everybody here is acquainted with, and broadly we can attribute any success we may be lucky enough to have to those values that we were taught when we were young. By the same token, we can probably consider that if no one explained this to us at an early age, it might have damaged our prospects in life, which therefore leads to a very simple causality. If we can introduce these ideas into schools, into the state as it stands, we can't dismantle the state overnight, children's social services, so on, mental health support in schools. And the reason why I'm actually quite confident about this is because I was lucky enough to co-found a charity about 20 years ago called the Boxing Academy, where we dealt with youth offenders, excluded students between the ages of 12 and 16. Most were involved in gangs. Most had no fathers. Most came from, obviously, housing estate, social housing, with all the disadvantages. And talk about life expectancy. Some of them didn't make it. So it was deadly serious. But what we learned is that this regression to the norm idea is incredibly powerful. All of a sudden, if you take these kids, the cohorts that cause so much damage down the line and such a burden to the state and the NHS, if you reintroduce them to these values through positive male role models, which are very rare, as we know, in the state sector, all of a sudden they have someone to look up to. And it's really hard work. For some of these kids, they earn more than their teachers, 14, 15-year-old kids in gangs. They have respect. You know, they're safer on the streets because they're part of a gang, so they have some protection. To try to say, well, actually, that's not working for you is very tough. But we did it at the Boxing Academy with a well thought through model of positive male role models. In a way, it was a de-radicalization program. You know, an alternative family, goal achievement, whether it's 10 press-ups or go down the track, is very powerful. They're doing exercise. They're seeing something they've achieved. So you're setting up a virtuous cycle of work, achievement, reward. And slowly but surely, you've got kids who haven't been to school in years, really upset because they can't come in to school. Why? They misbehaved, and you said to them, sorry, you've got to make better choices. You can't come into school for a day. And they're really upset because they missed it. They really love coming to school. This can all be done. For all the failures of the big society, it did help a huge third sector, a huge charity sector to expand. And they did such good work. And actually, for me, it's been a tragedy. A lot of what they achieved during those first 3 or 4 years has really been lost. And the debate actually has fallen silent over these troubled families, over the kids, and the people who are going to have failed lives and be such a burden on every level. So actually, there's low-hanging fruit, there's incremental change, it's the school curriculum, it's the structures, notwithstanding they need to change, it's the structures that are there, and working with what we have.
That's really helpful. And I guess the downstream of those are things like overall health, mental health, lifestyle choices, obesity, things like that.
Part of it.
Will, you sketched out the kind of coming tide on those things for us, as well as the demographic issues. You've seen this, both as a doctor, a care provider now in care homes and in consultancy work. You've written your sort of manifesto, which, similar to ours, is a suite of targeted policies. On those incoming crises, if you would call them that, what are the strategic reforms, the kind of low-hanging, we've got the low-hanging fruit a bit further upstream here from Simon, you're further downstream. What's the low-hanging fruit at that point?
Well,
if there isn't any, you can tell us. The fruit's up here.
There is. I think sometimes we miss the sort of glue in the middle. So we have great policy ideas, whether they're good or bad, and then we have people who are working very hard at the front line. And actually, the connection piece, the sort of how do you run a great organization and get stuff done piece, is often missing. And that's sort of what I was trying to sort of articulate in the book, that actually, regardless of whether you think the NHS is good, bad, or indifferent, a large amount of getting it to work is just administering it properly. And so there's, you've got to have effective, capable, passionate leaders who are laser focused on something, not on their sort of tenure or the next couple of years trying to make it through, or political shenanigans. They've got to be focused on the plan, and they've got to have capable, encouraged people around them. And I think that's what we're seeing, not just in the NHS, but in the public health sphere as well, is actually, you need those management tools. Sorry to sound boring and sort of mundane, but actually every great organization on the planet, regardless of whether you like their product or not, if they're doing well, it's because they have these disciplines at the heart of them. They know exactly what they're doing it effectively, efficiently, they've got a great service culture, they're encouraging their people, they're training their people properly, their people feel like they've got a future, they feel like their leadership are behind them. All of those things are slightly missing in our ecosystem. And I feel like they're probably missing in public health as well, to the extent that public health is sort of, a bit of a vanishing act in many ways. So I would say the strategic but slightly boring thing to do is, let's make sure that we get a public health environment which is squarely focused on achieving it. We saw this with Michael Marmot's report long time ago, 2010, when he wrote, the report that coined the term, the social determinants of health and that sort of thing. And it was an amazingly good report in terms of what he was prophesying essentially would happen to the nation if we didn't get certain things under control. And then he came up with some slightly nebulous ideas about how we would do it. So, give people, the best start in life and make sure people have gainful employment and the rest of it. And the trouble is, you give that to a bureaucratic organization and say, go and make this happen, and they freeze and they can't, they write another report on how they might make it happen in another 5 years' time. And we saw this, like if you look at some of the Marmot cities, for example, there were a few organizations that said, great, we're going to take Marmot's report and we're going to sort of do it. Coventry was one, which I looked up relatively recently. And they wrote a lovely report, which probably took them a very long time on how to do this. They then did it. I went back to the report after 10 years and nothing had happened. I mean, there were some lightly positive stories about sort of, I don't know, individual cases that have maybe changed, but it didn't have that energy behind it to say, right, we have a specific problem with obesity. We have this many people over the BMI of 40, this many over 35, this many over 30, and here's what we're going to do very specifically at each level to go and attack it, which at Microsoft you would have, or at Amazon you would have. And here we don't. We sort of let it drift, and everyone's been de-elected and moved on by the time it comes to fruition anyway. So they don't care. And I think that's the piece that's missing. I'm out of my pay grade here in terms of policy experts and exactly what to do. But certainly, once you've decided that you've got to attack it with vim and vigor and make sure it actually happens.
And part of attacking it with vim and vigor in 2026 is our use of data. Stephen, if I come to you. You've seen the NHS from the inside as a director, now looking at it from the outside at Palantir. When it comes to these things you've been discussing, there's wider determinants of health upstream that Simon's talked about, and then running the public health and care with dedication and efficiency. Does the NHS, how would you grade its current use of data in those different areas?
Well, again, if you don't mind, I'll share a bit of context about the NHS in relation to data. So you touched earlier, Reece, in your presentation on this kind of federated nature of the NHS. So we have, if you include general practices as independent units, literally thousands of independent bodies under the brand of the NHS. And for the last 78 years, they've all been busy collecting data and information. So we've got the richest longitudinal set of healthcare data of any country in the world about our people, but we don't do an awful lot with it, if I'm honest. It gets accumulated. It's very rarely connected. It's hardly ever integrated. And therefore, our ability to generate a single version of the truth about what's going on is almost impossible. We very rarely have real-time oversight of what's happening in the NHS, and it's virtually impossible to generate reliable evidence-based actionable insight. So perhaps we can begin to understand why some of the decisions that are made in management by the NHS are flawed. That was cruelly exposed during the pandemic, when you might recall in the very early days, we were panicking as to where the ventilators were relative to where the patient's need was. And it was at that point that Palantir was introduced to the NHS to try and make some sense of that. Quickly following it, the next crisis was protecting our staff, because we didn't have the personal protective equipment and clothing in the right places. And again, Palantir brought the technology in to allow us to connect that insight, or connect the data to create the insight and manage the situation far better. Jumping forward, I think the NHS then realized what it was missing. Not only was it missing a standardized model for managing its data, but as a consequence of not having it, it was incredibly difficult to adopt at scale best-in-class digital innovation. And for anyone that's tried to sell a digital product into the NHS, you will know how incredibly difficult it is to enter that market, because every hospital trust will have its own configuration of data, separate software solutions working across departments and divisions. So you have to sell it not just once into every hospital, quite often into every department. So it's a tragedy, really. Many of the digital innovations that are generated by the NHS through the NHS Clinical Entrepreneurs Programme ending up going abroad to realise their potential, and our patients miss out on that opportunity. So it's not for want of endeavour, it's not for want of intent. It's a legacy of this extraordinary institution of the NHS that's been with us for so long and has been allowed to grow and evolve almost organically. So what we're putting in place now, and I say we because it is a collective effort by the NHS and the consortium of organisations that are now establishing the federated data platform, is for the first time introducing a standardised data model. They refer to it as a canonical data model, which allows that data to be connected, to be integrated, and gives us a common platform to diffuse the best digital innovations. Turning to public health, this is so incredibly important for us to understand the needs of the population we're trying to serve, both at a big data macro level, when you look at a whole population, or regional, to understand the disease trends, how disease is spreading, where the inequality is. But very, very importantly, that data then translated through to a local level, to a street, to a house, to a family, to an individual, because we can only really start to make a dent in the poor outcomes we have by making targeted individual interventions for individual patients, which is why primary care is so important, because currently 70% of our contact with the NHS is through general practice and primary care services. So public health is not in a great place at the moment. It's quite fragmented. One of the unfortunate, I think, looking back, outcomes of those 2012 reforms was to move public health responsibility from what were then primary care trusts into local authorities. So we have quite a fragmented now setup for public health. Some of it sits in local authorities. Clearly, NHS England still retains a responsibility. We have public health responsibility in the Department of Health and Social Care. And increasingly, we're finding integrated care boards who are responsible for the majority of the spend of NHS resources are reinstating public health into their organisations. My public health colleagues, my directors of public health that I remain in contact with, actually talk about the information that's available to them being poorer today than it was 15 years ago. So we have, I think, a huge responsibility to correct that as quickly as we can, so that we are able to target the resources where they're most needed and do something that the NHS has never been terribly good at, and that is decommission what isn't working. We've never had the evidence and the confidence to turn off services and move the money from one service to another where it will generate far superior outcomes.
Very helpful and insightful. I'm keen to move to questions now, with lunch looming towards us. If I could open up the floor, do we have a roaming microphone? Francisca here has the mic, so do raise your hand if you have a question for any of our panelists or in general. Gentleman in the back corner first, and then this chap here in the middle.
Well, I don't know whether to stand or not. Is this working? Yeah. Sorry. My name's Nick James. One question about the cost of the NHS is not being mentioned. And obviously on one side, the immigration issue. On the one side, you've got immigrants who come and work in the NHS, so they contribute a great deal. You've got paired with what I call fiscally neutral ones who come, they pay their way, but they don't make a big contribution in other industries, and they pay the taxes and cover themselves. But there's a lot of people are called health tourists, and they come to Britain and they just use the system, but they don't pay any tax through national insurance, and they're a drain. And that's never mentioned in the immigration debate, or very little, and it's not being touched on today. I just wonder why it's not being touched on. And the frightening thing that was raised in this session was that we're going to raise another 10 million population in 10 years' time. Where are you going to house them? And that's other issues. But that has a massive demographic problem when you think of the riots and the problems we've had recently. I don't see how that's going to help life expectancy or anything else. I just wonder if the panel have any response to that. Thank you.
Anyone particularly inclined to jump in?
So, I mean, I can't really the health tourism. I mean, the reason no one's going to do anything about health tourism is that doing something about health tourism involves being mean. It's true. fundamentally, you would need the NHS to be equipped to say no and refuse to treat somebody who needed it. American hospitals are equipped to do that because that's their entire system. The NHS is not. And so given that, these people will be treated. And then the question is, how do you recover the money? Theoretically, you could try and come up with an arrangement for chasing the fees. Purely pinballing this off the top of my head, you could have something, you could maybe threaten visas for countries that didn't help you pursue, but it's given the cost, it's the relatively marginal cost of health tourism compared to the big structural problems with the NHS. It's not something that's at the top of most people's thinking. You mentioned the immigrants who come and work for the NHS. The interesting thing about a lot of that is that basically we have this very strange system where we constantly hike the standards that we say that we want for something, in this case, medical training. So for example, we now have nursing is now a graduate profession. It didn't used to be a graduate profession. There's lots of senior nurses who deeply dislike it being a graduate profession, but it nonetheless is one. This creates enormous costs because you now need to subsidize the medical places for 3 years in which they don't do any work. You need to employ people to do the work that trainee nurses used to do. And it creates a cap on the number that you can bring through the system. And then, of course, what you do is you then make up the shortfall by importing nurses who haven't had this insanely high British standard that you've put in the first place. And so the actual nursing coming through the system is not particularly improved, but it does mean that as a policymaker, you get to insist that you on the very highest standards and feel good about it, and then import your way through the consequences of that policy. So I think we need to be careful about suggesting too often that the immigrant workforce that comes to work for the NHS is necessarily a net positive, because actually what they're doing is they're compensating for self-indulgent training policies and requirements by the government that we could simply get rid of.
And the polling touched on dissatisfaction with care from overseas health workers, and as I believe Fred says in his intro to our polling, NHS workforce is the same percentage of immigrants as the population in general, so they're not disproportionately represented, and the public routinely overestimates it to be about half or more of the NHS workforce, which it's not.
Almost half of doctors.
Right. Almost half. Sorry, it varies across different professions.
42% of doctors now. In the last 10 years, we've imported 100,000 doctors mainly from Nigeria, Pakistan, and India, which must be damaging their health systems more than anything else. Which I think is concerning, and as you say, lazy. I mean, there's a huge amount we could be doing with our own medical run-throughs that makes it a lot less onerous. I mean, the number of people being turned away because they have 2 A stars and an A at A level rather than the full suite is ridiculous. And they're making people sit in this trainee program for best part of 20 years before they're no longer trainees. I think is a bit crazy, and we could be a lot more efficient, completely rethink medical training from that perspective.
And that would address the sort of operational efficiency of dealing with public health and these incoming crises that you've
100%.
You've highlighted.
Yeah, largely.
Gentleman in the middle here, Francisco.
Thanks for the discussion. I'm Aaron Thierer, academic surgeon. On the policy document, there's an emphasis on tertiary prevention, which is great, making sure that disease that exists doesn't get any worse. I just wondered if any or all of you have any thoughts on quaternary prevention, that is preventing overdiagnosis or overtreatment, both in organic disease, but perhaps especially in mental health conditions where we see sort of an explosion of diagnoses. And one more question, if I may, on indicators or performance indicators related to those. Is there a process you have in mind for who or how we define who has the comorbidities that count and whether or not things are preventable or not, touching on some of the points raised earlier? Thanks.
Thank you. So tertiary prevention, thoughts on that, and how we assess who has these comorbidities that would be of concern for escalating later on. Yeah, great. Will or Stephen, I suspect your clinical experience might speak to the intervention.
Well, I'll just speak to the data side of it, the evidence, which at the moment is patchy. And funnily enough, talking to a regional director of public health only a couple of weeks ago, was reaching out for help because of his suspicion that we are over-treating particularly elderly patients admitted who would probably be on an end-of-life path, but the clinicians are stepping in to try and extend that life by a few weeks, and just calling into question whether that is in the interests of the patient. So we are looking to support that particular project, that particular investigation, but it seems unfortunate that it's really generated by the interests of one individual, and it's through their own direct experience, the family member. What would be helpful is if this was something that was nationally directed and we were using the data to inform that kind of research. And I come back to the point I made a little bit earlier, that there's so much more we could do by having a stronger evidence base to act on. And that's why I think getting our act sorted when it comes to the data that's within the NHS, the information is there to help us make those informed decisions. We're just not harnessing it at the moment.
Will, any clinical thoughts?
I think one piece of evidence we do have is that GPs are incredibly efficient and effective use of funds. And I think we with all the talk of the shift into the community and, trying to sort of free up hospitals and the rest of it, the one piece I think certainly recent governments have missed is that, you already have this community network of, GPs, of care homes, of pharmacists and others who have been chronically underfunded for a long time. Just in that sort of mini-ish budget we had for you in 2024, there's 22.5 billion that went into the NHS. I think, $1.5 billion went into, let's say, surgical centres. That probably should have been a lot more because they can start to really clear the backlogs in hospitals. 600 million went into social care, which is just a massive thing that we never seem to touch on because it's not quite as sexy as acute care. And nothing went into GPs. And yet we're talking about the shift into the community. And in the same budget, I think it was, GPs also got NI levied on them, which the rest of the NHS was exempted from, and they were given a tougher contract. And so with one side of our mouth, we're saying we've got to shift care into, areas where they can be given the tertiary prevention and maybe even quaternary prevention, given the fact they have more time maybe to go, well, let me think about this person who has, a so-called mental health issue or whatever else, and maybe triage them properly. Rather than that, we go, actually, we're going to garrote you behind the bike sheds, GPs, because, I don't know, I'm not sure what the agenda is, and then most of that 22.5 billion goes back into the acute sector, which just swallows it with no audit trail. And so I think that, when we start to talk about prevention, using this, you're using this pretty unique network of primary care physicians we have in this country, which is fast diminishing. Most of my friends who are GPs are trying to find alternative employment at this point, is really dangerous. And we could set ourselves up for a real headache in the future if we don't, give them the resources they need to be the tertiary and quaternary preventive force.
Simon, the question of overdiagnosis strikes me as very flush with what you've been talking about with this change of values. Part of that is surely entitlement or people lost and at a loose end or overdiagnosing themselves into just an endless list of medical problems rather than people who have, other structural things that we would not once have medicalized, maybe.
Yeah, and I think that speaks to Henry's point about no government wants to explain to people that bad things are going to happen. There's no more money to pay for it. There are consequences to your actions and so on. And it's very difficult. And perhaps one area which might help is diabetes, where it's grown 200-300% in the UK, and I think across Europe as well in the last couple of decades. And I'm not a physician, so forgive me if I'm wrong, but I think the general consensus is in the medical profession is 9 out of 10 type 2 diabetes cases can be completely avoided. Yeah. Through healthy eating, not just losing weight, but cutting down on the sugars you eat and very average amount of healthy exercise. You don't have to go to a gym and do crazy things, just really simple stuff. So if you go onto the NHS website, you don't have to actually work that out. The NHS Diabetes Information website, yes, talks about nutrition, yes, talks about exercise, but it doesn't in any way explain the revelation that you don't need to have type 2 diabetes if you do those things. You just don't need to have it. And it's costing the country, I think, 9 or 10 billion if you separate out type 1, obviously, and the type 2 that is unavoidable and genetic. So 9 out of 10, you end up 9 or 10 billion per year that just doesn't need to be spent. Now, I don't know if that's overdiagnosis or misdiagnosis or just a culture that doesn't want to say to people, actually, it might help if you make a few changes to your lifestyle and really get that message across powerfully. And in terms of getting the message across powerfully, one that came to mind when we were talking this was, who remembers a campaign from the 1980s, Don't Die of Ignorance? Remember that? Yeah, pretty much everyone, sorry, over 40, everyone remembers it because it was incredibly powerful. Now, correct me if I'm wrong here, but I don't recall any kind of similar state-organized campaign since then that could address these devastating consequences like diabetes. And talk about tertiary care. My goodness, diabetes feeds that in the most dreadful way, does it not? So that, I think, perhaps talks about some of the areas you brought up, and perhaps, and again, I'm not saying the state is the answer to everything, but the Don't Die of Ignorance campaign shows how powerful a good campaign can be that communicates something with people and how to make changes to your life.
Thank you. One final question, if there are any more. Druin.
Hi, thanks. Druin Birch, I'm a physician. One brief remark, one question. On Palantir and data, and I actually, as a physician, I think we're very good at not trying to extend life pointlessly in the last little bit of life. I mean, our qualities vary, but we are generally pretty sensible. One of the issues is you don't actually know what a doctor's mortality rate should be, and it might be that the slightly better doctors have a higher in-hospital mortality rate because they allow people to die. I'm not suggesting you said otherwise, but it's just an interesting point about data. The question's actually to Henry. I really liked your point that if there's a two-way thing between rights and responsibilities. You've said that we shouldn't sort of use people as a unit of labor and regard everything they do as our business. What do you make of the rest of the panel who largely have suggested doing more and things that we should do to make people behave better, take responsibility, have less diabetes, do more exercise? How do you square those two things?
Well, I mean, this is the role I play on nearly every panel I'm on. So it's not much of a surprise. And in fairness, there's a reason that happens, right? Which is that if you're on the right, typically the difference, a key difference between the way the left and the right tend to approach rights and responsibilities is that the right places a much stronger emphasis on the reciprocal nature between the two. So if you look at some of the rhetoric on the left about the NHS, it would be like, we're giving you this right, and this is an unqualified right, and we're doing it because it's nice and it's good and it's moral. And then the fact that you want to start controlling people's lives and all the rest of it, that's a practical matter. That's just, you know, we're doing this thing because we're good people, and now we need to control costs because we're practical people. Whereas on the right, you're much more like, actually, hold on a minute, if I have a duty and an obligation and so on. But as right-wingers, this unlimited obligation, entitlement to healthcare does exist, right? And so actually, it isn't obvious why somebody who is being taxed to the hilt to pay for somebody else's decisions shouldn't have some kind of say over those decisions as long as that tax is being paid. I think that you do, therefore, if you think about this structurally, need to try and change how you structure healthcare. But there is a reason. There is a reason that the rest of the panel talks like this. There is a reason that the Conservative Party talks like this, and it's because otherwise you end up with a system where you have an unreformed healthcare system, an unreformed welfare system, but you have people living unhealthy, unproductive lives, and that is suddenly an enormous direct cost to you, to your voters. And the other thing to bear in mind with this, of course, is that actually very often, and this is a challenge that cuts to the heart of all welfare policy, is that very often your big welfare state has destroyed the incentives that previously created the behavior that controls the things that you're now trying to control, right? People would live healthier lives if they had to bear more of the costs of being unhealthy themselves. Having a universal safety net that will always pick you up when you fall down is an incentive towards reckless behavior. which is why the metaphor I tend to use is that you gradually, in most developed countries, you start to see a shift from the concept of a safety net to this concept of a straitjacket, which is about controlling that irresponsible behavior in order. It does keep you safe. A straitjacket and a safety net both keep the person to whom they're applied safe, but they make fundamentally different assumptions about the relationship between you, the person subject to it, and the person in control of the system. So these are important philosophical questions, but unless you change all of it, actually there's a reason the rest of the panel starts talking like this. And a brief comment on quaternary care, especially with regards to mental health, which I don't think people talked about very much. As much as anything else, that is a definitional problem, right? Because actually it's not obvious that we are over-diagnosing mental health problems as we currently define them. Mental health definitions is a movable feast. Anyone familiar with a history of the DSM, which is the big manual of the increasingly big manual of mental health conditions, will know this. And I think that the fascinating thing about this is there's now a term of art in the mental health sector called serious mental health. Now, serious mental health, you might call it actual mental health problems. It's things like psychosis and all the rest of it. And then you have something which is not called unserious mental health, but which logically you can infer what people think of it from the fact that they have a term serious mental health. And that's your depression, your anxiety, and everything else. And with that, someone might genuinely be depressed. Someone might genuinely be anxious. If they are, and you say that somebody who is anxious has anxiety, you aren't necessarily over-diagnosing them. You need to change how you define that as a mental health problem in the first place.
Thank you, Henry. Thank you to all the panelists. We will conclude there. I wish we could talk longer, but lunch is available through the doors. Thank you very much to all the panelists again, and we'll be back in here at 1:15 for our Reforming Healthcare panel. Thank you. Thank you, everyone.
Sorry. I'm literally going to do it in that order. Yeah, just let me know, yes. And it's 1 hour, is that right? 1 hour altogether. Oh, yeah. Can you hear me? Can you hear me? Is there life in the room? Yes, right. So, ladies and gentlemen, thank you very much. Clearly, this morning you heard about the polling. You've discussed the health of the nation. In the next hour or so, we're going to talk about a possible reform, not the political movement, actually healthcare reform, and how we can change it to meet some of the challenges. And what I'm going to do is introduce the panelists. I'll ask them to make 2 or 3 minutes contributions, and then I'll have a session of Q&A. I'll be quite selfish, and I will ask the questions, but then I will open it up to the floor for more questions. And really what we want to talk about is if we look at the demographics of this country, we have an aging population. As people get up, we're now diagnosing more diseases that people get in old age, such as Alzheimer's, for example. That means the cost of an aging population is falling more and more on the taxpayer. If you look at the wider political arguments, we have 3 of the big parties, Labour, Conservative and Reform, are using language that is at times sceptical, from hostile to sceptical of immigration, with the best will in the world. How do we get those people who are long-term unemployed back to work? And is it realistic to expect all of them to fill the labour shortages? And given the scepticism on immigration and scepticism about how we get the long-term unemployed back into the workforce, we also have an NHS that probably has more doctors and nurses than ever before and still calling for more doctors and nurses. So how do we meet that challenge? When's the crunch going to come? And how do we meet that challenge before the crunch comes? And to help us try and answer that question or to investigate potential ways of meeting that challenge, very pleased to be joined by 4 panelists. Tim Reed, who's the head of research and consultancy at Lang Bouston. Christian Niemitz, who's the editorial director and head of political economy at the Institute of Economic Affairs, the world's oldest classical liberal think tank. Tina Jenkins, who is the general secretary of the Association of Medical Insurers and Intermediaries, and Lizzie Dibden, who's an advisor for Odyssean Capital, working in this space. For those who don't know me, why not? No, that's a joke, sorry. I thought you were going to say there's a man in this room who doesn't know who he is. My name's Sai Kamal. I'm a shadow minister in the House of Lords for Health and Social Care. I have been a health minister. I also am a professor of politics and international relations at St Mary's University in Twickenham, where I teach an MBA module on healthcare policy. And I also work at the Vincent Centre for the Public Understanding of Economics and Entrepreneurship at the University of Buckingham. So let's without delaying you any further, let's go straight to Tim. Tim, I'm going to be very strict on the timing. I'll give you about 2 to 3 minutes for your opening remarks, and tell us a bit about what you do and your thoughts on reform.
Great stuff. Thank you so much. So my name's Tim Reed. I'm the Director of Research and Consultancy at Lang Bouston. Just a very quick background. So I spent 5 years in local government doing public policy development there, 5 years at the Care Quality Commission as well, spent some time doing M&A due diligence on health and social care assets. And Lang Bouston is one of the market-leading organizations who write reports on the private healthcare sector. So we write reports on the health cover market and the private acute market, among various market segments. So I've experienced it from the healthcare environment from lots of different angles. And a couple of opening remarks I'll make. One is going to be focused on the types of private model you can have, because we spent a lot of time talking about private medical insurance earlier on. And I think one thing I would say is not to maybe narrow the focus to just insurance as a private cover type. So one of the things which wasn't mentioned at all is something which feels quite old-fashioned now, which is health cash plans. Some of the older people in this room might remember, like, they sort of really sort of grew up in the sort of well, some predate World War II, but they are a much lower cost way of introducing health cover to the population at large. And I think there is a real critical issue of thinking about expanding private medical insurance as we understand it, this holistic comprehensive coverage, which may include everything from cancer coverage down to these days allowing access to virtual GP services. And that type of coverage comes with a price point which even tax relief will mean is potentially unaffordable for both individuals and for some employer groups, particularly those employees with a very, very large employment base, which covers very kind of low cost and high cost workers. So I would urge thinking about the broadest level of kind of health cover products there. The other quick point I'll make is about a point which is mentioned about taking ALBs into DHSC. I think there's vast scope for efficiency savings there. I would say that when it comes to MHRA and NICE, there are specific perhaps reasons, and it's, it's a judgment call. Do you want something which is politically led or clinically led in its decision making, particularly when it might apply to approving regulatory products for both a private and a public market? So I think, NICE has an international reputation for excellence, and I think it is worth considering why that is the case before we rush to bring all arm's length bodies back under DHSC. So I'll pause there.
Thank you, and thank you for being very strict on the time. Christian, you've done a lot of writing over time, looking at comparative healthcare and different models, and you proposed different models for successive British governments to look at in terms of reform. Share your thoughts.
Yes, thank you, Say. That's exactly right. I've been writing about alternative healthcare systems for about 12 years now. I wrote a book 10 years ago called Universal Healthcare Without the NHS, where I proposed a social insurance system, which essentially means private insurance, but without risk discrimination. I looked at a couple of systems of that kind and showed that pretty much across the board, these systems have better medical outcomes for comparable costs. And I said this would be a better way to organize healthcare. And for most of that period, for most of those 12 years, I thought of that as, well, basically the sort of thing you can only really do if you work for a think tank, meaning it's an interesting thought experiment and it's great for seminars of this kind, but it's obviously not going to happen. That's the way I thought about it. I thought about it as the equivalent of, say, these libertarian writers who write about private currencies. Interesting thought experiment, great for a seminar. Is it relevant for policy? Obviously not, because most normal people think this is completely mad. But this has completely changed over the past 2 or 3 years. It's now become almost mainstream to criticize the NHS on a fundamental level, not just saying, well, it needs a few tweaks here and there, but really to talk about alternatives and to point out that there are systems that have better outcomes. You can now read this in newspapers, magazines. It's become pretty much a mainstream argument. And I'd say an even better indication of the way in which the mood has shifted there is that, well, the defenders of the current system would now feel obliged to explain why they defend the current system, why they think alternatives are worse. That didn't happen before. You now have the King's Fund, the Nuffield Trust, the Health Foundation, the IPPR, Institute for Public Policy Research. They have all written papers explaining why they think social insurance is not the way to go. And that's good from my perspective, because that's what it means to say that an idea has entered the Overton window. It doesn't mean that everyone agrees. It does mean that the people who don't agree need to explain why. And you don't do this with ideas that are considered beyond the pale. You don't have the Royal Geographical Society. They don't write papers explaining why they think the Flat Earth Society is wrong. They just ignore them. And for most of the period that I've been writing about alternative healthcare systems, I was basically in that position of somebody from the Flat Earth Society. I'm clearly not anymore. I now have opponents who take this seriously, and that's good. I'm still nonetheless not convinced by the arguments that these people make. So essentially, what a lot of the defenders of the current system would now say is that, yes, maybe if we could start from scratch again, then it would be nice to have a system of the type that you talk about. But we're stuck with what we have, and we need to reform what we have. Now, I have 2 problems with that. The first one is they never actually propose anything to reform the system that we have. So you had, I mentioned the IPPR, they have this report where they say, well, the Swedish healthcare system is quite good. Yes, maybe, but they're not talking about what can we actually do to replicate Swedish outcomes. They just talk about public health, which essentially always just comes down to rearranging the chocolate bars in the supermarket and nannying. And the second one is they always think that switching to a different system is massively disruptive and that it would take a generation. That's not true. There have been examples of where national health services have been replaced by social health insurance systems in parts of Eastern Europe after the fall of the socialist regimes. Yes, and it has happened before. It can be done. And since this is since the 10th anniversary of the EU referendum is close, I'll end by saying I remember going to an event I think 12 or 13 years ago where somebody mentioned the possibility of Britain leaving the EU, and everybody in the audience laughed because that seemed so outlandish at the time. And this is just wherever you stand on this issue, the Overton window can sometimes shift quite quickly.
Thank you. And I'm glad that you are no longer ignored. Over to Tina.
Great. So I'm the General Secretary for the Association of Medical Insurers and Intermediaries, that's AMI for short. I have over 30 years experience within the industry, both as an insurer and as a broker. I currently run my own broking business and wear a number of other hats advising femtech businesses on how they develop clinical care pathways into the kind of private sector. The association itself represents insurers and intermediaries, so our membership sits in both camps. And we work with them on the kind of basis of policy intent and commercial reality, that those two kind of cross over. We are currently, and just signed up to be a Keep Britain Working Vanguard. We think we've got a fairly unique position there, not as a commercial player, but really as an impartial organisation that has no financial gain to make by working with the government on Keep Britain Working on those kind of workplace health initiatives. We want to be able to bring our intermediary population as well as our insurers together to contribute to anything that the government sees fit to put in, particularly focusing on that SME area, which I think there's a real weakness out there. And we've talked about this, Tim, around how people are kind of crying out for that. In terms of the proposal, what you're asking for in the proposal is nothing less than what AMI has been asking the government for, particularly on 2 occasions. There are some issues around benefit in kind tax, misconceptions in SME businesses or across corporates around how that's applied. And there is a bit of a tax drag on that. Well, you know, that misconception means that people don't take that up even when it is funded by their employer. And around about the sort of second year of the pandemic, we wrote to government and proposed that they look for IPT tax relief specifically on private medical insurance to ease the burden on the NHS. Neither happened on both occasions, but the 8.6 billion figure in terms of the marketplace itself, yes, it's real, and yes, it's growing. What's driving that growth? Entirely the challenges in the NHS. If I'm looking at the private sector now, there's a huge amount of pressure on the primary care side of things, and they are now responsible for delivering a lot of primary care services that in past years they weren't. So that's me.
And thank you very much. And Lindsay, finally.
Yeah, Lindsay Dibden. I'm a career investor, was an aeronautical engineer to start with, then a chartered accountant, then a career investor. Common theme has been healthcare throughout all of that, and now trying to simplify my life. Anyway, armed with the task in hand, I thought 3 points to be made. The first was, where did healthcare sit 25 years ago in any general election as an issue of great importance? And of course, we probably all know that certainly those of us who were around then, yes, it was up in the top 3, but I then embraced AI and I asked Claude to tell me a little bit more about that. And the interesting nuance that you see is that whilst healthcare, of course, was one of the top 3 general election issues, back in the day, it was more about preserving its funding and securing its future going forward. Today, that nuance is slightly different. It's more about, is it sustainable in its current form, which doesn't dodge the question about funding, but it makes that question that much more important. And I think in order to get it right, any administration has to be honest with the British people and say 2 things. 1, this will take a lot longer than you think. It'll take much longer than any typical parliament. And 2, it'll get worse before it gets better. That often is the case with any corporate turnaround. Point 1. Second point is, what reforms do we think, or do I think, might need to be addressed? Some of them are in the realms of the obvious and are well recognized already. That's to say, the NHS needs access to more capacity. We've got to resolve the social care problem where there's a natural clash between funding and benefit there. We need to try and clear out the secondary care environment. Hospitals are singularly the most expensive hotel you could possibly imagine. So we've got to keep people from going into them in the first place and try and get them out as quickly as is possible.
Fourthly, I think changing the bureaucracy and the way administration and reward for good management happens. There's too much of the former, bureaucracy, and there's not enough reward for good performance as I see it in the latter. I think with improved management skills, you probably do an awful lot more. And then lastly is embracing data. Being an AI fan, I've got a good degree of optimism that what Palantir, for example, as we heard this morning just before lunch, might be able to bring to the party could be really quite significant and within a timescale which is good, quick. The third and final point actually speaks to Tina's questions earlier on, which is co-payment. I'm a big fan of co-payment. Carrot and stick, I think, need to be part of all of this. I think there should be some sort of fines levied if people fail to show up, but equally there should be incentives for people to take advantage of what's on offer and take advantage of their own responsibility or take responsibility for their own healthcare through life. That's got to happen. I like the idea of growing the insurance industry. There was another question I asked Claude, how many people currently avail of an insurance policy? My number was 6.9, but it's in the same sort of realm anyway. That number's grown significantly and it could do very much more. The point that all makes to me is the public is ready for change in the NHS. It knows full well that care cannot be provided for free at the point of demand care or however you choose to define it. We've all got to play our part in this. Quite what the solution to that is requires a lot of thinking, much deeper, and so on and so forth, but it's an issue, which I think is there. Thank you, Syed.
Well, thank you very much for your opening remarks. When I look at this as both someone who's written for think tanks, but also as a shadow minister in health, one of the things I have to think about is the art of the possible. You know, how can you get reform, but actually how can you build a coalition across the political spectrum? And I want to touch upon those issues in a minute. But two things I think came out of your opening remarks. The first was, actually some of this is already happening. People are already voting with their feet, aren't they? People are already taking up either pay-as-you-go private or insurance. What's even more interesting politically is that many of the trade unions offer their members private health insurance or private health care plans. If you look historically, I'm not saying this to try and get political promotion, but my father was a bus driver. And he was a member of the Transport and General Workers Union. And there was an incident when my mother wanted to see a consultant at a hospital, and she looked at his payslip. I don't know why. I suppose all mothers do look at fathers' payslips. And she found a small contribution and found out it was a contribution to something called the Manor House Hospital that trade unions used to use. And so she was able to see someone thanks to his trade union membership. And when I speak to my trade union friends, they say to me, actually, we have a bit of a funny relationship. We may lobby against it, but lots of us are members of private health insurance schemes. So what I really want to say and ask all of you here, and you don't have to answer, is we don't necessarily need to make the argument anymore, do we? Because people are now saying the NHS is at capacity. Can we keep doing this? People are voting with their feet, or do you think we still need to make that argument for non-state alternatives to the NHS?
I think you have to. If I go first, if I think you have to make the argument because it's such a huge political issue, and the argument is hard and it will cause challenge. I think actually achieving reform should be perhaps achieved through stealth rather than through actual thing, but you still do need to accompany that with the argument. On the other hand, as you say, people are making their own decisions, and that argument becomes progressively easier the more people have actually had first-hand experience of private healthcare themselves, because their experiences are often positive compared to what they've experienced in the NHS.
And Christian, you were ignored for a long time. We are very pleased that we are not ignoring you now, and I hope this is good therapy for you. You've also been realistic about what you've written and talked about the art of the possible. What do you think is possible now that the Overton window is shifting?
Well, I would look at something like the Australian arrangement where they have a tax rebate system for people who take out private insurance. Now, I wouldn't do it in exactly the way that they do it because the rebate isn't strongly. So the idea is basically once you have private health insurance, you need the public system less, and the rebate should broadly reflect those cost savings, and they need to be aligned. It isn't particularly in the Australian case, but just that kind of logic is something that could, I think, already be applied. Used to be the case, actually, historically. And where you give people rebates for getting private health insurance just so that you have to have recognition. There are some savings for the public system. Why shouldn't you benefit from that? That's something that can already be done now, and you could massively increase the number of people who have some exposure to private healthcare in that way.
Tina, you actually mentioned that in your own remarks. Do you want to build on that?
I mean, it's interesting because, I mean, I've been in the industry for 30 years, so I've seen it go through a number of iterations, phases, particularly on the removal of tax relief for the over 60s. It was never given to entire workforces. So I saw the impact that had on the industry. And I think, you know, there are some options out there for sure. And I think that the time has come to really look at that and analyze what those alternatives are. But I think we do need to think about there is pressure also within the private sector on the resource and availability, hospital access, and particularly around the primary care services. Our first port of call now for a lot of people who have policies is not to go to their GP, is to call the virtual GP and get their access through that route. And typically in the past, you would see your GP, go through a number of tests on the primary care, and then decide that you want to go privately. That has shifted fundamentally, but that cost is now shifted to into the insurer. And so the insurers are struggling. I was at a summit yesterday that we ran. There were a number of insurers there, and there was a common theme coming through, which is how do we address this increased cost of healthcare? What can we do on a preventative level, and what can we do in the current state of affairs? And it is a real challenge. It's a real challenge.
So, Lindsay, I was quite optimistic in some ways. Tina's sort of, has dampened that.
Sorry.
No, you're being realistic, which is great.
Yeah.
What from your own experience of investing in many healthcare providers, etc. Do you think it's the fact is that people are already doing this? That do we need to push any more, make the case any more for non-state provision of healthcare?
No, and I think as I mentioned in my opening remarks, that's already well established in the public awareness. I think what we've got to do is encourage the rate at which people are prepared to take it on. And these various examples of how you can encourage people to buy insurance product is a very good one. I think the insurance industry, if I may, I think needs to get a degree more sophisticated in how it prices. That can come about by two things. One is a fairly sort of blunt message, which is about increased competition to drive pricing down. But the other one, I think, is perhaps with a little bit more sophistication, which is you've got to understand how your customers manage their own lifestyles. And this goes back to some of the very early comments that were made this morning, first thing, which is it starts almost in the cradle, at your home. If you run your life in a way that recognize you're responsible for your own healthcare, then I think that should be something which the insurance industry can recognize. So you need to encourage ways for people to buy healthcare, however that mechanism comes about. In the primary care world, I would say the mechanisms which I think this morning, Reece, you mentioned, which are to do with a £5 copayment, is a fine idea. I don't think that's going to stop people from going along to see their primary care physician at a point of need, when they do need that care. It might stop trivial visits, perhaps, but equally on the other side, if they don't show up, well, they've lost the £5, or you can chase them afterwards. I'm sure HMRC has an ability to get into our bank accounts one way or the other and can fine us for not turning up. So I think there are various sticks and carrots that can be brought to bear. I don't think the point needs to be made anymore.
That's interesting. So the two factors I think are driving change. One is that people are already voting with their feet to a certain extent. The second one is clearly technology, and some of us have mentioned it. And what's very interesting in some ways, if you still look at a lot of debates around healthcare, we're still debating how to make a 1940s model of healthcare better. The fact that you have to try and get an appointment with your GP, you have to try and join at 8 o'clock in the morning, a phone call. Now they've made that easier. They claim via the app and via surgeries having their own websites, and that varies. Some surgeries won't let you book it via the app. You have to book it via the website. But second, essentially, you're going to the GP as a gatekeeper. Either what do? They either prescribe something, so you're off to a pharmacy, or they send you for a consultation in secondary care somewhere. And clearly that model has been squeezed, but also it's a bit out of date, isn't it? And technology can leap over that by putting you directly in contact for someone much faster. Do you have any thoughts about technology in the near term and at the near and medium term rather than long term?
So I think it's a very interesting issue. The ability to directly refer to yourself to a secondary specialist is, I believe, common in the German, is able in the German. I'm looking over at you, Christian. I'm not so sure. I believe it's possible in Germany, I believe, and maybe in other healthcare
you don't
systems.
need a referral.
Pardon?
You don't need a referral.
Yeah, but that's right. And I think, you know, it obviously does work, but obviously that's operating under a different kind of healthcare funding model.
Sorry,
as well.
but you can also self-refer in the UK if you're prepared to go private.
Oh yes, if you're prepared to go.
No, that's not necessarily true, because the GP is still the gatekeeper. There are some services, such as back services, you know, musculoskeletal challenges. Some insurers will allow you to go through a self-referral route.
I was thinking about
see the GP; he's the gatekeeper.
So I think it's pay as you go rather than.
She's the gatekeeper.
I think it's pay as you go rather than via insurance.
Even in that case, I think you still need to get a referral. The hospital will look for a referral from a GP to understand what the challenge is.
Okay, well, thank you for correcting me.
Sure. Sorry.
No, I learn all. We never stop learning. Is my excuse for all my mistakes. Okay. Sorry. Who's? Did you want to come in there?
I mean, we're obviously we're talking about the kind of the process of referral to GP. I think, there is an opportunity to leap over that. The insurers have jumped on that. They jumped on that in the pandemic phase where people couldn't get access to their GPs. So, you know, there was a real kind of emergence of that virtual GP service. Some insurers integrate it within their whole clinical care pathway. Vitality, for example, is really about prevention and really about getting on the kind of start of the curve of treatment of an individual at the earliest possible stage to make sure they get the most appropriate treatment at the most appropriate cost, to create the best possible outcomes. But not all insurers are doing that. They've all got virtual GP, but they're not necessarily integrated. Right. So they sort of present like it's joined up, but it's still a little bit clunky.
Christian, you know, what's you know, you are one of these people who can think the unthinkable in a think tank. Clearly, you've been looking, you know, far into the future with your crystal ball. But what about nearer term? What's possible with technology?
Yeah, I guess quite a lot. So I had a look a couple of weeks ago at the NHS 10-year plan, where they talk a lot about technology, about how AI is going to revolutionize everything. And that's all well and good. It's just that you can also see this. I compared it to an earlier plan from 25 years ago, from early Blair years, where they were saying pretty much the same thing, saying we now have the internet and that's going to sort everything out. And I'm sure you can find similar reports from the 1980s saying we will now use the fax machine or whatever, and this is going to revolutionize everything. I mean, it's all well and good for policymakers to recognize we have these possibilities now and let's make some use of it. It's just that I would prefer a system in which you simply have individual healthcare providers on their own coming up with being able to experiment with technologies and being able to recognize we have these possibilities now, and our patients are already expecting us to use it, and so let's experiment a little bit with that, and where you don't need a policy, where you don't need a white paper that is published by a department saying we have this technology, use it in this particular way, and we want to increase take-up from 30% to 37% by that year. Just give individual actors in the system the autonomy to experiment with different ways of using technologies.
So, Lindsay, you're an investor. You must see some quite exciting health tech out there, and, you know, and some of that, of course, is clearly saying we can do this now, and others are saying longer term this should be possible. What sort of developments do you think is possible in the shorter term?
Yeah, difficult one. Right. That's an easy answer.
I think we all want investment tips.
Yeah, in my experience, this is before the advent of AI and big data crunching ability that we have now. Getting any new service or product through the doors of the NHS was fraught with difficulty because you had so many decision makers who either might be supportive or quite hostile to what it is that you might have been proposing. And furthermore, you had to do an awful lot of work to try and identify, for example, in a medical device, who would be the early adopters? How do you harness them? How do you encourage them to get excited about all of this? How do you get that through a budgetary stop inside a hospital? How do you get universal awareness? And only with those things can you really afford to make what is an expensive investment decision. You've got to see the size of the prize. The United States is a hell of a lot easier because the market size is so much bigger and they're more willing to take risk and innovate around these things. We have a very conservative healthcare system. So the status quo hasn't really helped. More precisely to your question, I think the world of tech perhaps has offered some easier break-ins in the last few years, some of which have been born out of the the force of COVID. So hospitals, people weren't going to hospitals, so how else did you get access to your healthcare? And the use of tech became much more prevalent, I think, by foundation trust hospitals. But again, you've got 200, and I think there were 247 when I last got a different number this morning. But it's a big number, but it's a small number at the same time. It's not a very big marketplace, and you've got to break into all of those. But things like, for example, DNA, did not attend, is something where you can spend a relatively frugal amount of money and get a tangible, measurable return for that by sending people an SMS message 48 hours and 24 hours before their appointment saying, here's the pin drop. This is where you're supposed to come for your meeting at 2:30 tomorrow. And it does work. Yes. Not universally, but it does. So you can get some wins like that. Depends what area you're looking at.
So just before I open it up, I want to sort of use you as a focus group, if that's what mine. Please do bear with me as I have my own private focus group up here. But one of the things I've been thinking is how do we build a coalition politically across left and right to expand non-state provision? And I'm very careful about the language I use. I don't use the word private. And I try and distinguish. And one of the things I've found is if you speak to people on the left, we don't forget that rich history of mutuals and friendly societies and cooperative socialism. And they are more open to the idea of non-state providers if they are cooperatives or mutuals. For example, anyone who knows Bennington Healthcare is it's actually a mutual healthcare provider. Then you make a slight leap and you go private, not for profit. So Bupa and Nuffield, for example, and there's some acceptance there. The challenge comes when you start saying, what about private for profit? But I just wonder, is your advice to me, the politician who's trying to build this coalition across left and right, is that a good, sensible approach to try? Or are there other things I could be considering in trying to build that coalition that might appeal across the political spectrum? I don't know who wants to come in first.
I think if you look at the landscape of the health sector, as you picked up earlier on, we've got cash plans out there that are delivering kind of some sort of services out there. I think completely lost what you said then. Sorry.
No, so it's about building a coalition across left and right.
Yeah, I think
to be accepted, to be accepting of non-state providers.
Yeah.
People who aren't the NHS.
It does. The landscape does need to broaden. There are, key players in there, the likes of AXA and Aviva, who are kind of privately owned, stand to make a lot of profit if that insurance market booms. There are some associations out there like Bupa, it's not profits, as is WPA, and then obviously you've got Benetton, Exeter Friendly. There's all sorts of associations already out there. They are all still struggling to make ends meet, to drive those kind of loss ratios, to get the right returns. And I think if we're really serious about looking at the healthcare sector, not necessarily just the private, but across it all, I think you've got to really give some considerations to what that infrastructure looks like, not just use it as a pressure valve.
I do wonder if there's something about people on the right should also be championing non-state providers such as mutuals and cooperatives and and others.
There is a place for them, and there's a lot of cash plans.
Kristen, you do a lot of thinking across. You don't always want to build a coalition, but I know that's. By the way, Kristen and I used to work together. I think I was nominally his boss. When I say nominally, but go on, Christian.
Well, I don't want to make the concession that making a profit is evil, even in healthcare. And so, yes, I often hear this argument that it's morally wrong to profit from people's sickness. But by that logic, you could also say a baker is immoral because he profits from people's hunger. And I don't want to make that concession. It should simply be worked out on the market. You can have non-profit providers in competition with for-profit providers, and then the market decides what works here. And in healthcare, as it happens quite often in countries where you have mixed systems, people have a preference for non-profit providers. They trust them more. If that's the market outcome, perfectly fine, perfectly okay with that. But where I do a bit of coalition building, maybe atypically, is I guess it helps me to make my case that the system that is closest to the one that I'm talking about is the one in the Netherlands. If it were, say, Singapore, that would be maybe, or Hong Kong, that would be a bit of a harder sell. But the Netherlands is generally a country that people on the center left like. They see it as a Northern European social democracy correctly. And if they have a private healthcare system, you can argue, well, can it really be so terrible?
If I could offer just one quick reflection, because what we're talking about kind of here with mutuals and benefits is about the kind of funding structure with due access products for healthcare. If we look at it from a provider perspective, and if we take some learning from like social care, where you will find that not-for-profit providers have been pulling back from the delivery of services because they've begun to recognize, or they feel that they are not the right people to have to be able to deliver actual care services, and their role is better placed in the advocacy market. So I'm not saying there isn't a role for charitable organizations in the delivery of healthcare, but what we have seen in an adjacent sector is that actually there has been a pullback in how many not-for-profit charities are actually delivering services rather than providing more broader wraparound advocacy or early intervention services.
How do you feel about this, Lindsay? And before I ask you, one of the places that I suspect we won't get consensus between the left and right is the role of private equity.
Can't imagine why you would say that. But just staying with the point in question, though, I'm not sure I completely agree with the foregoing. I think it doesn't really matter in the public's mind whether you call yourself a mutual, a not-for-profit, or a charity or otherwise. These businesses have to make a profit, otherwise they'll fail and they won't be there to provide the service going forward. So at some level, they will be profitable.
They'll make a surplus, not a profit.
They'll, terminology.
Yeah.
We're a right-wing
environment here. At one of my universities, I share an office with two Marxists. So when we make a profit on a conference, I have to talk about making a surplus, not a profit.
Anyway, to the point about provision, where I agree, I think there is a very valid place for the private sector to provide. What it's good at is taking the less complicated, more homogenous types of elective surgery that are very repetitive and that you can get high efficiency out of, and doing those very well. There is a valid and legitimate place for that in the healthcare system, regardless of who provides it. But if the private sector can do it very well, why not let it?
Brilliant. And on that note, and having been corrected by Christian, we've got about 20 minutes left. I'm going to open it to the floor. Please state your name, who you are, not why you're here existentially, but and also if you want to direct your question at one person, I don't expect all four to answer unless they particularly want to.
Yeah, Hugh Eisbrow. Actually, I'm talking next, but I haven't run SynLab for 10 years, so that's incorrect on the next thing. Before I get sued. Yeah, so I've just interested in an idea about insurance. My partner is South African, and she has a insurance policy with Discovery, who own Vitality here, and she gets points for doing exercise, having dental checkups, keeping her weight and blood pressure in the right level, and kind of points being prizes, and she gets a lower premium. And there's a lot of evidence out of South Africa that has positively changed behavior, particularly companies who have Discovery say, we'll pay this level, and if you don't stay healthy, you pay the top up. I just wonder, should we as a country, and I know certain papers would disagree with this vehemently, should we give people a tax break or a top up on their benefits if they get points for staying healthy? That would be one way of, you think staying healthy should be enough of an incentive in its own right, but people do seem to respond to financial incentives.
So not nanny state, maybe nudge state or something like that. I don't know. Yeah. Does anyone have a view?
So I'm very familiar with Discovery and Vitality and the Vitality model. And I have clients who have that policy in place, so I give them advice on it. And they're also a member of the association. So we're quite close to them. They are very advanced in their approach to preventative medicine. Indeed, yesterday, we were talking about predicted ROI on preventative measures, particularly around the areas of genomics. So that's really big for them. But their policies are not always the least expensive. It costs money to provide those additional incentives in place, but it does drive the right behaviors. And so long as an individual has a policy and they understand they might be paying a little bit more, but they're investing in their health. And I think that's how it needs to be approached. But the rewards are there. It's the carrot and stick thing. It does work. But we were very skeptical as an industry about 20 years ago when Vitality did come in as Discovery in a joint venture with Prue Health. So it was quite an interesting step change to the marketplace, but it did shake it up a little bit. And therefore, a lot of other insurers have health and well-being incentives in place to kind of mirror Vitality.
You also find in the States, I know a lot of insurers in the States, but my parents lived in the States, and my mother's health plan incentivized her to go to something called Silver Sneakers. Basically, she had to go every week for some bit of physical activity, and that was part of the plan, part of prevention.
And they've got some great data. Vitality has got some incredible data, the impact that they can have on a preventative basis. by changing those behaviours.
Does anyone else want to come, or shall I go to the next question?
I'll just throw in a quick observation. Yeah, I think all of these things cost money to deliver, so we're not really challenging the question about how much would it all cost to do that. But I would suggest that that kind of incentive would be really powerful if the government did it through a co-payment or a Swiss or a Dutch medical system where there's a hypothecated tax, essentially. Because if you could see what you were paying for your healthcare and that cost might come down because you were taking better care of your own health, I think that's a powerful driver.
So the point is you could do it with the NHS.
I
You
think
could just
so.
give people a tax break,
Yeah.
keep the current NHS payment
Yeah.
system.
Now, somehow you've got to put in a system that measures what people are doing, and that's the challenge.
I think, if I remember correctly, I think Wes treating more thinking about incentives for. I think it got to the level of preventative incentives, but I'm not sure whether the thinking went beyond that, to be honest. Now, Tim, I remember you had a question. Tim, do you?
Thank you, Said. We all know the expression, the NHS expression and principle, which is free at the point of use. Now, my question is, how do we shift that to free at the point of need?
And Tim, when we were speaking before, you said something like you think you heard Wes Streeton once say "free at the point of need." Is that right? Right. Okay. Fine. So, once again, does language matter? And do we shift from free at the point of use to free at the point of need? Should we? We've talked a lot about alternatives to the NHS. Should we be looking at what the NHS offers free in quotations, because it obviously costs taxpayers, but free at the point of use? Should we be seeing if we change it to free at the point of need? Not to deny people much needed treatment, but actually should the NHS be offering all the stuff it does offer?
I think it's certainly an interesting question, because ultimately changing from free at point of use to free at point of need is a one-word shift which carries huge connotations and which requires a huge amount of political will to achieve. So, but if we're talking about the world of a possible rather than a world of, you got to embrace it in those terms. But I think you made the point earlier on about, a system which was set up 40 years ago. I think, even with the best will in the world, anyone serious on the left would not say that you would set up the NHS today in the way that it's structured to meet today's healthcare needs. Like, the NHS may have been absolutely the right model for 1947, 1948, but it's not necessarily the right model for today. And of course, free at the point of use, where that becomes a real challenge is what does that even mean in a NHS world which funds kind of preventative health as well? Because you are sort of engaging with health at all points in and outside of clinical settings. So I think there is a very real philosophical argument that if you want to keep an NHS system in the way that it broadly is structured today, saying free at the point of need, or, and I also agree with co-payments actually, so I don't really even agree at free at the point of need, because I think co-payments, they work in a lot of countries, even countries like France, which you might think may kind of bristle at the idea of paying something. I think they pay a €1 charge to see a GP. So I think there are other measures, but free at the point of need is at least going in the right direction, but it would be very hard to achieve politically, I think.
One very simple thing, which I think one could do to bring the attention to the public consumer to the cost of the care that they're being delivered with, is to give somebody a little statement of what the cost of the care that they've just enjoyed in the hospital has come up to when they get discharged. We're not asking you to pay yet, but just have a look at this and take it away and internalize.
Christian.
Yeah, it's worth pointing out that it is unusual for healthcare to be completely free at the point of use for everybody. Most systems use co-payments, but of course they have exemptions then. Because making a service free at the point of use for everybody is just a very inefficient way of ensuring accessibility. You don't want, say, if Elon Musk lived in this country, you wouldn't want everything to be free at the point of use for him.
But it would be.
It would be, but that's what I'm saying. That it's an inefficient way of achieving accessibility. What you need is co-payments for those who can pay them, and if it's at a modest level, that would be the vast majority of the population. But you can always have exemptions. So, for example, in the system in Switzerland, where co-payments are actually quite high, it's something like 20% or so of the total. But even there, it's capped at some level. So you hit the ceiling at some point, and then if you're really unlucky and you need ongoing treatment, at some point your contributions are capped, and then from then on, it's free at the point of use, but you need to reach that cap first, and you can do that and still have exemptions for, if you want to make sure that ability to pay is never the reason why somebody doesn't access healthcare. That can be done even in a system that has co-payments, even if they're quite high.
Any other questions? Please do put your hand up. Don't be shy. Otherwise, I'll have lots more questions myself. Please.
Hi there. I'm just wondering what the panel thinks of the current state of PFIs in a lot of hospitals. I know there's still like millions, if not billions, still outstanding. There's been a few shifts of where the government wants PFIs to be, if they want less or more. There's some ridiculous ones where a lot of hospitals don't do their own laundry. I think Solihull Trust has a laundry bill of £576,000 per month because they don't have the facilities, so they just outsource it. And there's a lot of outsourcing in a lot of other parts of the NHS. So I just thought to get the panel's thoughts
So we're
on
talking
that.
about two things here, aren't we? We're talking about one is private finance initiative, or public-private partnership, as it was called after later.
And then just
for
outsourcing
infrastructure, and then
of
outsourcing.
facilities.
Very interesting. Was it James Murray, the current Secretary of State for Health? I think it was yesterday on LinkedIn. He had a video that talked about stuff that he was somewhere where it was being outsourced, and he was going to bring it back into. No, it wasn't James Murray. It was Darren Jones, and they were talking about bringing more things back in-house rather than things being sourced out. Not only for ideological reasons, but he claims security reasons as well. So, any thoughts on both PFI or PPP and outsourcing?
Yeah, I've seen some evidence that for some of the PFI schemes that it probably would have been more cost effective if it had been financed in the conventional way. So some of the criticism of PFI is correct. It's just that it's often overact. You sometimes hear the argument that PFI is bankrupting the NHS and that you have these companies that are ripping off the NHS. Well, whatever financing mechanism they would have chosen at the time, if you expand a hospital or build a new one from scratch, that costs money. There is some upfront cost under any kind of financing arrangement. And so you can't just look at the amounts of money that is being paid to a private company under a PFI contract and say, that's the problem. They're not getting that money for nothing. They have provided a service or are still providing a service, and they're getting paid for that. And then you can argue about, well, could it have been done in a better way? It probably would, but then again, this is a consequence of a system where these decisions are taken centrally. In the system that I have in mind, these would just be local decisions. A hospital, each healthcare provider would itself just ask itself, do we want to use this financing mechanism, or do we want to do it in a different way? Do we want to outsource something to a different company, or do we want to provide that in-house? And that would just be a local decision. There would not be a policy.
Any other thoughts on PFI or people? No.
A very brief one on outsourcing. Yeah. So again, like a lot of there's obviously a lot of the concerns which are raised about, why are we using and private sector companies, although people tend to blur private equity and private sector companies together as one homogenous mass for their own purposes. Actually, private equity backed health and social care companies is actually a reasonably small proportion of the overall private sector market, and some of them operating maybe in quite sharkish ways, but other of them are actually long-holding stewards of private sector companies. There's a vast spectrum. What I always say to these people of criticism is, ultimately, it's commissioners who are outsourcing services to the private sector companies. When they say, it's so disgraceful, there are so many private sector companies which are running children's homes, and about 90% of children's homes placements are in the private sector. Now, I don't think that's a great state of affairs, to be perfectly honest, but ultimately these are decisions taken by commissioners, and commissioners are commissioning, as long as a baseline quality mark has been reached, which is Ofsted in the case of children's homes, then they are doing it on a price basis. And so this is kind of a market in action. People may complain about it, but it is public sector commissioners who are placing those services in the private sector.
Thank you. Reece?
Tim, you mentioned at the start about ALBs as one of our policy suggestions was to bring the ALBs back into DHSC. You were beginning to come out to bat for a couple of them.
Yeah.
So I'd like to hear your defence of the MHRA was one that you mentioned, if I remember the other. And then broadly to the panel, your thoughts on how we talked more generally about the market and the public and politics here, but on ALBs and regulators and how they feed into this space right now.
And I will say that I'm not currently going out to bat for CQC, my ex-employer, and not what decisions may happen in and around them. But with MHRA and NICE, and I think what I would like reflect on is the extent to which you would rather have decisions on medical devices and pharmaceutical products for the entire country being decided at that ultimate accountability level by a kind of clinical-led position or a potential politically led position. And I'm separating out here the distinction between you're approving something for use in the country and you're saying that the NHS is going to fund its use for the public. Because there's a big decision, and the larger the private market grows, the more important that distinction is. And I think, some of the conversations early in the Labour government about, better access to innovative drugs and changes to drug prices, may have been needed. That's an open question, but also reflect that potential danger of having a more politically driven approach to making determinations about pharmaceutical products. And you could argue it either way. I personally would say it's better clinically led, but you could equally easily you can make arguments to say it should be politically led as a decision-making body.
Well, no, just really to kind of echo some of what Tim has said, but I don't have any particular political leaning either way.
I think at that level, to Tim's point, my position would be it needs to be an apolitical body that makes the decisions on whether or not a product, device, or a drug should be made available in the UK. The pricing doesn't need to be made by a central body. The pricing can be left to the market. And the market comprises hospitals, it comprises GPs, they've all got their budget and they're empowered to make a decision around all of that. So I think less can be made of that. I think my observation about regulation, having been there firsthand in a social care provider, is the cost benefit was hopeless. It was woeful. The cost of the CQC fee to me versus what they didn't bring to the table at all needs a lot of explanation. There you have it. So there's a bit of reform needed over there. But
Christian, you must have some thoughts on this, particularly with the upcoming, or actually the current NHS, what's it called? Is it NHS Modernisation Bill, I think is the official title. It was called the NHSE Abolition Bill initially. Go on.
Sounds good to me. On the question of should decisions about what should be available, well, essentially rationing decisions, but rational rationing, should those decisions be made on a technocratic or on a political democratic basis? Perhaps unusual for a classical liberal, I'm a technocrat on those matters. Where you can really calculate cost-benefit ratios, you should do it. And we have seen, I think it was under the Cameron government, where they said, well, there are a number of cancer drugs that were not approved by NICE, but we will have this cancer drug fund, and that will wave it through. Well, there you get the problem, that the reason why they did it is that, of course, those were headline-generating visible instances, but it could well be that, say, a particular cancer drug, it may be high profile, it may generate bad headlines if it is rejected, but it could well be that that money is better spent elsewhere, and that you save a greater number of lives in other ways, but just in ways that will not be very high profile. And there's always going to be a political temptation to concentrate on the things that have a high public profile and that are very visible.
It's interesting from my perspective, having been a minister and now a shadow minister, many of the companies who approach me and want help, quite often it is to try and convince NICE to change their approval. And basically they are lobbying for their drugs to be bought by the NHS at the price that they want to sell it at, and to be approved. And NICE has done a cost-benefit analysis, also thought about taxpayers' money, and whether, so for example, a couple of drugs recently, I think there's one on for Alzheimer's that slows down in the first 6 months, and that what the cost-benefit analysis wasn't considered sufficient to be funded. And they're lobbying heavily. So, yeah, 6 months is really important. It slows you down. And that's the sort of issue that we face as politicians, particularly in opposition. But obviously in government, you have to defend those cost-benefit analysis. I think the other reflection I would have is we had this when we were at the IEA, and when I was at the IEA, we started thinking about jokingly who regulates the regulators, but who are the regulators accountable to? And certainly a number of debates in Parliament or in the House of Lords, a number of people have said, where's the accountability for the regulators? Who are they accountable to? And it's almost as if, well, why are they not directly accountable to Parliament? And I just wonder whether that is a slippery slope to being, if they are accountable to politicians, the moment, especially MPs, the moment a constituent writes to them about something that they can't get, even though there's not an overall cost benefit there, they might be lobbying very heavily on a political base for this to be approved. And I think that's the real challenge, because politicians, we want a lot of these organisations to be accountable, but we think they should be accountable to us. But the danger of that is, if it's got political accountability, then decisions may be politically driven and not driven by the evidence. We've got about a minute left, so please. Fred.
I would like to make a point in defence making when it comes to matters like this. I don't think that the MHRA or NICE should be brought formally under ministerial control. I do think lots of the ALBs should, but I think those two have operational independence. But when it comes to accountability of regulators, I think it's worth remembering that when we were in the European Union, those regulators were largely accountable to the Commission, who are ultimately politicians. And that was the accountability structure, and it sort of works coherently within the EU. But as ever with what we've done since leaving the European Union, we've kind of left a lot of the old wiring intact. So we're in this strange dynamic where we don't really know who the Financial Conduct Authority is accountable to. We don't really know who the MHRA is accountable to. Same with the Competition Markets Authority. But it is right and proper, I think, for governments to appoint the chairman, to the CEOs of these organizations, while guarding their operational independence. Ultimately, I think these things are a matter for democracy. It's just we have to trust and hope that Parliament sets the correct rules and guidance, and then we elect a Chancellor of the Exchequer who holds the purse strings relatively intelligently. So these regulators can make decent quality decisions.
So depending on the by-election result today, that could all be about to change, could it not? So we've got about 30 seconds. Does anyone want to make any final points at all? No, good. Well, well, thank you very much for sharing your views. We talked a lot about the system of healthcare, mostly outside the NHS, a little bit about the NHS, but clearly there is a momentum in this country at the moment for people taking up more and more non-state provision of healthcare. And if you look at the tensions politically, it's obvious that the state can't do it all and the NHS can't do it all. So can we show our panelists our appreciation in the usual way?
Yeah, I know. She's not for a little while. Yeah, maybe a few months. Yeah.
Great. Hi, everyone. Thank you so much for joining us for our next panel, Enablers and Blockers for Clinician Business Leaders. To introduce myself, my name is Harry Richer. I am the Director of Fighting for a Free Future. We are a relatively new campaign organisation for freedom and free markets, and there's nothing more important to free markets than supporting our business leaders. So I'm really excited to have a fantastic range of guests here. We have Dr. Ian Chan, who is the Primary Care Network Clinical Director at TELDOC. TELDOC is a primary care network, a collection of GP surgeries, and it describes itself as Telford's first super surgery. 80% of GP surgeries are GP owned. That's the kind of historic norm. And super surgery started to really appear in 2015 as surgeries began to consolidate. We have to my left, which is Mary Beckwith, who's the co-founder and co-CEO of Lindus Health. Lindus Health is a contract research organization. They've created industry-leading software to manage clinical trials across a range of health areas. And actually, they describe themselves as an contract research organization because their technology has meant that clinical trials can be managed much more effectively, much more reliably, and much quicker, partly through the use of AI, which is something I'm sure we'll get into. And the next to me is Hugh Risebrough, who is the CEO of Latchmore Associates, which is a consultancy firm that supports operationally, commercially, and gives strategic advice to private healthcare firms that are looking to enter the UK market. So I'm going to invite our panelists to say a few opening remarks, speak a bit about their business and their experiences of both the enablers and blockers for them in their work. And then we'll move to a kind of panel discussion and then onto a Q&A with the audience. So I'll invite Mary to start.
Yeah, thank you so much. Thanks so much for the introduction. It's almost become a tired refrain that the NHS should be the best healthcare system in the world. You know, it is true though, right? So you have, firstly, fantastic base of fundamental research, key opinion leaders in virtually every area. You have an incredible longitudinal data set, particularly in primary care. And you have very high trust in public healthcare. And yet it doesn't work this way in practice. So my perspective is going to be almost very myopic around clinical research because that's my knowledge area. But you know, when we talk about clinical trials, firstly, they're essential for all new sort of progress in medicine and science. But the UK has recently fallen from one of the world's clinical trial powerhouses in the top 5 globally to now I think it's ranked 13th or 14th globally for a number of patients enrolled in clinical research. This means longer delays. In many cases, it means preventable deaths from patients who could have received treatment on a clinical trial. And unfortunately, these barriers are all completely self-inflicted, and a lot of them have to do with the NHS. And I'm sure we can get into this more in the panel, but I can give you kind of lots of examples, such as when I watched a sort of research and ethics committee delay a phase 2 trial for oncology non-responders for a drug because they didn't like the font that had been used in some of the documents. But with a few small changes, the UK can and should and hopefully will regain its place as an excellent place to do clinical research, which benefits the public at large, certainly financially and health-wise. So yeah, thanks, and I'm happy to discuss further.
Fantastic, thank you so much.
Yes. Me next, yeah. Anyway, thanks very much for inviting me. So I got into healthcare kind of mid-career. My eldest daughter, who's now 27, was in hospital for 6 weeks, and partly I was very grateful, but mainly I was intrigued by how dysfunctionally managed the NHS was. And at that time, I'd had a background in consulting and turnaround management, and I was invited to join the turnaround team in the NHS Modernisation Agency, which didn't really turn around or modernise anything, but we had fun trying. I guess a couple of other experiences. I under the Blair government, ran a business called InterHealth Care Services, which delivered about 7,000 orthopaedic procedures for NHS-funded patients a year from sites in Kidderminster and Runcorn, and we achieved 99% net promoter score, great clinical outcomes, 90% treated within 7 weeks of referral. And as a reward for that, under the Brown government, we didn't get our contract renewed. So, I mean, that's one of the big issues for companies looking at investing in the NHS. If the NHS is your customer, you can be a political football. I actually then went to the dark side. I became a main board director at Guy's and St Thomas's, which was fascinating, but we haven't got time to discuss that. And then joined a German lab group called SynLab, who we worked with the Christian hospitals in South Essex to run their laboratory services, and left when their private equity fund sold them. But I think on this topic, I was going to use the German example. I got to know the German health system very well. And I think if you compare Germany versus the UK from both a doctor and a patient perspective, if you qualified as a cardiologist, a radiologist, or a histopathologist, or whatever in Germany, it is much more likely that you would set up your own or become a partner in a, Frankfurt cardiology practice, or a histopathology lab in Hamburg, or lease a scanner and become a radiologist in Munich or something, and you would be a small business. You would have to be accredited, meet quality standards, but then as a patient, if you need a cardiology, see a cardiologist or have an MRI scan, you would choose which of these providers you go to. They would all get reimbursed by the insurer, and so these small clinician-owned businesses are competing for the right to treat patients. They have to treat you quickly and give a good service and give good clinical outcomes, or people just vote with their feet and go elsewhere. The other very clever thing I would say about the German system is they have and because people say, well, that's great, but we'd run out of money. And what the German system does, which I think nobody really talks about here, is they have a floating tariff. So if Bavaria says we're going to spend 500 million euros a quarter on radiology, for example, and the tariff for an MRI scan is 150 euros, and all the bills come in, and it adds up to 520 million. They go, oh, we don't want to overspend by 20 million, so we'll just knock 4% off everybody's bill, and we'll balance the books. But so essentially, all the providers are competing to do as much activity and attract as many patients as they can. But with this floating tariff, which they can adjust by up to 5%, the system never overspends. And so I think it's always interesting to talk to people who have lived in two countries for a period of time. So if you talk to British people who've lived in Germany, or Germans who've lived in Britain, about the comparative experience with the system, I haven't met anybody who thought the NHS was the better system yet. So I'll pause for thought there.
Thank you so much, Dr. Chan.
Thank you for having me. I think it's been a fantastic conference today. What I particularly echo is in the beginning, the notion of that how clinically owned enterprise should be the model for the future of healthcare in the private sector. Because with clinical ownership, you generate a very different set of behaviors. For example, you're more likely to integrate, you're more likely to innovate, you're more likely to look at how you transform pathways and how you look at cost control. Because simply as private providers, you cannot operate in financial deficit. That just doesn't happen. It cannot happen. So with that notion in mind, I think it's a good starting point of discussing this topic. Now, I feel if we are to look at the enablers of the private sector, at this moment in time, we need to look at how we continue to make sure that NHS is sustainable, particularly in general practice. Because if you don't have a sustainable general practice, then what do you have? You have a private sector, then de facto, you just have a private sector of general practice. That simply wouldn't work, because then you undermine the whole notion of free at the point delivery. Then the whole NHS will need to change. Then in order for us to look at the sustainability, we then need to look at the current pressures of general practice. As of March this year, general practice have provided 388 million of appointments. That's a record number compared to before the pandemic, around 312 million. That's a 24% increase. And the interesting part is, despite the continued pursuit of increasing access, if you look at the clinical outcomes, I would argue it hardly changed. Likewise with the life expectancy within UK. So the question is, why are we doing the same thing when it's not working? And we're spending more and more money into it.
And not just the front door demand. We're also seeing a continual increase in the promotion of use of digital enablement. For example, using online triage, which is a fantastic thing for workflow. However, the word triage tells you something. You have more demand than what can be met systematically. And that is going to continue to balloon over time. And this is going to be an ongoing concern. And that's just the front end in terms of demand. And if you look at the back end, is the referral to the services in secondary care. In secondary care, because of the ongoing and continual climbing in elective waiting lists, we had a good run of 6 months of reducing it. But now it's gone back up to around 7.22 million. And at the moment, I can't see any immediate measures could change that. So the government or the NHS has introduced the advice and guidance mechanism for which to make sure that you allow GPs to provide advice from specialists. But at the same time, those activities will go back to the GP and you're holding a clinical risk when these patients are supposed to be seen in hospital. So my analogy to this is a pressure cooker and the pressure is building. And over time, something will give. So unless we see a policy change or a change in the financial model, particularly when the forthcoming neighborhood contract comes out, you're seeing there's no other way to decompress the demand from general practice unless there's private provision. But at the same time, if you have such a NHS that fully commits to private, then the question is, what happens to primary care in general practice? So I see the importance longer term is how we make sure that the current partnership model remains sustainable, because the behavioral change from private sector will also change the mindset of NHS general practice.
Excellent, thank you so much. Starting with Dr. Chan, do you want to tell us a bit more about your experiences and maybe explain a bit more about the super surgery model? How it came about a bit, and then also the kind of wider advantages it gives to the NHS, and particularly because general practitioners, GPs are the front line for so many people's healthcare, and it's really where the vast majority of people interact with the NHS. What has stopped more super surgeries popping up, and then also what could this government, a future government, do to really support that kind of frontline provision?
That's an interesting question. So if I'm honest, we are starting to see more and more super practice spawning around the country. If you look at the number of general practice closures throughout the years, in 2015, you got around 7,600 practices. Now we've got around 6,300. So where does all these patients go? What really happens is when you have a closure of a practice, they would call it mergers. The mechanism by a merger, because those patients will have to be displaced to somewhere else. And those practices will suddenly become bigger. And when that happens, you've got more patient to GP ratio. And straight up, I wouldn't even say that would cause a deterioration in quality of care, but will lead to a deterioration in satisfaction because of the demand would outstrip the demand there is. And also, if you look at the number of GPs comparing to a full-time equivalent GP partners compared to now and back in 2015, we had, I would say, that's almost 20% or more reduction. And that's quite significant. So a lot of GP practice that didn't form because they want to, sometimes because they have to. And often because GPs are very entrepreneurial and they will see this as an opportunity to change the quality of care and change internal pathways. But there are different models of how super practice come about. And how we did it was because of multiple traditional issues of last man standing in some of those practices, retirements coming up. So it was, again, looking at how we look at the sustainability aspect to continue growing at the same time as we are dealing with the demand within the local population. And that's what we did. We merged in 2017, started with 38,000 patients with 6 practice. Now we are 55,000 in population and A sites.
And just speaking about kind of GPs in general, do you find that, I don't want to say ideologically, it's not quite the right way to put it, but do you find that their mindset does support innovation, new ways of practicing, new ways of organizing, or do you find that there's actually quite a large resistance from, you know, kind of GPs at mass?
I would say GPs are the most innovative because they're using the natural agility being an SME. They can make decisions quick. They can incorporate technology quick. They don't need to go through procurement processes like you would with central NHS, which go through committees or over committees. It doesn't happen. They can make decisions quickly and can transform the care at the front line.
Can I just add an anecdote there? So we work a lot with primary care and with, you know, NHS secondary care for research. And essentially what we're doing is, you know, we're contracted by a pharma company to run a clinical trial. A lot of that trial will take place at physical sites. So they might be primary care sites or they might be NHS secondary care sites. And the difference is night and day. Having to work with, you know, primary care, as you say, you know, you can just be pragmatic. Everyone's kind of aligned on the shared goal, like let's get this started up as soon as possible. Whereas, you know, so we could get, and we have had, I don't know, 30, 40 physical primary care sites set up in a matter of a few weeks. Whereas to get even one NHS site set up can take 5 or 6 months.
It's like trying to get an appointment at the NHS.
Yeah, yeah. I mean, it's really staggering.
Is it,
and there's all sorts
is it bureaucracy that causes that resistance?
So it's a combination of like bureaucracy and just no incentive. So you know, effectively with the clinical trial, we and a pharma company are offering to pay primary care or the NHS well above market rate to do ordinary procedures, to take a blood test, to, you know, give a patient a CT scan, whatever. With primary care, it's great. Okay, here's the contract. You know, done. Whereas with the NHS, it is just this, you know, insane kind of series of false dawns. Oh, you now need research. All your staff need research passports. Oh, you know, this person's waited. You need a separate contract over here. And just this never-ending farce. And we're literally trying to pay them above market rate to do their normal jobs. And so it's, yeah, you know, I think that's the probably the single biggest factor cited when, you know, you talk about research moving to other countries is it's just so difficult to work with, and particularly to contract and set up NHS secondary care sites. And unfortunately, you know, as you probably know, there's lots of great, really well set up primary care sites for research in the UK, and I think it's an increasing, or we seem to see a lot more sites also in super practices. But often there are just, you know, certain patients or certain procedures that you just have to go to secondary care for, and they're kind of forced to.
I mean, I was really shocked in your opening remarks where you spoke about the fact that we dropped from kind of top 5 or 5th in clinical trials to kind of 13.
Yeah.
Why have things gotten worse?
Yeah.
Or is it that other countries have just gotten better?
I think it's a mix, and I think the UK was like 3rd in like 2018, and now it's sort of 11th or something in clinical trial patients enrolled. Yeah, complex answer to that. So firstly, you know, due to Brexit and the MHRA separating from the EMA, the MHRA are actually really good. So they're way better than the EMA, and they're kind of, you know, on a par with the FDA in terms of how forward-thinking they are, how permissive they are, et cetera. But unfortunately, they, I don't know whether this is the MHRA's fault or someone else, but kind of post-pandemic and post-Brexit, there was a massive backlog at the MHRA for approving, you know, new clinical trial starts. And there was a massive kind of reputational fallout among international pharma companies who were just all of a sudden seeing, you know, MHRA approvals take 6 to 9 months when they normally take 30 days. 30 days is really fast compared to certainly the EMA or the FDA. And so that was a bit of a reputational hit. And then over the last really kind of 3 years, the NHS contracting problem seems to have got worse. And there's no one cause, but there's just a complete lack of standardization of contracts across each trust. And so you just have to go through this incredibly manual one-off process for each one. And you're dealing with people where there's just no incentive. And what we resorted to doing was we would send, you know, our nurses physically to these NHS sites, like with paper, with printers, to like hound the people they needed to hound to get, you know, this form signed. To often it would be like, oh, I can't print this out because my printer doesn't have paper. Okay, well, I'll go get paper for you and like print it out. Like crazy stuff. And that's, you know, ultimately how we managed to get these sites set up faster. But yeah, all of that, unsurprisingly, does not exactly, you know, recommend itself to international farmers. Final thing is just NICE is often a late adopter of new drugs and new medicines. And so part of the rationale for running a clinical trial in a given country is just like pre-marketing for when the product is approved. And if, you know, NICE and the NHS are not great customers of new medicinal products, again, less incentive to run your trial here. So, yeah.
No, that's very interesting. Hugh, you work with you know, the all sorts of healthcare business and
some of the NHS.
And the NHS as well. You know, one of the recurring things from whether it's Channel Mary has been incentive. Have you found that just the major issue is there is just no incentive structure within when you do work with the NHS, and then with the private healthcare companies, do you see it's that incentive structure that just makes the biggest difference?
Yeah, I mean, I think there is an issue if you are a director of an NHS trust. A kind of good outcome is you get to 60, you get a gong, and you get a nice final salary pension, and you haven't got share options. There's not a lot of incentive to take a risk is the first thing. The second thing is how, you know, if you were running the local branch of Tesco's, your bonus and career progression is basically getting more customers to go to you than Lidl or Sainsbury's. If you're an NHS trust director, screw the patient, you know, getting more patients, probably a bad thing, you're going to run out of money. There's no reward for giving good patient service, getting good clinical outcomes. It's all about keeping the sort of middle ranking, you know, NHS regional apparatchiks and ultimately politicians happy. So, I mean, there's a fundamental misalignment of incentives there. There are a lot of misaligned incentives about, you know, doctors getting a lot of extra money, not only for private practice now, but also for doing NHS waiting lists at private hospitals or through insourcing companies. I guess getting back to sort of the German example, I do a lot of work in pathology. So an NHS histopathologist in their salaried 10 PAs, 40-hour week, on average reports about 4,200 histopathology cases a year. Their German equivalent, who's a partner in a lab, is doing about 15,000. So we're not talking like a 10% difference. We're talking about a factor of more than 3 difference between being a salaried employee who's hiding behind a Royal College guideline of how much it's safe for me to do versus an entrepreneur who's got to work hard to make a business profitable. So I think within the NHS, there's a whole lot of lack of incentives and perverse and misaligned incentives. And yeah, I mean, private businesses. I think one of the other differences I think is important, a lot of private providers of NHS funded services, the hard bit is getting a contract. You know, you win the right to do service X in, you know, ICB area for 5 years or something. But once you're in there, there's not then a lot of incentive on you to do a good job because patients don't have a choice. You've gone from a, you know, NHS owned monopoly provider to an outsourced private monopoly provider who still doesn't have an incentive to do a good job really, other than maybe, you know, 3 months before the contract gets renewed. I do think the kind of the system you have in a lot of places, and you don't need to switch, in my view, to well, I do agree with what Christian was saying about social health insurance systems generally get better outcomes, but I don't think you actually need to go through that pain to get there. You just got to give patients choice. If you give patients choice and people are competing for the privilege to treat patients and they're there in kind of perpetuity, not just for 5 years till the contract gets recommissioned, you would get incentives. So I think the incentives on a lot of the private providers, you know, where you've got a 5-year contract, are also not that strong either.
When you're supporting private providers who are entering the UK market for the first time, are they shocked by how bad it is, how bad the regulatory burden is, how bad it is to get anything done? And are they shocked? I mean, I guess it depends a little bit on what country they come from, but the vast majority of countries, I imagine, run so much better than we do.
I mean, that varies. I think various things shock them. I mean, a slightly different example. I got a lot of I do calls through something called JLG, where people want to talk to supposed experts, if I can call myself that. But I had a sudden spate of about 17 calls from basically bond investors who were looking at buying in the secondary market bonds of a company called Vianet, who own a company called Spar Medica here. And I don't know if any of you know, anybody heard of Spar Medica? I think they're a phenomenal business. They, from 10 years ago, they were doing about 1 or 2% of NHS-funded cataract surgery. I think last year they did about 32% of NHS-funded cataract surgery. Their guys do 25 cataracts a day. Probably the NHS average is 8 or, I know we've got an NHS ophthalmic surgeon in the audience somewhere, might be 8 or 10. They actually get good clinical outcomes. They are 15% of their procedures are done by trainees. I don't have an interest in them. I just have a huge respect. I think they run on similar lines to the orthopedic business I ran. But a couple of changes to them, or 3 changes really. One is that the NHS arbitrarily last year decided to cut the routine cataract reimbursement by about 19%. And Spar Medica were making a lot of money and probably will still make some money, but that was an arbitrary cut. No sort of, we might cut it by inflation minus 2% every year for the next 10 years, one-off 19% cut. The second thing is ICBs, integrated care boards, now have the right to limit your volume. So if you're, I don't know, Spar Medica Southampton, where I live, last year, they kind of said, you've got an indicative target of 6,000 cataracts. You did 7,000, never mind, we'll pay you for the extra. As of the 1st of April, they might say your target's 5, your limit is 5,500. The minute you go over that, you don't get any more money. And the other thing is the NHS, which I think is kind of completely contradicts the basic human purpose of healthcare, is imposing minimum waiting lists. So you might have somebody who needs
minimum
waiting time. So they might say, to save money in theory, so they might say, you need a cataract replacement. These guys have got the capacity to do it, but you've got to wait at least a minimum of 16 weeks to get it because we don't want to pay until then. And so
what a fantastic way to run a healthcare system.
I don't know why this has not been more publicized. I find it shocking. But you explain the combination of these factors to people in other countries who are looking at buying bonds in this company. They're going, you're having a laugh. It's serious. And people, I think those sort of people find it difficult, and you can kind of gradually hear them sort of saying, maybe I'll steer this. Maybe there's a reason why these bonds are 86 cents on the year. And I think that, again, this is almost punishing a company for being too successful. And because at the same time as cutting the cataract tariff by 19%, they put up the tariff for all the complex stuff so that if you're an NHS trust, who are the only place you've got the equipment and the backup to do complex procedures, you're not worse off. It's blatantly designed to hit independent sector. And I think the fact that, arbitrary political decisions can suddenly massively disadvantage private providers is a big turn off to going into, NHS funded treatment. Again, people are selling AI or Chinese PET CT scanners is a recent one, or people delivering other sort of services or products to the NHS. They're sort of less put off by that, but I think people are very frightened by the politics around the service delivery.
I can imagine. So speaking about the kind of attractiveness of the UK, Mary, Linda's had to secure investor funding. How easy was that as a healthcare business based in the UK?
Yeah, it probably would have been easier had we been based in the US. But now a great majority of our revenue comes from running clinical trials in the US on US patients with US pharma companies. It wasn't that way at the start. It was mostly UK. But yeah, I think there's generally a perception that in healthcare, in life sciences, the US is the market. That's not just the perception; it's the reality, right? I mean, every healthcare, virtually every healthcare market is per capita 2, 3, 5, 10 times the size in the US compared to Europe. So yeah, I guess we were lucky though that the regulations for clinical trials are pretty harmonized cross-border. So the high-level things like ICH clinical practice, that's pretty much standardized internationally, but there are kind of foibles per country. So yeah, but it wasn't a massive impediment, let's say. Yeah.
So this is about the blockers and enablers, and we've spoken largely about the blockers. So let's talk about some of the enablers. So Dr. Chan, what would you say is one of the biggest enablers and something that we could push, support more for the success of super surgery and the success of the kind of work you're doing?
Well, it's more about if it's not super practice or small practice, it's about general practice as a whole. If you look at the activity from general practice, it accounts for 90%, 92% of the entire NHS, and the funding stream is around 7 to 8% annually. When in the latest 10-year plan, it is about how you move activity towards primary care, called left shift. At the same time, not only you want GPs to be part of a treatment model, you want them to be social care, at the same time prevention. So, but there is no reciprocal increase in funding for that. If anything, if you look at GP core contract, throughout the years, if you factor in inflation, factor in NI contribution and minimum wage hikes, then they're actually making a loss over time. So the expectation is increasing. And how do we make it better is a question. Funding is certainly one. Reduction in the red tape is another one. So there are a lot of targets being asked of not just primary care, but secondary care. And these targets, a lot of times, do they actually generate a genuine improvement in the outcomes? I don't see them. They became more of a tick box exercise.
What kind of targets?
Well, waiting list for one, and also about access. Well, general practice has delivered the increase in access, but the access increase doesn't become the sort of improvement in patient satisfaction. And why is that? Because you're moving care or medical provisions to become a more transaction relationship. And that's actually harmful longer term. So when we talked about, okay, should we look at a co-payment system? And a number of interesting conversations about that. So how much are we going to charge? £5? Heard that number before. Why are we charging £5? Why not £10? And if the argument is for to reduce misuse or people think twice before they use, then we're using a monetary reason as a behavioral modifier. And that in itself, is it the right way of doing it? Does that create more tension between the politics behind it, the NHS, and the patient themselves? So I'm not saying it can't work. It can work, but it comes down to, I would say, smart exemption. But if you want a lesser controversial model, then you really want to push for a private sector in its entirety, because you can still make it work. Particularly if people who can afford it can pay for it. And some say you're creating a two-tier system, but then doesn't that two-tier system already exist?
Yeah. And wouldn't it be nice if one of those tiers worked well?
Absolutely. It already exists. The key question is not about a two-tier system. It's more about when that activity has moved to a private sector, the capacity remaining as a result of that, in monetary terms, they shouldn't be classed as savings. They should be recycled back within the NHS to provide for the people who needs it. Then you have a true redistribution. And that's what can make it more sustainable. And that's probably how you receive a less tension overall politically.
Yeah, so would you support the Fantastic Prosperity Institute's kind of suggestion for tax relief on those who do take out private medical insurance?
Absolutely. There's got to be. I mean, at the moment, people don't pay VAT on private healthcare anyway, but it needs to be further incentivized, because how do you decompress demand in general practice? There's got to be other way than policy drift. It's got to be coming from additional capacity, which can only be offered by the private sector.
Excellent. And then, Hugh, what would you say is a big enabler currently, or something that we could push to really support both healthcare startups and new entrants to the UK healthcare market?
Yeah, I mean, there are a whole number of issues, but I do think a sort of move to this choice and any qualified provider for a lot of I mean, in some ways you already have it with some services. So if you want to pick up a prescription, you can go to, the GP dispensary, the local boots, the local Lloyd's chemist or whatever. And I don't hear anybody saying, gosh, couldn't get my prescription filled last week. We just take it for granted. But there are a lot of other services. I don't know, physiotherapy, for example. Why do you have to wait a long time to see an NHS physiotherapist? Why can't?
And then it's online.
As in a lot of countries, well, it could still be online. I've done online physio during COVID. It was great, but why can't you just choose any qualified physio who's willing to treat you for whatever you decide, £25 a half hour for a tariff? I think that would create a lot of and do they minimize the bureaucracy that a business, if two physiotherapists want to set up a business to do that, make the business, make the barriers proportionate. If you look at some of the NHS tenders, you've got to have Cyber Essentials Plus, your carbon net. I kid you not, you've got to have now it used to be a 36 million threshold. Now everybody has to have a modern anti-slavery policy, and you've got to have a sustainability plan, a carbon net zero plan, a business continuity plan, and it drives up costs and things like NHS procurement frameworks. They think they're being clever and saving money. It probably adds 15, people providing services have to add the cost of that bureaucracy into their service.
With a lot of this bureaucracy, is it coming from the Department of Health? Is it coming from the regulators? Would there, the Prosperity Institute have a fantastic suggestion to bring, the vast majority of the regulators back into the Department of Health? Would that help things so at least they are accountable?
I think it's much less regulation, and it's, being CQC, it has a lot of faults, but if you want to set up a dental practice or something as a CQC, it's not that onerous.
Mm-hmm.
I'm not saying it's very effective or very well regulated, but that sort of regulation isn't there, and it's right, you should have to meet certain standards. I think it's more about procurement people, requiring that every tender you have to demonstrate what you're doing for apprentices and what you're doing for carbon net zero when you're a 2 or 3 person business. I mean, it is just, if I wasn't sort of dependent on trying to win some of them, it'd be tempting to publish some of these things. The public could see what a load of bollocks. Using that word, I can't think of a better word. Some of these tenders are, and it's just bureaucrats creating work to keep themselves looking busy. That needs streamlining. And why does every trust and every ICB, there are multiple frameworks for things, and they're all slightly different. Tesco's don't let every store manager deal with Procter & Gamble. They have somebody central working out the policy and doing it. Why we have massive duplication in the NHS. So that it's sort of, I think it's more bureaucratic than, the clinical regulation is not disproportionate. It's just the sort of procurement bureaucracy, really.
No, that makes a lot of sense with the bureaucracy that exists, and then also, it's crazy with the healthcare system now that we don't actually have a standardized form across so many of our providers. Mary, you interact quite a lot with regulators, because clinical trials, understandably so, are highly regulated. How have you found your interactions with them, and have you found them to be enablers, blockers, and who's the worst and best of each?
Yeah, God, okay, yeah. So I generally think that the regulations aren't as much of a barrier as people assume in clinical research. The FDA in particular are extremely forward-thinking. They've just published some amazing guidance. So Bayesian methodologies for clinical research, that's huge. They have a new pilot on using AI to do real-time clinical trials, which is incredibly cool. A bunch of other stuff we make use of around decentralized trials, remote monitoring. You can do all of that, well, minus the Bayesian part. You can do all of that, or all of that is pretty supported by the MHRA, nowhere else in Europe. And so the MHRA generally are sort of pretty good. I think when you get down to specifics, I talked about a lot of the bureaucracy that we face at NHS trusts, and I don't think that's a regulatory thing. I sort of agree with you, Hugh. That's bureaucrats doing their thing. Maybe one area where UK regulations are a bit challenged is around ethics committees. So before research can start, you need to have an ethics committee kind of opine and say it is ethical. And in the US, these ethics committees are actually privatized. They're heavily regulated, but they're privatized. In the UK, they're sort of public bodies, and they're staffed by volunteers. Now, what kind of person do you think volunteers their time to sit on a research and ethics committee council? It's exactly the kind of person you're all thinking of. It's like that hellish Hanforth Parish Council video on crack. It's, you do usually have like a few clinicians who are sensible, but then you just have like complete freaks. And we've had like we were running a trial for a new diagnostic for STIs, and we had someone who was kind of a fundamentalist Christian object to the research on the principle that a better STI test might lead to more people having premarital sex, right? And so that was that was one. And I mentioned the anecdote at the start about the ethics committee objecting to like the font someone had used in a document. And
how bad was the font?
I didn't even know what font it was. This was relayed to me by one of my colleagues. But this kind of thing. So yeah, there's definitely pockets of just like nonsense that we can strip out. But generally, actually, I think the regulatory bodies are pretty good and are pretty forward.
And why do you think they are pretty good and forward thinking compared to some of the other bureaucrats or other bodies?
So I think you genuinely have pretty smart, competent people in leadership positions. So I was at an event with the head of the AJ. His name is Michael Tallow, I think, the head of the MHRA.
Lawrence Tallow.
Sorry, Lawrence Tallow. Yeah, and he was he was a very good person. I think the challenge is, and I've seen the same thing in the MHRA and FDA, is that you have sort of like very kind of forward-thinking folks at the top, but then the people that you might interact with as a drug company, submitting your clinical trial design for approval, are more conservative, and they're can be more difficult to deal with. But yeah, why are they so tough? Part cynically, I think that if you make it to the top of somewhere like the FDA or MHRA, you can basically walk into an extremely high-paying job at any pharma company afterwards. And so I suspect that an element of it is it is effectively a very high-status, well-paying job, and so there's good competition. But yeah,
excellent. Well, thank you all so much. We're going to go to questions from the floor now. Fred?
Mary, you talked about AI in clinical trials. Could you tell us more what role it is playing and what role it is playing in your business?
Yeah. So look, I think like the average drug costs about $1.5 billion in clinical trials to develop once you amortize it across the failures. And I genuinely believe that 60-70% of that cost can be effectively automated by AI, and we're seeing a lot of that today. Clinical trial is just this sort of it's a process, right? So you're basically setting up a process, getting patients to where they need to be, collecting data, monitoring that for various clinical data things, and then analyzing the data, and all of that is like eminently analyzed by AI. So specific. So firstly, we use AI for document generation. AI is really good at generating documents, sticking to an approved template. We then have our human experts review it. It's also really good for like patient-facing materials. It's pretty hard to write medical concepts in simple language that patients of 9 reading age or whatever can understand. But AI is very good at that. And then we have AI for clinical trial monitoring. So this is an area that like consumes about 25% of clinical trial budgets. And the traditional way you do this is you send people physically to these sites to like look at pieces of paper and do double data entry. We use AI for all of that. So the AI looks at the data, tries to spot patterns in the data that indicate something might be going wrong. And then finally, we use AI for like data visualization and sort of reporting. But we're just scratching the surface and lots more to come.
Where do you see it going in the kind of medium-term and long-term future in terms of AI within?
Yeah, so I mean, the FDA is this really cool AI pilot, and this really took me by surprise for a couple of reasons. So in this pilot, they basically have the clinical trial running. It's in oncology, even, which is like the hardest space to run clinical trials in. So they have patients going into these sites. The data is being captured at the site, and the data is going straight to the FDA, where the FDA is kind of, they say they're using AI to analyze it. No other details provided. But like that should genuinely be feasible. And I think if you can mandate better standards for how that data is captured, so like avoid paper, use standardized systems, that whole loop becomes much more feasible, and you can massively accelerate the time to getting new medicines to patients. Yeah.
Excellent. Hugh, Dr. Chan, do you have any comments about the way in which AI is being used now, whether it's private healthcare into the UK market or within GP surgeries, and where you want to see it go in the future?
I mean, I've had some exposure to it. So, for example, again, in pathology, things like a prostate biopsy might take an hour, hour and a half for a pathologist, and there is an AI tool that costs about $25 a go that probably brings that down to 20 to 30 minutes. And it, you know, pathologists who use it love it because you don't have to look at 36 cores and, you know, it will just say, I've looked at it. You really want to look at these three and particularly look at that bit there kind of thing. And, you know, I did work for it's actually a lot of AI comes out of Israel. This is an Israeli company called Ibex. I did help them get in the UK market, and I think they were about to get their 4th installation after 6 years. And, it should to me be a no-brainer, $25 to save 30 to 40 minutes of somebody who's costing you £150 an hour. Why has the uptake been so slow? I don't know. I mean, okay, medicine is quite conservative. Actually, on trials, I did hear the other day that somebody was talking about AI looking at patient records and working out which trial a patient might meet the criteria.
Yeah, we do that too.
Yeah.
So about AI, I see there's going to be an increasing use of AI for sure. The question, it's about trust, because when AI is applied in healthcare, it comes under the level of safety it can provide, particularly the risk of AI hallucination and AI drift. So unless these fundamental issues are resolved from a governance perspective, then the rise in AI will be curtailed because of the inefficient of trust within clinicians. But it is an efficiency tool. We should embrace it, but it's how we do it. And that's why if you look at the way NHS adopt previous digital solutions, they are very conservative.
Yeah.
And therefore, some argue, why is NHS operating using a very obsolete digital infrastructure? There's a reason for that, because it's about safety. So on one hand, we want to increase the productivity of NHS. At the same time, we've got to think about how we balance that with trust and safety.
And do you think the pendulums have shifted too much towards safety?
It has to be, because it's healthcare.
Okay.
Because the ultimate owner of that risk is the clinicians and also the organization.
Yes.
Hi there, Tim Reed. Just following on this point about AI, in my role at Lambuson, I've hosted a number of sessions on AI usage in healthcare, and I think maybe one of, so if not a quick win, something which definitely requires a solution in relation to how it's used in clinical practice. And Dr. Chan, please tell me if I get this wrong, is that if a surgeon uses a scalpel in an operation and it breaks, the surgeon is not responsible for the fact that the scalpel has broken. That is a defect in the medical product, and the surgeon wouldn't be held liable for that. I mean, it's possible a claim might be brought against the hospital, but the individual surgeon they're not at fault for the scalpel breaking. If you use an AI as a decision-making tool, and the AI, and you use the AI solution, and that solution is incorrect, say it's hallucinated, then the responsibility sits with the clinician. So I think there is a regulatory grey space there, which is still to be kind of worked out in relation to how clinicians feel comfortable using AI in their decision making, because there's obviously the safety issue, but there's also a liability question as well, as far as I understand it.
If I may,
of course, John.
So with AI, because the rapid advent of AI within healthcare, we are seeing more practices and PCNs are required to adopt the relevant governance behind it. For example, like the DCB 129, DC 160 compliance, that you need a clinical safety officer for your organization responsible for digital infrastructure. But general practice is largely lagging behind in that regulatory framework, because you got to train for that, and it takes time for people to train in it. So that is going to come, but the key issue isn't about how you use AI. It's about, there's no one-size-fits-all approach. You cannot use one digital solution to solve all problems. Even an exact same problem in one practice might be different from a different PCN, different for another practice, because of the demographic difference and how they operate in a different way. So, the challenges in a rural practice to a inner city practice are very different. So if you're trying to adopt a system which can solve all, that will simply not work. That's why NHS is adopting a very vibrant aftermarket or marketplace for this solution. And I think that's the right way to go.
Thank you. Lord Kamal?
Thank you. By the way, please call me Syed. Only call me Lord Kamal if you're angry with me. I just want to continue that point on AI, because we've looked at this when I was a minister and now as a shadow minister. And a couple of things. One is we have to be quite clear what we mean by AI. Are we talking about AI being purely machine learning, so looking at large set data sets and identifying patterns, I think as Mary said, or are we looking at actually algorithms that rewrite themselves, if that makes sense? So, for example, an Ocado warehouse AI, it rewrites itself. That, I think, for the sake of safety, we can't do that. I think what happens in healthcare, it helps the clinician to make a more informed decision. At one stage, that was the sort of conversation we were having, because we were really concerned about safety. The other concern we had was that AI helps the clinician to make a better informed decision based on large data and patterns, but you have to be very careful about automation, and you need a human backup in case something goes wrong. You don't want someone to get into some sort of doom loop. Quick example: I applied for a Monzo account. I was supposed to get a result in 48 hours. 2 weeks later, I got a message saying, we've declined you, and we don't have to tell you why by law. That might work with Monzo. That can't work in healthcare, if that makes sense. So that's why we have to be extra careful with healthcare. It's just an observation. I don't know whether anyone wants to comment on that.
Yeah. So I think that's a very fair point, because if you're looking at AI, are we talking about we're using large language models? And if we're using it, what are we using for? Are we using it? Depends what solution we're talking about. Some are using for pictures-related interpretation. Some are looking at result interpretation. Some are simply using it for orchestration, so or workflows. So the problem is how you're using it. So if you're relying on certain interpretive framework, then you're at risk of a drift, AI drift, or the hallucination element. So it's how you work with AI to make sure that doesn't happen, or how you apply your large language model. If you use that as an engine and you go a wrapper model around it, then it's how you apply it. So I think there's a lot of work being put into that, but there are some fundamental issues with AI still needs a regulatory framework to make sure that it complies.
Excellent. We have time for maybe one or two more questions, if anyone has. Yes, Reese.
To carry on the AI theme, since we're dining out on it, Hugh, you were asked about what shocks overseas entrance into the market. A lot of chatter about companies being unwilling or uncertain to enter the UK because of our uncertain AI regulatory regime. Currently, we're ahead of the EU, freer, easier to do things. EU alignment kind of puts that in jeopardy. Are AI concerns relevant to your healthcare clients?
No, I don't. I think it's more kind of political whim that tariffs and things are going to get cut, or contracts will end when political parties change, that sort of stuff. I think probably we're seen as, from I wouldn't say I was an expert, but I think people see the UK having coming out the EU. If there is a small silver lining, it's probably implementing things like AI may be easier here than it is in the EU. So I think that AI is, we're ahead of the EU on that from AI companies' perspectives, and we have worked with various AI companies in diagnostics, and they're looking to launch UK ahead of EU for that reason. So.
What's the situation like in the US with the way they're trying to use AI within healthcare?
Oh, I don't know that. Mary, do you know that?
No, I mean, it's pretty similar to the talking points we've had here, where you have calls for restricted models like open evidence, or more purpose-built healthcare models like open evidence versus general models like Claude. Mm-hmm. I'm actually just going to slightly disagree. I feel like we've agreed too much as a panel, so I slightly disagree, Dr. Ian. I mean, I think in my view, the models are evolving so quickly that to get the best outcome, to avoid the types of situations like you described, you just need to use the best model. And so the more kind of barriers you put up and the more structure around it, if that keeps you using suboptimal models, then the outcomes, you will just have higher rates of hallucination, which is somewhat counterintuitive. And actually, I mentioned open evidence. So this is like one of the leading kind of clinician-specific models out there built to be, by clinicians for clinicians. And, they consistently perform worse on all of the medical benchmarks than just the latest model of Claude. It takes them a few months to catch up. And so, yeah, I just think we need to be aware of that. Yeah.
What do you think about, Dr. Chandler, just finish that element of trust? Because the public do really need to trust the health service, even if, AI might give better outcomes in certain areas.
Yeah, I just think it's important that the outcomes are better. It's an interesting question because I suspect that the public would almost or would have more trust in a system that had higher rates, but it was always like a human doctor at fault versus versus the AI. But yes, I'm not sure of a good answer.
Yeah, I think you're probably right there. Well, fantastic. Well, we've come to the end of the time. Thank you so much. Please join me in thanking all of our panelists. We've had an absolutely wonderful discussion about the incentives within private versus state-run healthcare, kind of the importance of patient choice, the UK compared to healthcare and developments in other nations. The kind of I think a very common theme was a bit of frustration with bureaucracy and the kind of lack of standardization across the NHS, and then a really fantastic discussion during the Q&A about the role of AI both now and in the future. So thank you all so much. Risa, are we going to a break now?
15-minute break back here at 3:45.
Excellent. Thank you, everyone.
Yeah, and I think it's the other way around. I never finished my doctorate. I worked with dealers. Some days do.
Okay. Hello. Thank you very much for joining us, and especially to the countless thousands watching online. As Steve keeps reminding, is monitoring the numbers eagerly. So this panel is on improving NHS management, which is a pretty big deal. So I'm Robert Colville. I'm director of the Centre for Policy Studies think tank. I'm joined by Dr. Doreen Birch of, make sure I get this right, CSO CERAC Life Sciences. Emmanuel Igwe of the Prosperity Institute, who would like to point out that the doctor on the screen is a PhD, not a medical doctorate. Just Caroline Elsom, who is now head of government reform at the think tank Onward, but before that was a special advisor in the Department of Health, and Steve Baker, a former Conservative MP and founder of Fighting for a Future. So on the topic of NHS management, I'll just start by sort of ranting slightly. When I started at the CPS 10 years ago, the first report we did was on, well, one of the first 2 or 3 reports we did, I think, was on NHS pay. And it was written by a doctor, a consultant, who sort of said, so I was like, hang on, let me get this straight. So there is no way for someone managing the NHS to incentivize people for good behavior. No. There is no way to vary pay between hospitals or disciplines. No. There is no way to vary pay between locations so that you can hire people in places where you're running short. No. There is no way to. There is an incentive scheme, but doctors vote on it themselves and give it to their friends. Yes, we have that. And every year, everyone gets an automatic pay rise under a system in which driving an ambulance is somehow considered to be sort of roughly equivalent, according to some mysterious formula, to typing a report if you're a physiotherapist. Yeah, that's basically how. So there is. It is the most fantastically and fascinatingly broken system of management. In fact, it's often sort of said it's quite hard to manage it at all. So I would be delighted if each of the panelists could set out in 2 or 3 minutes what their vision is for fixing NHS management, or even just what their sort of main complaints are with it. And then we can have an argument or a discussion, and then we'll open it up for questions. So, Drew, we'll start with you.
So I'm in fierce agreement with your conclusion there, but not necessarily the details of the examples you gave. And I was going to say some of the same things, actually, following on from Hugh, who said that the incentives aren't there for managers to manage properly. I'm always fond of the Charlie Munger quote that you show me the incentives, I'll show you the outcomes. And my minor suggestion for how you'd improve management in the NHS would be to give the managers the tools by which to manage. So you would be able to pay people differently. You'd be able to sack people. You'd be able to hire people more easily. And I think those would be relatively easy changes, which would probably require changes in employment law, which would improve the NHS or improve any of the systems that might replace the NHS. So you're right, I'm Chief Scientific Officer for a biotech startup called Serac Healthcare. I'm also a consultant physician in Oxford. You have to work quite hard to get your chosen consultant job. You will see people work quite hard to get their chosen consultant job. Once they've got them, you will see them relax a little bit. And it's, even if you try not to, it's very hard not to, because for the rest of your career, your pay will have no relation to how hard you're working. It will have no relation to the quality of the work you do. You can't be fired, except for gross misconduct, and you can't be promoted, which makes it very difficult for managers to have even a sharpened carrot.
And even at the start of your career, as of the last few years, if you work hard at medical school, you still get sent to wherever they want to send you. There's no actual merit component in the...
Yeah, they've utterly, in the name of making everything fair, they've reduced your ability to discriminate on the basis of whether someone's any good or not when it comes to prioritizing jobs. And that is bad. The one minor point I disagree with, your headline wage has got to be the same nationally. But I do little stints to vary things across the country, and it's very interesting going to work in a bad hospital. And I think all doctors should spend a portion of their time deliberately going to work in a bad hospital because it's eye-opening. But I also do stints in very rural hospitals up in the Highlands and Islands of Scotland, where they just cannot recruit people permanently because nobody wants to live there. But effectively, everyone there is a locum. You're on temporary pay, so you're being paid triple what everyone else is being paid. So there is an incentive there, but it's not an official one based on your headline pay. It's that everyone's on these emergency pay schedules. So while we pretend that there isn't a tool for incentivizing people, it creeps in by the back door. And you hear everyone complaining about how much the locum spend is in the NHS. It's because there's no other tool for incentivizing people to do the jobs that no one wants to do.
Thank you. That makes a lot of sense. I mean, Emmanuel, the Prosperity Institute has obviously come up with some proposals to accompany this conference on what should be done. So what are the headlines from your thinking with Nick White, who I know can't be here today?
Yes. I would say our offerings, I suppose, in this platform, which you pretty much have in your sheets, are reforms to basically performance-related pay. And this is where I may take a little bit of a challenge with Doreen's position on headline wages. This is in part because I think back in 2010, there was a very interesting research in the Journal of Political Economy by two eminent economists that tried to observe how pay affected recruitment in various NHS practices across regions. And what they found was that in places where you had, when you applied the sort of the blanket national NHS pay position, it was more difficult to recruit in places where you had the outside kind of market having a higher wage in comparison to what was available in in the NHS kind of environment. So in other words, the inability for NHS trusts to be able to openly compete to get people into to work for them, like nurses, etc. Yes, obviously it meant that you couldn't get as much people that you needed, but then obviously you could imagine the sort of the ultimate consequences of that, i.e., sort of mortality and all that kind of stuff. So that's one point that we raise in our offerings. We also talk about the importance of basically rescinding some of the reforms to IR35, the ones that came in 2017 and 2021, that basically just makes it creates less incentives for doctors to be able to work more optimally, to be able to actually pursue, as Reese had mentioned in the sort of our opening remarks, as something that they consider as a vocation, because they understand that they may just be taxed even more just by participating. And we could also extend this to the pensions and taper as well. The situation where over £200,000 threshold, where if you earn above that, you effectively get taxed an extra £22,500. I think, and that was 2024-25 figures. So some of these kinds of reforms that can be able to make it more attractive for people to actually work more, work harder, would be very important. How many have I mentioned so far? But yes, I mean, I could stop at that for now. But yes, this has sort of at least a flavor of the kind of ideas that we have in mind.
Thank you. And Caroline, speaking of managing the NHS, you were part of the Department for Health, which, as far as I could make out, due to the very peculiar structure created by Andrew Lansley, couldn't even manage NHS England, let alone actually managing the NHS.
Is this the part of the discussion where you asked me to make an apology at the outset for everything that I did wrong? I mean, there are three big things.
I don't think we can blame you for the Andrew Lansley rewards.
Yes, to be clear, I came in the post-COVID recovery era from 2022 onwards into the Department of Health, having worked in some other government departments. Now, safely recovering just a little bit further along the road at Ormond Think Tank. I mean, before we get into the sort of nuts and bolts meat of the arguments about how you can improve NHS management, I think there are three big themes that really struck me when this topic was posed, and I think that they really underline the success of any management reforms. The first is, as has already been touched on, we need to be really careful about how we are designing any new incentive schemes like performance-related pay, or indeed some of the learning some of the lessons of some of the COVID recovery programs that were put in place, like the urgent and emergency care, capital incentive scheme, or the targeted investment fund. There needs to be some genuine jeopardy for poor performance, rather than just a bonus for trusts that improve their performance. So I think I think we really need to dwell on how it normalised some poor performance in the post-COVID recovery era, and that shouldn't just become baked into the underlying baseline of the NHS, because it creates a sort of feast and famine approach where central NHS or indeed funding will suddenly go into a trust for a year or 2 years, and then as soon as that recovery period has finished, it will all just fall away, and the same bad managers or bad management structures will still be there at the end of it. So I think that's the first really, really fundamental thing. The second is that we can't just stop at the finances and the financial incentives alone if we want to fix how the NHS is managed. There was a sort of slightly sick joke within the Special Advisor Office when I was there, that I was the SPAD for national scandals and disgraces, because I would end up, if anything got so bad that it became a headline, that
But you weren't SPAD for Matt Hancock.
Well, very true. Very, very important to be clear about that. But if anything got bad enough, it ended up on my desk. And what this really taught me is spending an outsized amount of my time and energy working with ministers through some really difficult optics around various public inquiries, about rapid reviews, task forces, CQC Section 48 reviews, handling some of the most salient and delicate cases of the day, things like Lucy Letby, Valdo Calacane, David Fuller, the fallout of the infected blood inquiry, which was still ongoing, is that there really does need to be more accountability for where very serious wrongdoing has happened under NHS managers' watch. So it cannot just be the carrot, it has to be the stick as well. And so I think that we have to look at the whole stack of different steps that lead up to a public inquiry and how there can be better accountability all the way along the way, so that it doesn't just happen that while all the fanfare of a public inquiry is ongoing, all of the managers involved quietly retire or are shuffled through to a different post in a different trust, or indeed leave the country, as several of them have in some of the cases that I've mentioned. That there has to be a way of tying those people in so that we don't get to the point of a public inquiry in the first place, which is usually the only last resort left to compel somebody to go and give evidence there. So it's got to be the finance, but it can't just be the finances that are the key to NHS management. And the very final quick thing that I will dwell on is I did something very stupid in the last couple of days so that you don't have to. And that is that I went on Spotify and I looked up some of the biggest NHS management and leadership podcasts that are out there. You can do it yourself. I would not advise you, because by the end of just a few days of listening to them, I was in a blind fury at how much nonsense was being peddled about the priorities and the mission and the values of the NHS. Rather than, I was expecting to talk about things that probably many people find deeply boring, like electronic bed management or digitizing patient care records or theatre utilisation, the things that will make the difference for patient care going into the future. And instead what I got was people saying that the single biggest thing that they were focusing on as an NHS manager was about social justice and helping marginalised groups in society, or bringing your whole self to work. And it really just struck me that we need to take a really serious look at what managers in the NHS are being trained to do and where their priorities are. And I mean, it takes the whole destruction of the progressive ideology that has infected so many of our public institutions, but by far and away, the worst example is where this ideology has taken hold is in the NHS. And so I don't think we can fix NHS management without taking a look at that. And that starts with looking at what is in the NHS constitution and its accompanying handbook, which is a total mess and needs review. Anyway, I will stop my rant there for now.
Yeah, well, to be continued, I suspect. So Steve.
Rob, well, thank you very much. When I was a very new member of Parliament with very little experience, I met a politician from the Faroe Islands. And not knowing anything about the Faroe Islands, shamefully, I said, what are the top issues in the Faroe Islands? And he paused with a weirdly long pause and gave me an extremely old-fashioned look and said, at any given moment, the top issue in the Faroe Islands is fish. Now, as the former Member of Parliament for Wickham, I could give you very much the same answer if you asked me about the top issue in Wickham. For 14 years, it was the quality and availability of the services of Buckinghamshire Healthcare NHS Trust. And that's my qualification for being here. I want to give you 3 points from it. First, good management actually is possible within the NHS. And I think Druin indicated that. There are good hospitals and there are bad hospitals. There are many things I worried about during the COVID pandemic, notoriously. One of the things I did not worry about was whether or not the local hospitals were well led and managed. And I've told him I was going to mention him. So Neil MacDonald, if you've tuned in, thank you very much. Really brilliant leader and manager, is now working in Plymouth, sadly for those of us who still live in Buckinghamshire. But it's not always the case. When I was first elected in 2010, I had a growing dossier of never events, culminating in the death of Edward Maitland. His paramedic son took him into the hospital and said, you can't give him solid food. You can only give him this liquid food. If you give him solid food, because he's had a lot of his tongue removed due to cancer, it will kill him because it will go aspiration, pneumonia will go into his lungs. The son told the team that. They gave him Weetabix, it killed him. This was the moment at which I went tonto in Parliament and, cut a long story short, forced the Trust into special measures. Mortality was too high. They were just on the cusp. I forced them over the line by my actions. And they got turned round. Management failures, of course, were identified. Prior to my election, there was a C. diff scandal. 33 people died, about 10% of those infected. Again, management failures identified. It really matters. Poor management and leadership can kill. Second point, it shouldn't be down to the chance, the accident of the quality of the particular individual who happens to lead a particular trust or service or whatever it may be. I think we were blessed indeed to have Neil. Real genuine admiration from me for his leadership during COVID, because as a Member of Parliament, you get to talk to other Members of Parliament and find out how they're getting on. And we were doing very well. So how do you make sure it's not about chance? Well, yeah, it's about training. It's about culture. I care about lifting poor people up out of poverty. I care to make sure that everybody's treated equally and gets the care that they need. But we should be doing that by worrying about electronic bed management and whatever else, and not by obsessing about abstract political concepts. So I completely agree with you. But how we talk about these issues is going to be really important in order to be able to communicate with those who are fully bought into the crazy ideology which they obsess about to the detriment of patients. So we have to change incentives. There are two ways to organise society fundamentally, either the political way, which is rule following, bureaucracy, or prices, profit and loss and voluntary exchange. The NHS, or however we organise healthcare in the UK, will always be caught somewhere between them. But the more we can have prices, profit and loss and voluntary exchange, the more I would suggest we get the right incentives around people to deliver, to attract capital in, so that no longer in Wickham do you end up with operating theatres that can't operate alternately because it's too hot or too cold. You need a modern theatre that just got two modern theatres next to each other, operating continuously with a team going to and fro, for example. And the third point I'd make, it's a two-way street with politicians. I fought 5 general elections. At every general election, the main issue was get A&E back at Wickham Hospital. It's a classic DGH in decline. People will know that it used to have A&E when the treatment for heart attack was bed rest. Now you're 10 times more likely to live through the cardiovascular unit in Wickham Hospital, but it hasn't got A&E over the door. That's all people care about. It's a two-way street. On the one hand, I would plead with doctors, let us call the urgent treatment centre an A&E class 3, and then you've got A&E back at Wickham Hospital. And then we can have the conversation about what is actually available and say to people the truth, which is that complex trauma will always be in Oxford and Southampton in this region because of footfall, blah, blah, blah. But for 5 elections, I was honest with the public. In the first election, I said, no stone left unturned in the search for blah, blah, blah. The other 4 elections, I just said, we'll never get A&E back. This is why, you're 10 times more likely to live. But it's a two-way street. Politicians must serve NHS managers, not by representing what they say, but by dealing honestly with a public who naturally do not apply all the attention that they might to the detail of how the NHS is organised. Politicians have to play fair, and NHS leaders should give them the equipment necessary to do so.
Well, so to add a topical flavour to events, Wes Streeting has just resigned, as I wrote in the Sunday Times, basically leaving the NHS like a Jenga tower that's had most of its pieces torn out. I mean, there was a bill. I don't know if anyone else has read the bill going through Parliament now, but it basically starts with like, line 1, abolition of NHS England (brackets country's largest wango spending £200 billion a year). Line 2, fundamental purpose of NHS Trust. Line 3, fundamental purpose of NHS GP officers. It is pretty foundational. He's walked away right in the middle of it. Keir Starmer bizarrely offered the job to Angela Rayner. I don't think the idea of a health system like designed by Wes Streeting and implemented by Angela Rayner. I mean, but it feels like we've gone from we've agreed that it's a bad idea to have NHS England running the show.
Yes.
The new idea seems to be a combination of let's have Department of Health running the show, but let's also do the Gove reforms and empower individual hospital trusts. There's other ideas about older ideas about money to the patient and internal market stuff. Like, I mean, this is obviously horrendously complicated, but in a very rough sense, what do you think is going to happen? Do you think this current blueprint can work, and what do you think a better one would look like in terms of how those incentives cascade across the system?
This morning we heard 2 different accounts of what you can say about the NHS, and there were some people sitting up here saying, you can't criticise the NHS, you have to praise the NHS. The NHS is wonderful. That's the only line you can take. And then in a later session, a few people said, Overton windows changed. You can now criticise the NHS. My hospital colleagues criticised the NHS bitterly in a way that would have been unthinkable 2 or 3 years ago, including very left-wing colleagues who would say the NHS is finished. I think that there will be more talk of reforms. There will be endless reforms. There will be minor reforms. But I think we are heading for something much more major. And I think there really is the appetite there to consider a completely different way of delivering medical care in this country. And not just on the right wing, I think on the left as well. There's the feeling that the NHS at the moment is not fit for purpose. You're not going to change it by giving it 10% more money. Reorganising NHS England, you have to do something bigger than that.
So one pollster I know said at the last election, the feeling was that everyone thought the NHS was in an awful state, but that made it so nervous about it. They felt it was like a kind of vase where if you just touch it, the whole thing will shatter.
I can see why they're terrified to do that. But I think people are eager to hear a story about what we can replace it with that will do better.
And in your take,
I wouldn't go for, I would, my learned colleagues who know more about how to organise a health service, but I would say even the people who work within the health service are open to the idea of massive structural change.
Yeah, I mean, yes, I had a chance to read through the health bill. I was just going through Parliament in a minute, and I think from what I observed was essentially that you have basically you want to get rid of the NHS England, which we all agree about, yes, but it alongside basically major controls to foundational trust, etc., and with the whole end result being more controls seated with the Secretary of State. And I suppose the purpose of introducing the NHS England back in 2013, I believe it was to basically try to take away some of those kind of powers or responsibilities from the Secretary of State. And one question, I would have, at least I have in my mind is, how do we expect the Secretary of State to be able to deal with us? And the kind of powers afforded to the Secretary of State include things such as yes, hiring and firing particular sort of executives in particular in trust. It includes changing the objectives of ICBs, for instance, and so on and so forth. And as well as sort of the way accountability is redefined as well. And my question is, how do we expect the Secretary of State to be able to do all of that stuff whilst being able to sort of consider other responsibilities at his disposal? So my proposition would be something along the lines of, yes, get rid of the NHS England as is, but also as well try to disperse the responsibilities and decision making away from that kind of sort of superstructure that was NHS England into more into to the trust, to ICBs, etc., below the line. So, yeah.
And Caroline?
I mean, it's certainly something that was considered multiple times over during the time that I was in the Department of Health as to what do we do with NHS England? Can't we just get rid of it? Why are they blocking everything that we're trying to do? And yet we take all of the blame when things go wrong. But I think the current blueprint, the plans going through, as you've laid out, have just been left totally in limbo. But that's a product of coming into government with no plan as to what NHS reform actually really looks like, and saying you're not going to do a top-down reorganisation and then almost immediately embarking on a top-down reorganisation. So I think it's very predictable how we've got into this state. I mean, having said that, I think some of the reforms proposed are a very good thing to do. The move to foundation trusts, moving everyone onto the same basis is a well overdue reform, and will have some upsides. But and I think there will be some upsides as well, that you will end the brain drain that NHS England exerts on the Department of Health as well, where you will have two entirely parallel structures within NHS England and the Department of Health working on the same topics, but NHS England is able to pay officials more, and therefore they take all of the best stuff. People just move sideways, and then ministers at the moment are left without the best officials with which to make their decisions. So there will be some upsides, but I mean the blueprint is left in limbo, and I fail to see how it will be well executed on that basis.
Fair enough, but I mean that is very interesting. But I suppose the question I was asking is sort of where should, if you're talking about managing the NHS, who should be managing? Like is it that we need to hire more and better managers in hospitals and give powers to hospitals? Is it that we need to give power to the patients, which was in theory the idea behind Lansley, and it didn't quite work out?
Well, strangely, yes. As you say, the idea behind Lansley was some of, at least, the right ideas, but incredibly poorly executed and moved a long way from its original intent. I mean, better management at all levels. I think get rid of the regions. I've only ever had regional managers come in to make excuses when things have gone wrong. They don't have the access to the information on the ground. They're not in the hospitals enough. They're just kind of divorced. And now we've got the integrated care boards as another level. So remove some of those middle planks, whether that is regions or ICBs, but we shouldn't have both of those structures operating in parallel, passing the buck to each other in a way that doesn't really help anyone.
And Steve, I mean, you've already referred to this, but the issue, like the most fundamental division within the NHS is between good trusts and bad trusts.
Absolutely, and that means lives saved or lost, and it's crucially important to know that. When we're talking, though, about these institutions, we're here trying to be technically correct and professional and all the rest of it, yeah? And so when we have some of the necessary conversations, we have to be very careful about how it leaks out. So I want to make a comparison to the wide array of things in our lives which work very well and deliver complex products with a wide variety of choice without us having to worry about how they're produced. For example, cars, large complex supply chains. There is not a shortage of supermarkets in Wickham with an incredible array of products in them. We do not have to worry about how the supply chain works and how Tesco organizes itself. Now, when I make that comparison, I am very confident that of the 2,200 people currently watching this live stream, some of those people feel personal animosity towards you for your work at the CPS, towards me for many other things, for you for being a special advisor.
10-year anniversary, isn't it?
Yeah, but the point I'm making is not everybody's our friend. And so when we have this conversation that is dry and technocratic and about economic arguments about incentives, I think it's really important that we say to people, universal healthcare, free at the point of use, is a goal, will continue. That's what the public demand. I've seen it already today on Twitter, people saying, is this the end of free universal healthcare? Well, maybe a place to start is to remember that when we advance an argument, should NHS England be abolished? And the answer is, well, yes. But we have to connect first when we're being watched by the public with the emotion, because a lot of this political and public policy debate is not about the technocratic rational argument. It's about emotion. Will I end up going without healthcare? And the answer is, no, you won't. You will have healthcare, because every last one of us giving up our day to be here today wants you to have more and better, cheaper healthcare that allows you to have a longer, happier life. And I really am speaking to some of that proportion of those 2,200 people.
It's going up by the minute.
Yeah, who aren't on our side, and they should be.
We're going to open it up to questions for you. But one final question for me, and apologies, there's lots and lots of things we wanted to cover, but we're probably not going to be able to. But this is sort of listed on my cheat sheet as rebuilding the NHS clinical workforce. I mean, sort of notoriously, there hasn't been a workforce plan, a long-term workforce plan. During you were talking about the reliance on locums in large parts of places. There's all the tensions about hiring of foreign doctors versus training of UK doctors. I mean, what is the state of the workforce, and how can it be improved? I mean, good management obviously being a way to improve morale.
I think it's probably worth saying, you can say the good things first, that actually the NHS in some ways it's a mad place to work. I'm not saying the good thing first. It's dysfunctional, it's dreadful. But actually,
but apart from that, how did you like the play?
To some extent, it's also a joy, because the people you're working with, you're all trying to do the same thing. You all actually want to deliver good care for people. Everyone wants universal healthcare. I think the time has arrived for very serious arguments about should we deliver it in a completely different way. But nobody's suggesting that we should stop delivering it. That's absolutely what we want to deliver. So you have a workforce that actually is very well motivated, and where fundamentally you are all working to the same goal. So I think morale in some respects is still very good, because we feel we're doing something worthwhile. In terms of workforce plan, I think there are many things you can do. And I'm very aware that as doctors, we are incredibly protected in that the barrier to getting a job as a consultant is getting into medical school. And thereafter, as long as you're not psychopathic or incompetent or drunk, you will become a consultant. You've got a job.
And to be honest, in some cases.
In some cases, yes. Well, in some cases, that's how you get your merit award. I think if I were the government, I would overtrain. I would train more medical students than we need and make them compete for jobs. And that would be uncomfortable and unpleasant for doctors. But why should we be spared that? Because people in other walks of life aren't. And you would probably get a better deal for patients at the end of the day. And isn't that the main thing?
I mean, I remember talking to the leader of one of the most impressive hospital trusts in the country, saying, look, we train for the number of jobs we have in year one, and we don't actually work out that, by year 10, we'll have lost 20, 30% of those people.
And they won't take into account that maybe you saying good hospitals and bad hospitals are also good doctors and bad doctors. What percent of doctors do you want to get rid of because they're not good enough to compete for a job? The answer can't be 0%, because there just are not 0% of doctors that are no good. It's above zero. Make them work.
Emmanuel, Presumably you'd agree with quite a lot of that.
Absolutely, absolutely. I suppose what I would also add to that would also be training for specialty sort of applications to specialty kind of areas, which is sort of not really talked about a lot, and where it is that you have so many applications, very few, very low acceptance rates. And so what you have is this kind of odd situation where you have so many doctors wishing to sort of specialize in internal medicine or whatever, just lurking about being unemployed. And these people have been through many years of academic training, but just not being able to get into those kinds of specialty sort of areas is critical. Is a shame, really, and we're losing out on a lot of sort of talent. And as a result, I mean, earlier, we had also covered some of the issues relating to training people who eventually get lost to Australia, etc., and the perverse incentives that lead to hiring of people from elsewhere coming into Britain to work. And so, yeah.
And Caroline, I'll give you a choice. You can either answer that question, or you can do the rant about GP appointments that you said you wanted to get into
Maybe I'll
earlier.
stay on a safer territory and stick to what we're currently talking about.
So, someone ask a question about GP appointments.
What I would add to what's already been said, I agree on uncapping the training places, is that I think there also needs to be more of an open conversation with the Royal Colleges about what the future of roles in the NHS actually look like and what skills we are training people to have. I encountered a lot of resistance from some, but not all, of the Royal Colleges and the other regulatory bodies for roles in the NHS about not allowing new technology like AI reviewing scans that can do it much better than the human eye can.
Physician associates
as well. That a lot of these new roles, there's a lot of nervousness about them, a lot of protectionism from the existing professions about what these new roles are and what responsibilities they should have and who should have oversight and accountability over them, particularly if they are blended with new forms of technology. And so I think any future workforce plan has to build on that and think about what the new tools of the future will look like alongside some of those existing professions.
Steve, anything to add on this area?
I've forgotten what question we're answering.
It's about how the workforce and how to get a
right. Yes. Right. So one of the things I hate about being a politician is most of the people you're serving don't want your services. In a good year, a third of the people don't vote, a third vote for another candidate, and a third vote for you. So most of them didn't want you anyway. One of the great things about working in the NHS, surely, is that everybody who comes through the door would like to receive your services. They would like you to cure them, relieve their suffering, or whatever else. And presumably everybody who goes into medicine, and indeed goes in as an NHS manager, is there because they would like to be part of this amazing human process of connecting with a person who's suffering and ending that suffering so that they can be happier, healthier, and live a better life. What an incredible opportunity. So when we're talking about all these issues, I find myself seized by how we're making it so dry. How can we get things out of the way of the NHS?
You've not done much with think tanks, have you?
Do you know, the funny thing is, Rob, I have. But I suppose I'm trying to inspire us all to think differently about this. When we're talking about improving NHS management, I want us to remember, if I may, that the people we're talking about improving, they all want to be there, and they've got customers who would like to be there. What we should be challenging ourselves, as it were, the technocratic class who set up what the structures and incentives are, how has it been done so badly for so long? My favourite book, Working Class Patients and the Medical Establishment, a story about how the state was used to capture healthcare for doctors' advantage. Sorry, doctors, but it was. Brilliant book. Mutuals, in particular, enabled the ordinary working class patient to determine the terms of conditions of doctors and complaints processes and all the rest of it. And that would be a great way to change the system of incentives. Talking about having doctors compete and having getting rid of bad doctors. Well, let the patients combine in mutuals and sack them. Ben Enden's still there.
Okay. On which note, we'll open it up to questions. And there is a very eager question. Is there someone handing out the microphone? Do I hand out the microphone? Yeah. Oh, okay.
Yeah, on cue.
Cool.
Thank you. Hi, Jack Hadfield. Just sort of building on from what Caroline said about the NHS management being focused on diversity, woke stuff, marginalised communities, etc. Obviously, this is a problem that's been within sort of the state public sector overall. It's been pushed, but I think there are certainly some people who will just go along to get along with it, etc. But I think there are lots of people who are, again, in the NHS, but wider parts of society as well, that are true believers in it. And I think that it basically, if we were going to say, we need to stop focusing on all this and stop focusing on actual patient care, are these people going to simply turn over and just admit that this woke stuff is gone, or are they going to be so ideologically aligned that we're going to have to fire a lot of people? And I guess, frankly, overall, are there so many managers that are superfluous to the system anyway that we're going to have to do a lot of cuts to these sorts of roles in the bureaucratic end of the NHS?
Please don't everyone feel you have to reply to everything, because we want to get as many questions through. So if anyone does want to reply to that.
It's a fundamental point about how you carry someone who doesn't want reform. Again, it's about connection and bonding and agreeing on common territory. So you can say to somebody, I agree with you that we should be providing more better healthcare to the people who need it. Of course I do. Now let's go down to the operating theatre that's currently closed because it's too hot / too cold. And let's talk about how we'll have let's talk together about how we'll get more capital, because it is millions of pounds, so that we can have 2 theatres with the team going to and fro. I'm a bit fixated on this because it's such an easy example of what could be done with enough capital investment. Let's have a serious conversation, because there's the queue of people queued up, and connect with them on common objectives, bond together over those common objectives, then show your reasons for wanting to do it, your evidence, recognize, affect the emotional connection that's there, and so on. I'm using a framework called Embrace, which I work on with my friend Professor Paul Dolan, a behavioural scientist, which is about this problem that when people disagree, they polarize and can't connect. And the tools of behavioural science are out there. I've got a business called The Provocation People. I hope 2,000 people have now heard about it and look at the website. But we've got to learn to deal with people differently, so that when someone's, as you suggest, opposed to change, we can connect with them on their objectives and move them to something which will better meet their objectives without creating the impression that we're heading in a different direction.
Shall I quickly return on that one? It was directed to me. So, yes, I think there will inevitably be some people who are so resistant to any change in this regard that they probably will have to leave / be fired. But I don't think that's a sort of a necessary baseline part of it, that anybody who holds these beliefs has to go. I'm not in the business of a sort of thought police. The point is that it should be actively encouraged to bring and espouse those views at work and be enabled to have clinical time often, or management time, or whatever other time in whichever profession it is, to just discuss and talk about this sort of ideology. It's not a good use of resources or time. And so I mentioned very briefly in the opener about the NHS Constitution and the Handbook. The last time that this was reviewed was in sort of the peak woke era, if you like, and there is a whole load of dross written into it, which is what the NHS managers who really like this sort of stuff use as the reason for spending an enormous amount of time and resource on these sorts of things. So the challenge is more about, and it's within the power of the Secretary of State to rewrite what is in that Constitution and Handbook. So it's for the Secretary of State to set the tone and to set what the NHS values and priorities should be. And those should be making people better, about clinical outcomes, not about activity, not about ideology, about health outcomes. And that's how you would fix that without having to fire lots of people. Just change the Constitution.
You close by saying maybe we have too many managers. I think we have too few managers, and I think we have managers who aren't allowed to manage because they can't hire, fire. There's no carrots, there's no sticks. So I think we need more managers. We need managers who are allowed to do their job better. And I think if they had that, they would concentrate on things that mattered to patient outcomes, that maybe they're concentrating on other things simply because there's nothing else for them to do. So I disagree that we have too many managers.
Emmanuel, so you want to come in? We can go to the gentleman at the back has been very, very keen to.
Hello, Nick. It's Nick James. I'm glad this is being put online as well. So for the record, this question is mainly, but the other people can come in, for Caroline Elsom and Right Honourable Steve Baker. Caroline Elsom, you mentioned the inquiries, and particularly on things to do with the infected blood scandal, and of course we could talk about thalidomide and so on. How about the biggest scandal, which has been covered up by the 650 inhabitants of Westminster and others, especially the Wokerati, on the damages caused with the vaccines, the COVID vaccines? And I want this for the public record so everybody can hear about it. When is there going to be inquiry about it? It's killed far more people than thalidomide and infected blood put together. It's been in the Telegraph. This is not a conspiracy theory. And secondly, this was raised by one of the Tory MPs and he got hounded out, ignored. Steve Baker and others, are you ever going to debate this stuff in Parliament? Bearing in mind there's been inquiry into the COVID pandemic and the vaccines were raised in it. Anybody else want to contribute to answering my question? I'm not going to keep quiet about it. We live supposedly in a democracy.
I'll go first. So I won't be debating it in Parliament, no, because I'm not a member of Parliament. I lost my seat. And I don't mean to make light, but I'm not a member of Parliament. It's a serious subject, it deserves debate. I mean, things like the infected blood scandal went on throughout my time in Parliament, and now look where it is. I mean, I remember walking down a corridor behind two people I could name, a whip and somebody who'd signed the pledge, and I wouldn't like them to now have to confront what was going on there to get her over the line to try not to support an inquiry into the infected blood scandal. So the point you make deserves the most serious engagement. I do feel I take it extremely personally seriously. I led the COVID recovery group with Mark Harper. We took a positive decision in that campaign that we would not fight against the government's policy on vaccination. We took medical advice from people who were serious experts in the field, and we decided that we would support the government on vaccination. And so I and others were out. I had my vaccinations. I did stop. I didn't have my third jab, I think. But we encouraged people to have the vaccines. So for me personally, it's a big deal to hear you make that allegation, and I take it extremely seriously. But I'm delighted to be here. I now have this project to support the think tanks, but there's a limit to what I can do now.
Sorry, I think we all know what you think. I mean, there's quite a lot of other people who do want to ask questions. Caroline, do you want to?
Yeah, I mean, I worked on a vaccine damage payment scheme and looking at reforms therein. I completely understand that it's an incredibly difficult area because the system of vaccine damage payments was never built around such a widespread and very fast vaccination program like the one that we had during COVID. I agree with you that, or I agree with what I think you're trying to say is that the thresholds for the percentage disablement are totally wrong and out of date. They're built on an old industrial accidents framework and not built for the sorts of injuries that people, or the sorts of harm that some people who had the vaccine ended up getting. So it needs review. It needs looking at. Had I still been here and the election not been called, maybe we would have got to do it. But it needs reform. I agree with you.
Cool. Any further? Well, there were some further questions, but yes.
We've talked about carrots, and I think both Drew and Caroline have suggested they would like bigger sticks. Can we flesh that out slightly? You, Drew, and you said it's hard to lose your job unless you are drunk, mad, or incompetent. How much would you lower the bar? And maybe you could not name them, but call to mind someone who you think should have been sacked. And clinicians and managers.
Oh, can I name names?
I suggest don't name names, but it's easy to say we need incentives, we need to be able to get rid of people, but who do you get rid of? How low does the bar go?
Is this going to be alphabetical or chronological?
I think, did you mention that you try and give merit awards to your friends? That's not true. You try and stop them going to your enemies. That's the motivating factor. I'll dodge your question entirely. What I'll say is when I've gone to work at a bad hospital, often I will find that I have been allocated the work of not one consultant, but two consultants because they're so short-staffed. And I will have finished my work by 10:30 in the morning. And these people aren't doing much work. I also think the quality of work that they deliver isn't always that high. The amount of work they deliver isn't that high, but it goes back to poor management. And I wouldn't be looking at the beginning for extremes where you want to sack people And actually, I don't think that's what matters most. What matters most is bringing up the general standard. And you bring up the general standard by making incentives sane for managers and for doctors, for nurses, for all of the staff in hospitals. And at the moment, those incentives are not there. And when they are there, as we've heard repeatedly through the day, they're often perverse. So those are the things that need fixing. And I don't think they can be fixed by another sort of NHS reorganisation of the sort that we've had government after government for the last 50, 60, 70 years. You know, it is important whether you have NHS England or whether you don't have NHS England, but it isn't going to fix the problem that the NHS gets bigger and bigger. It doesn't get more and more productive. Outcomes are not good. You need different changes to tackle those problems.
And Emmanuel, I mean, your policy paper today deals quite a lot with this area, isn't it? Actually managing the workforce. So,
yes, I mean, I suppose when we talk about, for instance, you know, say performance-related pay as one kind of element to which we could be able to look at the career side of the equation. You know, I was hoping to just sort of, would I say, build up on something that Caroline had mentioned earlier. And I think it's very important to be careful about how that is implemented. For instance, you know, you don't want a situation where sort of intrinsic motivation is sort of taken out because people are driven by this kind of incentive to just deliver. And so the more you deliver, the more you kind of get more. You get more, which is essentially sort of where I say a bastardized perception of the good heart law, which is basically you have a situation where only the things that are measurable are sort of rewarded, and the things that are not measurable are not rewarded. So you want to be able to sort of control for those kinds of effects. But then also as well, you want to be able to observe not just individual performance, but also as well team performance, because I mean. And NHS structures are built around teams, and it's not the classic, you know, house or whatever kind of famous doctor on the TV show that comes out and just basically
house.
Yeah, exactly. You know, that it comes out and solves all the problems. You know, you have like team kind of incentive. So you have to figure out ways to which you could be able to, on one end, yes, reward teams that perform well, but also as well, I think something that Caroline's point about the constitutions, I think, is also very important, because whatever kind of stake-related kind of I call it the punishment, I suppose, or whatever kind of restrictions that could be put in place to ensure efficient or even better effective delivery of your work is cannot really be done without fundamental reforms to the way the Constitution is written, because right now everything is written in favor of just a more lenient approach towards the way staff are hired and kept on. So almost quite similar to what you'd find with the sort of civil service, broadly speaking. So in a sense, it's going to reform that the legislative element to how people are recruited, etc., and kept on the job, and that's critical towards any kind of add-on kind of stake-related kind of punishment, such as how you punish people for bad behavior, for instance.
And we haven't also talked about how you get any of this past the unions, which is
there is that too. Yeah.
Caroline, Steve, do either of you have anything to add on that front?
On this point about like sacking people, a lot of what we've been talking about here is transactional leadership, isn't it? It's how do we set up incentives and institutions so that, you know, mechanically you get the right stuff out of people, and that is very necessary, and I support the conversation being had. It absolutely has to happen. Transformational leadership is different. Transformational leadership is about humility and resolve. It's about nurturing and valuing people. Now, over the 30 years of leading in the armed forces, in business, in parliament, in government, I have sacked people summarily for misconduct, managed them and had to sack them for poor performance. I know it has to sometimes be done, but I'm absolutely convinced that the vast majority of people who are underperforming can be turned around by changing the conditions within which they work and the inspiration which they're given by transformational leaders. That there are never going to be enough transformational leaders. Caroline set out how the Secretary of State can change the culture from the top. That has to be done. But I really don't want us to. Yes, people. It should be possible to sack people, but I would love for us all to be thinking. Actually, most people who go to work want to get home at the end of the day thinking, I did a good job. I touched lives. Those lives are now better. Let it go. Good night's sleep. Start again. That's where most people are. And I don't want us to be really thinking, how can we sack more people? And I'm quite passionate about that, because until we can, and like talking about the unions will be difficult, especially they'll be difficult if they think we want to sack people for underperformance, when from a union point of view, we're maybe not treating people as well as we might. Now, I'm a classical liberal to libertarian. There's a lot of the union stuff I haven't got sympathy with, but treating people right, transformational leadership on top of a change in the way that mere transactional leadership can work, that's the kind of thing, that's the ingredient set I want to see used. Something that really values everyone.
Okay, we probably have time for one incredibly quick question and some incredibly quick answers. So let's go for the gentleman in the middle. I don't know why I said probably. There's a great big timer there. But...
There is, yes.
Thank you. It was a quick question. So, but it's for everyone on the panel, really. So often we focus on mistakes and big scandals, rightly so. But just as a sort of positive, what were the best NHS teams you came across, and why?
Great question. Let's go.
The best teams were passionate because they loved what they were doing. If you look at the cardiovascular team in Wickham, they almost to a geeky scientific extent, they absolutely love what they're doing and they know it transforms lives, and that's what makes them really terrific.
Get it right first time team. The GIRF team are fantastic, trying to make sure that the best way of doing things are implemented across the NHS. Yeah, amazing. We need more of them. Yeah, I would beef up that team hugely.
I'm the chair, but I'll give an answer anyway. Which to plug a guy called Martin Landry, comes from the same home village as I do. When the COVID vaccine broke out, he set up the recovery trial with one of his colleagues, which is estimated to have saved, I think, like at least 1 million lives worldwide. At a cost.
That was within a year of it starting, so it will have gone up massively.
Yeah, and so there's a reason. So he's now Sir Martin Landry, but he still does the Morris dancing, which I think is both very admirable things.
I could only mention Dr. Nick White, I suppose, because he's done incredible work on, on leading teams, etc. So yes, Dr. Nick White.
Great plug for you.
Great plug, yes.
And just briefly, I think the hardest job for a doctor to do is general practice. I think that is far and away the hardest one. Well, it's an easy job to do badly. It's a fiendishly, impossibly difficult one to do well day after day. I couldn't bear to do it because the thing that I really enjoy is the working in a team in a hospital with junior doctors, with the nurses, with the physios, and the day to day, you're generally working with people that you're pleased to see and that make you pleased to be there regularly.
Well, that's a really nice set of answers and a really nice question to end on. So next up is Fred de Fossard interviewing Luke Evans to find out what the Conservative plans are from the NHS. Very excited to learn them. It's been quite a while since we heard any. Please join me in thanking. Please join me in thanking Druin Birch of Serac Life Sciences, Emmanuel Egwe of the Prosperity Institute, Caroline Nelson of Onward, and Steve Baker of Fighting for a Free Future, and various other initiatives which he has plugged in the course of this event. Thank you all very much.
Don't despair. You're staying in the room.
Thank you. I will just need your microphones back. Thank you.
Where would you like me? We talked about this, I think. Yeah. No handout.
Yeah, so we just setting this up. We will be left with 2 chairs on stage, one for you, one for Fred. I think because you have
Right. Good afternoon, everybody. Good afternoon. We are back for the final session. It is lovely to see a good crowd running throughout the day. Thank you so much for joining us at Prosperity Institute. Those of you who've been here since before 10 o'clock, absolutely bravo. Those of you who've joined throughout the day, you have missed some fascinating stuff before you arrived, but it will all be on YouTube for you to chew over in the future, which is absolutely great. As I opened the conference this morning, I thought it'd be nice to reflect for a second on what we've discussed throughout the day and sort of remind people why I think this matters and why Prosperity Institute has decided to intervene in this territory. Because as I said earlier, we don't really do healthcare policy. This is quite novel for Prosperity Institute. We're the think tank to do immigration, scrapping net zero, repealing the Human Rights Act, that kind of stuff. So why are we touching on public services and healthcare? Well, for one, because I don't think you can have a prosperous country without having a healthy country. I think when we have a single payer healthcare system, whether that's a good thing or a bad thing, it seems like the views of all the people on stage today, that's a bad thing, but maybe the doctor here will disagree. But if you do have a single payer healthcare system, which soaks up so much taxpayers' money, it is an essential part of public policy to think about how that money is best spent and whether it is being spent correctly, wisely, and what are the opportunity costs of spending it in the way that we're doing, and can we find ways of giving some of that money back to the British people in the form of lower taxes and better economic growth. So, of course, it's time to think about the state of the health service. As I said, we commissioned Merlin Strategy to do a 5,000 person opinion survey over the winter, end of last year, start of this year, on public attitudes to the health service. Scarlett gave a brilliant presentation this morning on that, and please do rewatch that if you weren't here for Scarlett's polling presentation. It was really, really good. And I think the point we were trying to get across is, while historically a lot of people have thought that talking about NHS reform, talking about quite radical changes was a third rail politically, it seems that that's becoming less the case. And certainly other panelists on their sessions, like Christian Niemitz, and the panel the one just beforehand, I can't remember who said it, but he spoke about people within the NHS saying, no, the NHS is dead, which I think is fascinating. Chap in the front row right here. And it was really, really eye-opening. And I do think that conferences like this are a moment to try and put a little meat on the bones of this thinking and develop these ideas. And if the public are angry and frustrated, it is the responsibility of people who work in public life, in politics, and the business of ideas to work out what we can do to solve some of these problems. So I'm delighted to welcome to the stage our final guest speaker. We have Dr. Luke Evans, MP. Luke has been MP for Hinckley and Bosworth, first elected in 2019. He was a GP before he became a Member of Parliament. We've heard from multiple GPs and throughout the day on stage and the audience, so I'd love to hear some of his reflections from his life as a doctor and as an MP, and for him to give a bit of a sense of where the Conservative Party is on health policy today. And we'll have a bit of a conversation between the two of us on stage and with the audience. So Luke, do take it away.
Well, Fred, thank you very much for having me here. And me and Fred actually worked together when I was a PPS and you were a SPAD in Bays for Jacob Rees-Mogg. I thought we got on reasonably well, but you're obviously getting your revenge by putting me on the late slot in the afternoon before the bills. But rest assured, as an MP, one of the things you learn is that the mind cannot absorb what the buttocks cannot endure. So I'm not going to speak too long. And I do actually find, I've got to admit, it's a bit of a surprise to find myself on a stage like this, because at medical school, I never thought that I'd end up in politics. And there was a glimpse maybe of my future, because when we were asked in the first year to do a word puzzle and there was an anagram, those who spelt spine went on to be doctors. Those who spelt something else became urologists or politicians. So I think maybe there was a glimpse there. But actually, within that, one of the biggest drives for me to become an MP was two questions that used to come up in the NHS, because I was one of those people who said, why do we do it like this? And I was always told, you're too junior, so don't ask, or this is the way it's always been done. And they used to infuriate me. And that ethos is still there in the NHS, and it's very frustrating. So I wanted to make a difference. And it's a pleasure to come here for you guys to set the context, because I think it's really important that us on the right talk about healthcare, have opinions on healthcare, because all too often we abdicate that playing field because we're a bit nervous about it, because we're not sure, because the left are so ideological about it. But remember, when Labour were last in, don't forget mid-staffs. Don't forget MRSA. Don't forget modernising medical careers. Those of you who were in it, they had to apologise because of the mess they'd made up there. Don't forget PFI. And if we get a win today from a certain politician up north, he was the one who first privatised an NHS hospital. He was the one who refused an inquiry into the mid-staffs. So Labour don't have an unblemished record to be speaking on this topic, and we must hold them to account on that. But I think looking at the work you've done, and you sent it through my bedtime reading of 37 pages. I managed to get through a little bit of it, but you concentrate on three areas: the health of the nation, reform of healthcare, and improved management. So let's start with health of the nation. I need some help from you guys here, because in the last 7 days, hand on heart, how many of you ate 5 a day? Hands up. Okay, 2 or 3. What about those of you who did 150 minutes exercise, or split it into 275 rigorous pieces of exercise? Okay, a little bit more, maybe a quarter of you. What about those of you who drank less than 14 units? Now, I know the bar hasn't opened just yet, so we got one or two from there. Smokers, do we have any smokers who are going to put their hand up? So we've still got a couple there, and I won't say ask people to put their hand up if they've got a BMI over 25, but the point here is you guys are you've literally given up your day to come to a health conference to talk about health, and yet you don't even follow the advice that's already out there for most of us. That's the challenge we've got in this nation. So we have to look around the world at other places that do this better. And the likes of Japan and Korea are fantastic. And you touch on it in some of your reports about how do you springboard across different departments. And that's really important, whether it comes to education, MHCLG, sport, joining all this up so that health is much more thoroughly thought of, but also in the work environment too. So if you look at what Japan do, for example, with their school kids having nutritionists in school, so they get a better approach to their diet, to the way they deal with things. Little things like this can actually make a big impact. What about reforming healthcare? Well, my question always comes down to what a patient would think. And if you think about what a patient wants to know is either what is wrong with me or what happens next. Now, you're putting access against continuity, and that is effectively the mecca of trying to sort out healthcare, because on the one hand, we need to have those services put in place, but the other hand, people want them very, very quickly. So I do think there is a way in which we, in this current system, can actually design the system a little bit better to feature that. And how do you do that? Well, first of all what is the role of a GP? I was a GP. Can anyone define what the role of a GP is? No. They're all things to all people. And then if you widen that out a little bit further, the role of MDTs, the role of PAs. Actually, if we don't have these defined in what they're doing, how can you hold them accountable? How do people know where to go? And it's great that we're bringing access forward with things like community pharmacy. There's brilliant opportunities there. But how do we join it up so that the public understand where they should go and get it right the first time? That leads us on to I expect today we've talked about private versus NHS, and as Conservatives we're keen to have as much of a market as we can in that. But I think there is a problem that not many people talk about, which is the accountability from private to the NHS. Let me give you a prime example. Teenager waiting for acne treatment that is on a long waiting list, that goes to see their GP, pays to go and see a specialist, gets given specialist medication that needs to be looked after by a hospital doctor, comes back to the GP saying, I'm having to pay £200 a month for this medication, and the GP has to refer them back through. It wouldn't happen anywhere else. And it's a bit like having a private education and then getting the homework from for the comprehensive. You wouldn't do it. So we need to align a little bit more where this accountability lies. And of course, there are the roles of the mutuals. And finally, on improving management, there is a cultural issue here. I'm currently undergoing care for my neck. Many of you all know that. And I turned up at my appointment and I waited 1 hour and 45 minutes. I was second on the list. And every time you ask, well, sorry, I've been waiting half an hour. Yeah, that's just the way it is. That's a culture issue. Government can't make changes on that. So how do we actually go about giving that accountability back to those who work in the service? And if I pick another example, as a doctor working wanting to help out with the vaccine program, I had to see 4 different people to get signed off to go onto the front line. And my wife, who was already delivering vaccines in the local service, wanted to join me to volunteer at the hospital, was told she needed to do the 48-page piece of paper to be signed off to do so. Of course, she said, no, I can't do it. So there's a huge opportunity here from the Conservative aspect if we think about this as a small business opportunity. GPs effectively are small businesses from the primary care side. So why don't we think about them, innovate for them, give them that opportunity to run smoother? And you can do that because the biggest problem that they have is at the moment that demand way outstrips supply. But if you're bringing a workforce plan forward, what can you look at doing? Well, you could actually look at tying that with list size. So if they dovetail together, you're going to control demand, which in turn is better for the staff. And the essence of a way I believe we should deal with the NHS is if you can improve the working life of the staff, you'll improve patient outcomes. If I asked you now to book a round-the-world trip to 10 different destinations, you'd do it on your mobile phone. And I tell you tomorrow to cancel it, you'd be able to do it in half an hour. Yet as a doctor, it takes 10 minutes for the computer to log on. If you're a patient, I tried to book an appointment, I needed to cancel it. I couldn't cancel it through the app. If I rang through, I couldn't get through to anyone. So I made a formal complaint to say, please, can I cancel my appointment? And still got a letter saying you didn't turn up to your appointment. This is the craziness of the system that we work in. And from a conservative point of view, you're never going to outstrip and outpay, put more money in than the Labour Party, because they focus on the inputs, not on the outputs. And that's really important. And my thoughts are, if you can spend more time improving the service for the staff, you have happier staff. That's 1.5 million people going out to patients across the country saying working life has got better. So you can make a real difference. Now, at the moment, to sort of pull this together, Labour are obviously in charge, but the biggest thing they missed from the 10-year plan, did anyone know? What's the biggest thing they missed? A delivery chapter. And it's coming home to roost. You're seeing that with the bill that's going through at the moment. But from us as Conservatives, we have been quiet. That's not, that is done on purpose, because Stuart wants to have an evidence-based, robust, accountable policy offering. Because at the end of the day, what's the Conservatives been struggling with most since we lost the election? It's credibility. We have to be trusted. And we are effectively, as a Conservative Party, have to be thought of like your accountant, your doctor, your lawyer. You don't need to love them. You don't need to be fanatical about them, but you need to trust them implicitly that they will do the best thing for you. And that's what we're doing. So the final thing I will say is that no one ever says the problem with that politician is they listen too much. Well, here in the health team, the reason I am here today is to listen to those ideas, because great ideas come from all different aspects, and work together over the next 2 or 3 years to put together something that we're really proud of when it comes to an election.
Thank you very much, Luke. As well, we'll have to invite you back here for the detailed breakdown of when that plan is ready for further discussion.
Oh, that's Stuart. I'll have the over to him then.
But on that, so we'll go one step above the plan. What would the principles of the Conservative vision for healthcare policy for the 2030s look like then? Do you have what do you think it has to, what do you think you're aiming to achieve?
Well, so I slightly touched on it when we close from there. I think evidence-based, so you can bring people with you. You've heard a lot, as I was listening to that last session, about the funny thing about the NHS is that it's the biggest thing we love to complain about, yet we're also bonkers as a nation that we put it in our Olympic Games because we're so proud of it. You know, this is the bizarre nature that the Brits have. So we have this strange understanding about it. But at the end of the day, I think that evidence base is really important, so you can bring people with you to make that change, because the health service is very upset from going through multiple changes. So this is why Labour are quite interesting, having come in and saying we're not doing a top-down reorganisation. To do a top-down reorganisation has only further inflamed, which is why I think you heard that culture is changing, saying, hang on a second, supposedly Labour was supposed to get us. They certainly haven't, and haven't a delivery plan. And now they're turning up and changing things yet again, and we can't see the benefit of it. Actually, that's really difficult. So evidence-based, number one. Number two, outcome-based, I think is most important. That's really, really important, because you project it very well about how much it will cost. But at the end of the day, it's personal responsibility, I think. Bringing that personal responsibility for the clinician, for those managers who are in it, but of course the patient in the way in which you use the service. And that's really important.
Excellent. So we talked about top-down reorganisation. Of course, the shadow of 2012 hangs large over many Conservative politicians. Of course, that's the year where the NHS turned up in the Olympic opening ceremony, as well as Andrew Lansley's reforms. You, I assume, were a practicing doctor at that point. So 2 questions, one to you as a doctor and one to you as a Conservative. How might Conservatives escape the shadow of 2012, as it were? And what did those 2012 reforms do for you when you were practicing in the health service? How did that inform your political views? Were you alarmed by what was happening?
Let's take the first one first. I think Labour did a very good job, actually, of making, the Conservatives own the changes, or it would have been the coalition in that basis. And again, I think it's partly because we vacate the field on this. So hence why I brought up in my speech context matters about the MTAS, mid-staffs. These kind of things are really, really important. So I'm not sure we can ever shake it off, although where people never talk about the big changes that we made again in 2022, which were effectively the the act that came in was almost entirely put forward by the NHS itself. You never hear that. Simon Stevens, came forward and said, basically, this is what the NHS asked for, and we got almost all of it. He's on record in the Health Select Committee when I asked him that, saying that. So we don't crow about that enough. So I don't think we ever can, but also I do think it's worth pointing out, whenever Labour talk about how bad the Conservatives are, they've run Welsh Labour, the health service, for a long time. They're not sat there going, this is the blueprint that we'll move across because we did it so well. And it's the same with the SNP when they have a go as well in Scotland. So I often talk about the fact that it's a rising tide across all of us. These are all difficult areas. The second one, as a doctor back then, I guess I was still finding my feet getting involved in politics in the first place. I think you become aware of change happening around you, and you see it, but it's a feeling. I think that's the key thing. Which is where I hark back to, if you can speak towards those who are working in the service, that you're heard, they're heard, and they understand that you get it and you're trying to make a difference. That actually goes a long way to people giving you the benefit of the doubt. Prove why you want it as well, and then you doubly strengthen your argument.
Yeah, very interesting. So you mentioned the 2022 legislation giving the NHS largely what it wanted. I remember there was a moment of controversy over the so-called powers of direction, which Matt Hancock and Sajid Javid were trying to install a bit more democratic authority over the management of NHS England. This government has abolished NHS England nominally, apparently restoring democratic control over the state of the health service. What are your views on that? If you were talking about the 2022 legislation as a good thing that was giving NHS what it wanted, now the NHS has had its powers taken away. What do you think?
I got asked this question when I was on Question Time as it was announced. And I said, I don't know at the time. Dangerous for a politician to say that. And I'm almost more confused as I've got further along. And the reason I say that is because we still don't fully understand how much the change costs. The bill is through today. The reason I'm here is because the bill's in committee at the moment.
Yeah.
And trying to actually understand the evidence base of what's going on or what you're trying to achieve is really difficult. I see the power of giving more control to the state, to the Secretary of State. I think that is important. But the worry is, and the reason Lansley put in his changes was to try and depoliticize some of the decision making, because I do worry something comes up in Parliament, it happens to be the hot topic of this cancer or that treatment, and it flies to the very top. How are you actually going to make the clinical decisions that are really important? And that's the kind of aspect that we in the Bill Committee are looking at the moment. For example, look at patient safety. If you're moving HCIB, the safety body, into the regulator, there's a real concern of what that could look like. So these things are really, really important to make sure we iron out, because you need to have some external response and reference that is slightly Quango-esque, I guess. But at the same time, when you need to pull a lever and make a decision, we've seen it went too far the other way. One big point I would point out, the biggest gap I thought was actually ICBs having teeth. The problem is everyone wants to play nicely with each other, but when it comes to a funding pot, the trusts go, this is mine. The council goes, this is mine. And no one had the ability to say, no, as chair, this is what you're going to do. And I've heard it all the way at different levels. The biggest thing that I think is missing through the NHS is direct lines of accountability. No one's doing often anything wrong, but actually trying to get them to do the right thing or join it up is really difficult. And that's from clinical base to who sorts out the printer when it runs out, the paper, all the way through to when you're developing a CDC, in my case, or even at the very top, how do you decide what policy you're taking forward?
It's very interesting. I think talking about funding pots is interesting on the question of depoliticization, because how can you depoliticize £200 billion a year? There has to be, there must be some kind of democratic check, right? It can't just be the Chancellor at the budget.
No, you're absolutely right. But then again, it comes down to the evidence base, because what's the first thing if you make as a Conservative, I make a statement on health, what's the first accusation from the left? You're privatising the NHS.
Yeah.
And so it's weaponized in that way. You'll never go... I don't believe you're ever going to be allowed to depoliticize it. In answer, I think you're looking in terms of ministerial response. No, you need that democratic accountability, but you should be able to, if we're going to go down the idea of having directly elected mayors look after healthcare, which is the way it looks like on ICBs.
Yeah.
Okay, so that's democratizing it. The problem is, in an area like Leicestershire, we don't have a directly elected mayor. No one's told us what's going to happen to our area in that place. So you've got deficits all the way along. So I don't have the answers. This is the part of the problem. It's coming through and it doesn't make sense to me. So it's how you then pick those pieces up and fill those holes when it comes to hopefully us being in government.
Yeah, naturally, because I think ultimately the voters will always blame the Secretary of State and the Prime Minister when something goes wrong, almost regardless of like the constitutional structure. But that point about privatization, yes, it's bogeyman. How do you fend that off? One of the big themes of the conference today is embracing greater use of the private sector. We've had some people on stage just advocating straightforward, we need to privatise the NHS, other people saying less. Our position at the Institute is more around the exposure of the health service to market forces. I don't believe that to be privatisation. How do you address this head on without being scared of the term, the phrase privatisation?
When I used to practice it, it's a while ago now, but we went through a phase of having something called choose and book. Does anyone remember choose and book? Choose and book was, Fred, you come to me as a GP and say, I've got this problem. I say, you need to be referred to have your knee sorted out. I would pull up a list of the different hospitals that are out there and say, well, look, you could go to Wolverhampton because it's only a 2-week wait. You could stay here in London, but it's a 20-week wait. Make your choice. And within that, some were private providers on the list, funded for the NHS.
Yeah.
Others were different choice. That was hugely useful because it empowered the patient. Because
It sounds
for you,
eminently sensible.
you might decide, I want to be in London, I'll wait 10 weeks because I need to be home. Other people say, for me, the access is the first most important thing. I will travel to Wolverhampton, but then it creates an incentive for those hospitals and those providers to improve and provide it. And no one, when I referred someone to a hospital and they come back and they've been treated in a private hospital, goes, do you know what? I got my treatment, but I'm really upset I was treated at a private hospital.
Yeah, quite, yeah.
It doesn't happen because at the end of the day, what we want is the outcome for the patient. And as long as that is good quality care, that should drive it, not ideology of being yes, all private or no, all state.
Okay.
That is fundamental. And if you focus it through that, I think you can bring the public with you.
Very interesting. To think about the pandemic for a second, as the thing that really does loom large over so much of, I think, Britain's predicament, particularly in the state of the public finances. How do you think the pandemic changed Britain's attitude to healthcare, health policy? It became the primary driving thing for about 2 years of public policy. Problems of the health, problems created in the pandemic are still present in the health service today, backlogs. Where do you see this from a political perspective in your relationship, in how you interact with voters, the public, their expectations of the state, or even their disillusionment?
So the first answer might surprise you. I think for the staff, despite the incredible challenges and Herculean effort they put in, the biggest thing that happened was systems were changed overnight. No government basis, no ability to say, well, you know, we need to get this signed off and go through a panel. The clinicians and the managers were able to say, we need to sort this flow out and we need to get it sorted now. Necessity dictated that change. Out of the pandemic, it's fallen back and you've lost that innovation.
Okay.
And so for me, there's always been a question of why could we do it when there was pressure on, and now when there's a different kind of pressure, why can't we enable that? So that's number one. Number two, for the public, I think you're getting at, and this is across government, the pandemic meant that everyone always now says, what is the government going to do for me? What is the school going to do for me? What is the NHS going to do for me? What are you going to do to help yourself? We just started off with that, the health of a nation. You know, there's quite a lot of people in here who could make quite a few changes that will probably have a huge impact to their life simply by following the advice. So why do we choose not to? So I think there is an element of pushing back to the public, saying, how can I help you both as a politician and as a clinician take control of your life? What can we do? We need to be there to give you that access, that ability, but take responsibility along the way. And I think that's a very sort of conservative way of saying helping compassion, but also responsibility that goes with it.
That's very interesting. Referring to the innovations that happened in the pandemic, I think that's definitely true from my limited experience as an observer. One of the themes that came through today is that some of the greatest pockets of innovation in the health service come in GPs, largely because they are private businesses and don't have to go through the same tedious, arduous procurement processes. How can innovative GPs and actors like that be encouraged to thrive, encouraged to take on more responsibility, encouraged to lead the way?
So I think two parts to this. One is, I think the partnership model is very good at doing this. So the way GPs are set up, the problem is, do doctors want to step in to take on that big liability. So bizarrely, GPs are, well, about 70% of them are what's called GMS practices, so they can't set up as LLPs. It's an interesting concept. Why wouldn't you limit some of their exposure on that basis? So that allows them to then take on more risk. Number two is time. I often think that the time to innovate is really, really important. And number three is the ability to foster those relationships. PCNs have been really good for GPs to be able to work collaboratively. So for those of you who don't know, this is 4 or 5 practices getting together to deliver a care in a certain area. You can get to an economies of scale to be able to do so. So what does the government need to do? Well, actually, as a Conservative government, we need to recognise that they are small businesses. Hell, we're saying we are the party for small businesses. Well, why can't we incentivise for them to invest more? Or take pharmacies, bring in more robots to help with your efficiencies, these kind of things. I just don't think the mindset has ever been there from the Conservatives to look at it from that perspective. Because a lot of people go, well, let's get rid of the partnership model. And Wes has stated that in 2023, you want to get rid of it. He's backtracked. At one stage, I think Jeremy was toying with the idea, but everyone concludes at the end of the day, because they have skin in the game, they are the ones who are making the decisions. It's their bottom line that's affected. There are a lot of problems from GPs because of that. But at the end of the day, I think that gives that accountability because they have that direct accountability to who they employ, how they do it, how they look after their patients.
Indeed. I mean, incentives has been one of the running themes of the entire day. And as Steve Baker said on the last panel, you cannot avoid prices, profit and loss. It's essentially gravity. They exist whether someone's technically profit-making or surplus-making, as Syed Kamal mentioned earlier, or non-profit, prices, profit and loss are unavoidable. So therefore, they do set incentives. So when the Conservatives were last in office, and I appreciate for that time, most of that time you were a backbencher, PPS, and I don't think you worked in the Home Office. The Conservatives' biggest promise broken was on immigration, and promises to cut immigration led to about 5 million people coming to Britain on long-term visas. And the health and care visa was one of the largest contributors to that. Well, I'm sure you'll have seen the stats that there were more dependents of workers than workers on the health and care visa. And many of the people on the care visa, of course, health and care visa, did come normally to work in care homes. That's slightly separate to the topic of the conversation today. Although it's worth noting that lots of the care homes they came to work for didn't actually exist. The levels of fraud were extraordinary. But this has led to the very difficult conversation about how the health service is allegedly now totally dependent on foreign workers. And this came up quite a lot in the opinion polling we did with Merlin Strategy. One, the public, according to our poll, by quite a large margin now think immigration is a net burden on the health service rather than a boon. There was a lot of very interesting findings around the British public believing that the quality of care provided by people trained overseas is lower than British workers. And then there's a great concern about the NHS losing British staff to places like Australia, particularly Australia because of understandable reasons, cultural similarities, whatever. How do we wean the NHS off its supposed dependence on foreign workers? I remember this was even a policy when Jeremy Hunt was Health Secretary. Said it was very bad that health service recruits from red list countries, but nothing ever happened. It continued to recruit from red list countries and it continues to do so today. What's the plan to change this, and how do we sort of atone for the real cratering public trust? Because this is one of the clearest areas where voters in the country, particularly the right of centre persuasion, although as we know controlling immigration is popular across the whole spectrum in Britain, think their votes are increasingly being wasted.
A lot to unpack.
Yes,
we've got bits, but perception and reality, I think, is really important because there is a perception around that. I'd be always interested to say, well, what is the quality of care that's being delivered? We shouldn't be moving standards on any of that basis. So there is a concern from, for example, foreign doctors tend to fail their exams more. I think you shouldn't make exams easier to allow more people to come in on that basis. That's a standard place we should start. You're right about all the fraud and things like that. I think what I'm more keen to see is how we incentivize people to fill those gaps.
Yeah.
So the classic one in medicine, or has been for the last few years, is to say, well, look, let's give you 20 grand to go and spend 2 years working as a doctor in the center of a city, for example. But actually, when you break that down to make you move your entire life, your family, to go in there for £20,000 that then is taxed all the way through, actually doesn't seem a decent incentive to do so and take on the workload. What you can do is turn it around into an educational opportunity. If you turn around to you say, I'm going to extend your training, but give you, the chance to learn about obs and gynae, do a day a week in obs gynae, dermatology. What are most junior doctors doing at that time? Well, they're in their 20s and 30s, they're getting married, they're having kids, they're putting them into school. They'll fill in those places on that basis. So that's the one side. The other thing you want to have is we surely want to be a center of excellence. So you want to drive people to come here to learn, to export, to go elsewhere, which I think is really important, often lost in that. We hold ourselves in high esteem about our medical training. We shouldn't be shy about that. And then there is that difficult conversation, which I do agree immigration is too high, but at what point do you then lose the quality of your services because you don't have enough people? And I'm not sure the public have thought that one through, because at the end of the day, if you've got prostate cancer, you want to have your prostate cancer sorted by someone who's qualified. Doesn't matter what country they come through, as long as they've got the outcomes on that basis. So these are difficult things to see. And the changes that the last government put in, that we're now seeing with 85% drop in migration, is great news on the headline, but we don't know what this looks like for our social care and our medical side. But on the social care, I think there's also another side of saying, well, how do we professionalize it a little bit more, join it up together and give progression so that you can encourage younger people to come through on a qualification that could get them some degree of moving up. So we're looking at, as the Conservatives, is how can we actually provide an opportunity for that basis to transition through care, be it into nursing or something else, or go into even running care homes, which is very important. And that's actually, it's Care Home Open Week this week at a care home. Two of the managers I met there on over £100,000 started as care workers and have gone through the business. We don't hear those success stories to think that you can make it on that basis. So we've got to, that helps the domestic side on that basis.
Oh, that's interesting. I think back to the migration points, I think that the issue here is, I think, twofold. One, there is still this big democratic legitimacy issue. And two, I feel that there is a fundamental unsustainable nature of basically the NHS and the way in which the Treasury does its 5-year cycles, because we all know that government departments throw up basically a war of lobbying to ministers saying you need an exemption to this visa policy, otherwise X industry is going to fall apart. And that's never tested. In my experience, X industry doesn't really fall apart, but ministers always just get blindsided, lose their nerve, pull the lever and say, okay, you have the exemption. And then before you know it, 20,000 people a month are coming on the health and care visa with no idea where they're going. Then the Nursing and Midwifery Council discovered that there was a totally fraudulent ring of schools in Nigeria producing fake qualifications, which were then allowing people to get visas to come and work in the NHS. So while I appreciate your point about the public wanting to be treated and saying they don't know what would happen if we don't have a supply of people from overseas, but we've had a large supply of people from overseas and it hasn't got better. Surely this is time to really pull together with your thinking of the Conservative Party about a reassessment of value for money, particularly of immigration when it comes to health workers from overseas, and also a proper strategy for training more British doctors and nurses, because we know how low the cap is for medical places for university students.
Well, absolutely. And so this is where the workforce plan comes into place that was brought through by Jeremy Hunt as being looked at again, because Treasury is going to have a very hard time, whoever's in government, to say this is what a workforce is needed. You need X number of oncologists, X number of GPs. I think there's a way of dovetailing that, as I suggested. If you're looking at, if we know that we need X number of GPs, but you're looking at limiting list size, for example, we know that if for continuity of care, if you get down to about 1,800 patients per GP, your continuity, your outcomes are much better. So there's a way of saying, well, if we're looking at the workforce plan and we need X number of GPs, dovetail it with a list size that starts at 2,500. As you get more GPs, tail it down so that you're actually filling the gaps that you need to go with it. There is a question mark to the Treasury, though, on the training cap. At the end of the day, that is how much are we as taxpayers prepared to spend extra money to have doctors come through. There isn't a dearth of people wanting to get into medical school.
Certainly not.
And so that is a legitimate question to ask, to say, well, how do we solve that? Where are we prepared to do so? And whose tax or where else do we get the funding from to do that? This is going to be the fundamental point that always comes back to.
Yeah.
All eyes are through the Treasury on that basis. But this is why we're having these discussions, hopefully 2 years out from an election, to be able to say, well, what is the answer on that basis?
Precisely, and I think it must be compared to the long-term fiscal costs of lower skill, low wage migrants, particularly in the care sector, versus the upfront costs of greater training places. So we have 4 minutes. So I'd like to get some questions to Dr. Luke. Please start with John Bullard, just here.
Thank you very much. I'd just like to make an observation. We've talked much of the day about the word health, but if you actually break it down, there's two aspects of health. One is sickness, the other is wellness. Now, 10 years ago, a Japanese wellness company opened up shop in Milton Keynes, not far from your constituency. And it was entirely word of mouth selling. And I took a franchise out on that. And it was very, very difficult to get any momentum on that franchise because the vast majority of the establishment, whether it's medical, whether it's political, whether it was pharmaceutical, were kind of saying, hey, this is all wellness, Japanese wellness stuff. It's all a bit spooky. You know, you're much better to go and see a doctor. And net, it never worked. Now, I put it to you that these, I wear them to this day, magnetic insoles. And what we ought to be doing politically is to be promoting wellness as a philosophy, thereby driving down the demand for sickness. And then we'd have the world's best sickness service if we but had the guts to do this.
Well, you're speaking my language because I get very annoyed. I cover mental health as my portfolio. I get very annoyed and have done in the last 6 years. It's very trendy to talk about mental health in politics. There's a big difference between mental well-being and mental health. Everyone has mental well-being issues. Not everyone has a mental health issue. If you're locked up, 24/7 during COVID, we're all going to suffer with our mental well-being. Not all of you end up with an eating disorder. The treatments are very, very different and need to be. And that comes to anxiety, that we're seeing the boom in anxiety. You need a different treatment set to someone who gets anxious when they're walking around in a big crowd, because that's quite normal, to actually then going around to getting very anxious just because you're stepping outside the house. They are two different things. So well-being is not talked about nearly enough of how we move on that leftward shift. And I think you're right. To come back on that, though, I think social prescribing is something the Conservative government brought in. For those of you who don't know, that's when you go to your GP and you don't need a tablet, or you're lonely because you've moved there, or your partner's died. You're seen by a social prescriber who gives you the third sector, volunteer areas, or some things that are funded to go and meet people, go to a men's shed, go out to flower arranging, go to a single mum group. That's fantastic. It sounds very complicated, and the industry took a while to get used to it, but actually it's exactly the kind of thing you need. Because at the end of the day, unfortunately, in this country, people don't believe in religion anymore. They don't know their neighbours. Their families have moved away. Who do they go to? The person they trust the most is their GP, and they turn up if they can get in. Do they need to be there? 10 to 20% of people who turn up to their GP do not need to be there. This is my point about what is a general practitioner in the modern age. Should we be looking at where we move that to be able to get people the help they need more directly, which is all the way back to your wellness point, because there'd be a space then to be dealing with your well-being, and the Japanese are very good at that.
Thank you. Thank you, Luke. I have time for one more question. Young chap just there. You, yeah, definitely. Yeah.
Thanks, that was really interesting. My name's Ollie. I'm a junior or a resident doctor in the Northeast. I've been quite outspoken against the BMA. It feels like I'm the only doctor who has.
Bravo.
But about the direction that union is taking my profession, or our profession. I don't know what your view is on the Conservative policy to ban strikes, but do you think there's anything else that we can be doing to try and face down the BMA and to represent many doctors who I speak to on the ground who don't want to just strike and strike, and who think that 16 rounds of industrial action is far too many?
Can I say fair play to you? And what can we do? People like you standing up, coming to this and saying, I'm speaking out about it is really important, because I know how tough it is. So I didn't say this is my usual plug, but all my family are medical. My wife's a GP. My youngest brother is a GP. His wife's elderly care registrar. My middle brother, he's a sports and exercise medicine doctor. His wife is a GP. My father was a GP. My mum was a nurse. So Christmas is really fun. And so there is a generational gap, but actually I think it's really important to hold firm. And I do worry about the direction of the BMA and the way in which it's become so toxic and visceral, and the pressure that is put on your colleagues and yourself included to say, no, actually, I came here to look after my patients. I think there's therefore a space for the Conservatives. I do think you need to have that stick to put that ban in place. I think that's important. The public need it. But I do think there's a crossover to say, well, how can we make your working life better and more, tolerant and what's going on? And I do worry when meritocracy is taken out of this, then what are you trying to do? Why would you work and strive to get through medical school and come top? Because at the end of the day, the person who enters medical school, what do you call the person who comes last? Doctor. They get there, they get through. And actually, that whole benefit of being able to do well was to choose where you want to be and mold the system. And I think we've moved away from that because it is very, very militant in its approach, and it doesn't do this service any good, and it doesn't do patients any good, and the perception, and it's only get tighter before it breaks. And I think they will see that first, but I worry about the consequences getting to that battle.
What a fabulous question to end on. Great work. Luke Evans, thank you very much for joining us. Thank you very much for representing the Conservative Party very well. A round of applause for Luke, please. So that brings us to the end of proceedings. It's been a really, really great and interesting day. We will follow this conference with multiple publications. The pack that Reece sent out, written by Dr. White, who really sadly couldn't be with us today, is just the start of this long-running project. If anyone in this room is interested in contributing to policy work and policy thinking, either via potential publications, roundtables, more events like this, please chat to me, Emmanuel, Reece, any PI people afterwards, because it'd be really great to hear from you. What we like to think of, what we call our theory of change at Prosperity Institute at the moment is policy, implementation, and people. We need all three of those. We need thinking about how to we need to think the ideas, we need to think up the plans to put them in place, and of course we need the people to be able to do them. So please do stick around, consume more than your 14 units of alcohol that Luke told you not to at the bar shortly. And I would like to thank all of our speakers throughout the day, but I'd especially like to thank my colleague Reece Laverty for running things so brilliantly, organising things, coming up with the topics, bringing together all the speakers. It's been absolutely fabulous working with him on this one. And Emmanuel towards the back for his brilliant performance on stage earlier, but also working very closely with Reece, getting this conference together. And as ever, Francisca, our events manager, who has put on 2 superb events this week, keeps Prosperity Institute producing what I think are the best political events in London. So thank you to everyone who attended. Thank you to everyone who took part. Let's all have a drink and enjoy a lovely summer's evening. Thank you very much.